this patient?
No. By fortune or misfortune, I have examined the patient before this case went to my dear friend, because I referred to him. Because whenever you are in difficulty, the best policy is to refer to your close friend. So I referred it to Rakesh. So I have examined the patient. Patient is probably a bus driver, so far I can remember. So he was unable, because when he came to me, his demand was like that there should not be no pain. I can take the bus driver profession. So I counseled him properly, because he visited me twice. So I gave him the option that probably if I operate, I will excise the fragment. You will lose some power over there. Obviously, you have lost some power from there because of the muscle insertion of your hamstrings. And then he told, no, I want to fix it. So I think it went to Rakesh. So already we have discussed the case. So I think Amolda or Chandan, what is your option? 2 years non-union is a big chunk of the ischial tuberosity.
It all depends on patient's demand. If he's hell-bent upon sitting comfortably because of his profession, there's no point just to ignore it. I think Excican in this case will be this is a very big chunk. So why not to fix? Only our problem is sciatic nerve and this thing approach. If you can get hold of, you can properly dissect sciatic nerve or bypass that. But I think fixation in this case is absolutely not a big issue. It's a simple operation.
The only problem was the yes, because it was 2 years old. I think probably if somebody is seeing this fracture on a very fast day or within the time of where you can fix it, probably everybody will give the opinion that you must fix it. You cannot ignore that fragment because it is a huge chunk. Only because of the delay of 2 years, because of the COVID time, and that time he has not consulted a proper surgeon who can fix it up. So I think that was the delay. So now everybody agrees that it has to be fixed.
Oh, what is the problem if we excise it? We usually sit over the ischial tuberosity. No, during sitting, we usually sit over the ischial tuberosity. If there is no ischial tuberosity in one side, probably there will be some discomfort during sitting position.
I want to.
Yeah, so his two main symptoms were, one, that he does walk, but he walks with a dragging sensation. So he can't walk with a reasonable speed also. He walks like an old man. And the second big complaint was that he cannot sit because he has to always tilt. He cannot sit on this side of it always is poking inside his buttock. So if we excise, now he will be actually sitting on the other side with again tilted because he doesn't have the cushion to sit on. So if he uses a very big cushion, then he might just manage, but on a hard surface, he won't be able to sit. So we've not done anything for one part of his complaint if we just take it out. Number two, you have two major hamstring muscles, short head of biceps and also the semimembranous and semitendinosus. All of them are attached into this fragment. So if you take out, you weaken his hamstring to such an extent that the power of walking again is not improved. So I don't think excision as such is a issue. Issue is fixation. How do we fix this? Because this injury, when I looked up in the literature, you'll be very surprised. It's only once described in an adult displaced. And this is not just a tuberosity. It's actually a whole of your lower, inferior column, the whole of lower inferior column. So this is not described, very surprisingly. It's not happened. So maybe in those countries, you see where the literature comes, they actually see this and they fix it. So we are the ones who will probably face this 2-year-old something. So I kept on looking. You will hear a lot of evidence for juveniles where there is an avulsion of the actual apophysis, the ischial apophysis. So those ones are, but those are smaller fragments. And this is happening in sport injuries. So they are well described to go and fix it because they get caught very easily. And sometimes it's just an avulsion of tendons. And now the sports injury people will tell you that even those tendons you need to go back and fix. Otherwise, they lose the power of sports. So I think we need to fix. Question was how, because there is nothing described in the literature. So we had to keep on thinking and then come to a decision as to how we fix it.
So I think if Dr. Chandan sir is going to fix it, what is your approach? How you fix it?
I think it's a definitely posterior approach and only my concern is only sciatic nerve straight way. So I'll keep the knee flexed throughout the procedure, keep a sandbag in front of your knee.
The classic Cocker-Langenback.
Langenback. And one thing I was just pondering that suppose after all efforts, it does not unite. Suppose it might happen. Will it do any harm? I don't feel that it will be a fibrous union. Our purpose will be served. So there is no point just thinking for union. It is a fibrous union. What sort of union doesn't matter. Is the fragment will be in place. Patient can sit and perform his activities. It's a non-weight bearing zone basically.
Then the question is how you fix it?
Depends on the fragment, but I think 2-3 screws are in. It should be okay. I don't.
Retrograde screws. Retrograde screws in the posterior column. Okay.
Can I proceed?
Sujitha, any opinion on this? 2 years non-union, big ischial tuberosity fragment. সিটি ওটা একই আসবে সিটিতে। সিটিতে দেখাও, সিটিও দেখা যাবে একই জিনিস।
Hello. No, actually, the pertinent question asked by if we leave it as such, what will happen? It has been elaborately discussed. In any case, I don't have much to say. Everything is discussed. I joined a little late. I have seen this. As far as the city is concerned, it's a big, as told by Rakesh, it's a big, not only ischial tuberosity fragment, and it's a big posterior inferior column as well. And all the hamstrings are attached here, but that hamstring attachment that is not going to give many problems. Only thing is the CTU problem. Basically, Rakesh is also telling that patient has got some sort of limping, but basically it's a sitting problem. If the patient can get away with the sitting, if he doesn't cushion and all these things, we could have get away of this surgery. But now coming to the fixation, I think we always now most of the time we do it in prone position. In this case, we have to do prone. We'll do KL approach, but little modification, we make it a little more medial so that our target is not hip or acetabulum, our target is ischium. So, and as it is, as presumed by Chandan as well, so we have to dissect that the most important part is the 2 years, so a lot of fibrosis around to take out, to dissect the sciatic nerve and go ahead. And accordingly, you fix, if you need, it's a big chunk, if you need to put plate, you can put plate. If you have got that exposure, or you can get away with 2 or 3 screws.
Kunalda, any opinion, Kunalda?
So,
That will cut out by the pull of the hamstring. Or else you have to keep the knee placed for long position, long time. It is not practical. You have to put on the plate, something to hold it. I did one thing in a child about 14 years old. I still remember 10 years before. I just sutured it. Just sutured because the bone is more or less cartilaginous.
That is advancing.
so you
Kunala,
got
the
it
column
fresh.
screw are very strong. Column screw, if we put the screw on the column, posterior column, these are very strong.
But hamstring is stronger. Pull of hamstring. If you allow the walk, how long can you give it a bed rest in knee place position?
And-
Hamstring is much stronger than the pull of strength of the.
And that too, that hamstring is 2 years down the line. So hamstring is fibrous that way.
So I think,
Already started hamstring.
wisdom only come from wise men, and Kunalda has really hit the nail on the head. You really got to worry about hamstring pull on this one. Whatever you do, the pull of the hamstring is going to be huge on this one.
So screw of plate is a must.
So Kunalda, Amit Tale, apnari argument ani, where will you put the plate?
Then I have to take your interview.
Or
It's
anybody. If you
extremely-
want to go with Kunalda's opinion, where would you put the plate? Anybody?
Rakesh, you don't have to cover the entire fragment by a plate. Suppose a portion of the plate proximal, but I mean the posterior column. Then you up to 2 or 3 screws at least through the plate. May not be the entire of the initial tuberosity, but till then I think it will be better fit than giving 3 screws only. Because something must be there to buttress. The hamstring is extremely
No,
strong.
Mother, problem to buttress, no problem to pull.
Pull. At least pull up. If you don't put a buttress.
Anything beyond the extra, keeping any plate presenting beyond the extra is itself a problem in city.
That's also.
Reason why we do not go beyond ischial tuberosity or we do not, while the posterior column plating or posterior plating, our landmark is that we have to stop at the ischial tuberosity. The only reason is that it will further aggravate the problem for which the patient has come to us. The surgery will end up in a painful sitting. That is something I.
Well, I am an pelvic acetabular surgeon, so I doubt whether I should venture on this subject or not. But then, as Kunal has said, plate versus screw. In a femoral neck fracture, there is also a pull of strong muscles. We give 3 cancellous screws and they do it well. So, as Orgo has said, that plate in this position will not ease the problem, perhaps will aggravate the problem. Screw is the only thing which stands a practical solution in this case. Pardon me for saying venturing into a field which I don't venture too often.
So the crux of the fracture is you put a screw, as it is being told. What you usually do, you put a screw, posterior column screw, you get the position, and then you put a secondary stabilizer plate a little high up, not high up. Not avoiding the weight bearing portion, you can put it. You can put the plate a little higher up so that it doesn't affect the weight bearing portion. But before that, you have to primary stabilization by screw, primary fixation by a long screw. You get that compression, and then you put a secondary stabilizer plate, little higher up without affecting the sitting portion.
So we plan for operation actually. So there is no such literature in elderly patients how what to fix or not to fix. But the juvenile tuberosity fracture, they have 2 proper guidelines. The distance of the non-union if more than 2 centimeters, and if there is a discomfort, you have to go for fixation. So we have planned for ORIF, GA, prone on radiolucent table, direct approach over ischial tuberosity fracture via longitudinal incision. First, we have to dissect the sciatic nerve. Throughout the procedure, knees flexed up to 70 degrees. So mobilize the fragment, freshen, reduce, check image, and then fixation with 4 screws. So this is the post-op image. So this is a custom-made screen specially made for this patient. So
Can you go back to the post-op image, please? Any comment, Kunalda? Because you are concerned about the screws and the plate.
It's very easy to comment, but when you do it practically, I don't think you can do better than this. What I think. Oh, it's very easy to go, oh, this is not perfect anatomical position. It's very easy to comment. Difficult is extremely difficult.
It was done by the master of masters.
So the problem,
I think you cannot do better than
see, the problem we were facing was the seesaw effect. So if you were reducing one side, the other side was going up. Both sides were not reducing.
bony erosion.
So we accepted that around the joint area, that is where the hamstring muscles are attached. That's where we want strong fixation. The rest probably we can ignore and leave that small amount of gap.
See, view is quite good. Getting right down view, quite anatomical alignment position. But straight AP, this is best possible, I think, one.
I think we've agreed with you that the hamstring needed to be relaxed. So this was a special brace which we had bought beforehand. So we did think about that.
How long? 3 weeks or 4 weeks?
6 weeks.
6 weeks.
Huh?
6 weeks.
This guy walked around like that for 6 weeks and he was very compliant though, this patient. So this is how you need
I
to
will have
relax
the
the
video
hamstring.
also. The patient is working. I'm showing that. So this is the 9 months post-op X-ray, December. Yeah. This is the with brace, 3 days post-op. Yeah,
He also keeps the hip extended as much as possible.
hip extended, knee flexed. And this is the video of the January 2 weeks ago.
নিচে বসছি কিনা আছে কোনো ছবি?
না, সিটিং পশ্চার নেই, না ওটা নেই। ওই ভিডিওটা আমাদের কাছে নেই।
Full extension. He's got full movement.
হ্যাঁ, ওয়াকিং ভিডিওতে
Hip and knee,
দেখা
full
যাচ্ছে।
movement.
So as per the present scenario, patient is happy with the symptom improvement. Majid score improved from 55 to 73. But has not still gone back to his old job, that is driving. He has returned to intermittent cycling now. Continues to get better, but expected to have some residual long-term discomfort.
Why is not going back to his job?
আমি বলি এটা, I think Kunal doesn't know that answer. The answer is because he lost that job. 2 years he did not work, so he was sacked. So when he went back to join, they did not give him the job back.
It's
It
not
was a private job.
nothing to do with his physical disability.
No. He can join. He's asking for a job, but nobody is giving him.
ডাইরেক্ট
Yes,
পোস্টেরিয়র।
as
It's a lower half of the cochlear line back, a bit more medial. That's it.
Another one approach can be done, a transverse approach. Can be
the
done
literature
at
says
that
3 approach
over
for
the
this.
circulation.
One is Cocker-Langenbeck, one is this slightly modified medial approach. And one is subgluteus or transverse approach.
At the oblique approach, থাকে, which is what we do for juveniles. It's more like an oblique approach on the ischial tuberosity.
So sir has already told that traumatic avulsion fracture of the ischial tuberosity in an elderly patient is only described in this paper only. Thank you.
Kunal, thank you. Next.
Thank you, Dr. Kunal Kaldipal. Our next speaker is Dr. Mrityunjoy Roy. Please come on the stage. Our next speaker is Dr. Rakesh Sarkar.
Good morning, sir. Today my topic is acetabular fracture. Sir, history: 34 years old male, obese patient. History of RTA 2020, 13 July. Here is a history of associated with head injury, chest injury, and pelvic acetabular injury. Patient initially admitted elsewhere under neurosurgeon. Head injury was treated. Head injury was treated conservatively and chest drain done. Patient was unconscious for initial few days, then shifted to another multi-specialty hospital, and he was in intensive care unit. He was admitted in our hospital after 2 weeks from the date of injury. Preoperative X-ray is AP view and Dudet view and CT scan. What will be the management classification and management conservative and operative?
I think you go back to the X-ray. Go back because CT scan is not that great pictures. So you can stick on this AP only. Yeah. Kunal da, তোমাকেই ধরবো আজকে। স্পাইনে তুমি অনেক প্রশ্ন করো মাঝে মাঝে আমাকে। ওই যে ভয়েতে স্পাইনের মিটিংয়ে ঢুকি না। এটা তো তোমাদের ডোমেনের কাছাকাছি পড়ছে। Basically, you want to fix the sacrum and also the ilium.
Ilium fracture.
স্যাক্রামে আছে কিনা তাহলে
স্যাক্রামে ফ্র্যাকচার আছে? স্যাক্রামে স্যাক্রামে দেখতে হবে। সিটি স্ক্যানটা দেখাও।
স্পাইনের বাইরে বেরোতে পারেনি।
ঠিক আছে, এটা তো দেখো এক্সরেতে তো অনেক সময় ওভারল্যাপিং বোঝা যায় না। সিটি স্ক্যানটা দেখো একবার, সিটি স্ক্যানটা দেখো।
কলামে ফ্র্যাকচার আছে।
Basically, I think this is for the juniors, those who are trying to see the CT scan of the acetabular and pelvis. Don't look at the 3D scan. Always look at the 2D scan axial. Then only in 2D axial CT scan, you will be able to judge the SI joint and the sacral fractures. That is the best picture. I think because these pictures are small, probably you won't be able to delineate. So I think we discussed the case, me and Rakesh. So I think there was no sacral fracture, Rakesh. No sacral fracture, kichu nahi.
Our main reason actually because this doesn't fall in the classical classifications of the
Acetabulum.
acetabular injuries. So Argo, do you want to put your brain into it? What sort of classification would this be?
Yes, you can see.
I have come across this, and when I was looking into the literature, this comes into the classification of extensive posterior wall.
Yeah, absolutely. You have to look for that classification, otherwise you won't get it. The eternal first, when he classified initially, he did not give this classification. It was when he kept on looking further X-rays, then he added this on, that these are extended lateral walls. So what happens is the superior wall goes all the way inside and then takes the ilium. So it's actually starting at the superior wall, posterior wall. So see, all injuries are basically your head is like the motor which goes into this inside this. And it depends on how much abduction you have so these ones don't have too much of abduction. So they go more up. So if you have, if you have more abduction, then you're going more central.
It's extended, so that first comes like here and it went
I
up.
think
Probably
Definitely, yes. That's different.
probably the hip was adducted at the time. The limb was adducted at the time, and there was posterior thrust at the knee. Because of that, if we see from the interior aspect, it is a vertical fracture. Starting from the superior dome of the acetabulum up to the ilium.
So you can.
So it
take
was
both Anando-
adducted and extended. That's
yeah,
why.
yeah. So
thrust
both
goes
Anando
up.
and here,
It doesn't
right?
Go
It
posterior.
is neutral or slightly adducted and extended hip, not flexed hip.
Extended it. That's why the thrust.
This was due to the motorcycle accident.
next.
Then we are planning for operation, preoperative investigation done. And operation done in iliofemoral approach and cochlear lingual approach. This is the video.
Video
Femoral approach, দুটো combined approach.
Iliofemoral approach, anterior superior iliac spine osteotomy is also done. The fixation is done superior fold of acetabulum on plate and periphery to the ilium at another plate, and in acetabulum anteroposterior screw is given.
Only thing is, you all know that secular fixation from periphery to center. Okay, so perhaps that top plate was fixed first, and then gradually they came down, and ultimately last was that screw.
Argo, any
That
comments?
posterior column screw was the last, I believe.
Let's ask the
I
most.
mean, to the posterior column.
Amra most inquisitive mind ke jish korbo. Argo, anything on this?
Not seen the CT properly, sir, but I would like to understand the justification of using only a screw for the posterior injury.
Okay, so this is actually not a post injury, it's a wall fragment which had come out, which is actually in together with all the ilium. So once you fix the ilium, this actually not displaced too much, but we wanted to compress at the joint also. So for one compression, I think screw is enough.
Okay, madam, basically, what I was interested in, first was the iliofemoral approach with which the things were. Ilium part. So that indirectly reduced the posterior part.
Yeah.
So you just went ahead to do a care to be doubly sure that the weight bearing
No, no care here.
But it was written as scale. Scale was written.
That is my.
Kale was written.
I think,
Huh.
so if you are, I think you are agreed, femoral, you can come out on the side, down the window, and you can actually put it from there. You don't need a separate, I agree with that, or you can even do percutaneous.
But then what was exactly done in this? Was KL formally done?
Kale done actually.
Actually, first I have done the iliofemoral
Yes,
approach.
yes, yes.
I have reduced the from periphery to center, I have reduced the anterior part. And if you can see the CT, the posterior column is not fractured totally. The posterior wall part is fractured, and which is continuous with the superior superlateral aspect of the dome of the acetabulum also. And to strengthen the anterior column, I have put the column screw from posterior to anterior on the anterior column.
No, this is
Actually,
a-
as acetabulum is involved, so weight bearing part is involved here.
Now. Involved, definitely. Show the X-ray. Now, as
No, no.
far as the
This is-
Amolda, as far as the acetabular fracture fixation is concerned, the only concerned area is superior dome. If the dome is, that is the weight bearing dome. See, the weight bearing dome is affected here. If the weight bearing dome is not affected, wherever may be the fracture, you can get away conservatively. But this fracture, you cannot get away conservatively as the weight bearing dome is affected here.
It is the key, that wing which you are seeing on the ilium, it's moved slightly up and it rotates out. So there is a rotational element to it, and there is a slight migration up, and you will see the gap. So it is actually opened up like a wedge. So even if you see, what you see the gap on the iliac crest, that bodo gap in the joint at this region. But because this is 3D, you won't appreciate this value. CT scans will tell you much better. This fragment is rotated out and it moves slightly up like this. So it has to be reduced. Joint A, we cannot accept anything more than 1 to 2 mm gap. So 2 mm if it is in a non-significant area, 1 mm if it is a significant area. So I think that superior articular surface is a significant area. So 1 mm is what we would accept.
Actually, I have reduced the fracture, whole of the fracture first. And after that, we have, I have given, so the post-operative X-ray. I have given one screw here at the iliac crest, then one plate here.
Anando, I have got one question to Anando. Operatively, why could you think of the X-ray from AIIS to straight compression rather than going down? You see that screw, which you try to pick up the anterior column from posteriorly. If you can go from anterior iliac spine straight transverse to, as we do, sort of that can give a good compression.
Here.
In out, not in out. What I'm telling is, it's very simple. You from this screw, your fracture line is like this. So from here, if you go up to
the
sciatic posterior column, that is the sciatic notch,
Achha,
that could have given better compression. That is my view.
মানে এতগুলো আপনি ইমপ্ল্যান্ট আমি জানি বলতে পারবো না মানে it is not that it's what done
The question, I think question the Amolda যেটা কোয়েশ্চেনটা জিজ্ঞেস করলো, whether this fracture can be done conservative. If that is not, right? No, another, that point I am coming, because the problem is that if you see this much of gap in the ilium, this is the message to the juniors, don't conserve, because these iliums, most of the time, some muscles go in, and these go into non-union. Even me and Rakesh has both together operated non-union ilium also.
Another point, Kunalda have rightly picked up, this patient had the SI joint injury also in this side. Not sacral fracture, SI joint injury was there. Ipsilateral side.
So there was opening in the SI joint. So I think if you see the CT scan, then only you can judge that you need the SI joints fixed, because it, yes, sir.
Sir, just retrospecting, are you Are you happy with the target that you achieved? I mean, are you happy with the purpose of KL? The compression that you wanted to achieve, or whether something could have been done differently, sir? And are you happy the amount of compression that you're getting at joint, because the gap is.
On table compression was achieved, and probably I have maintained.
I think, Argo, what you're looking for is that there is one screw which gives you a fantastic compression in these areas, and that is the LC2 corridor. This screw here.
Yes.
So that's the screw, I think. Yeah, that's probably what Sujita was saying. The LC2 corridor screw is the screw to actually fix these sort of injuries. Yeah, so that would have saved you from a whole Cocker-Langenbeck approach.
Yes.
After 2 months follow-up X-ray.
Kuralda, তোমার comment on the greater trochanteric osteotomy. কুনালদা কি ধরবো আজকে সব কোশ্চেনে, স্পাইনে প্রচুর প্রশ্ন করে আমাকে। So I think
Is there?
দাঁড়া, এটা তো ছোট ডিসকাস।
Is there a job?
Yes, yes, yes.
So now-
HO, patient had head injury also, and probably for that reason, and we have done the surgery after 3 weeks from the date of injury.
কোনটা? জিটি ফিক্স হয়েছে তো?
Myositis.
যেটা দেখছি সেটা এইচও জিটিটা ফিক্স আছে, নিচে দুটো স্ক্রু দিয়ে ফিক্স আছে। দ্যাট ম্যাস ইজ এইচও।
That is the poster video of on your list.
I request our panelists kindly hurry up.
Yes,
We are
so I
already-
think, I think the message from this case we have all taken, that there was a ilium fracture, there was also this is not a classic fracture which is being classified by the Latournelle elementary and the associated type. This is a different sort of group, and also whenever you see this sort of ilium fracture, always check that you are not missing something at the SI joint and the sacrum, as rightly pointed out by Kunalda. So I think Orgo, you can present your case.
Thank you, Dr. Rakesh Sarkar. Our next speaker is Dr. Arvo Saha.
What went wrong, I would take the opportunity to have and extract as much as knowledge from the esteemed panel members and my seniors. So I would like to omit my case presentation and present my failures so that we can understand much better. So what went wrong, PPT, can you please play? So these are cases which were done probably in my very initial attempts of fixation. So let us go one case. I have presented 3 cases. So can anyone comment? What is this? Can read the X-rays? Swarnendu sir, what are we seeing? What are we looking at?
No, I think you see the hip is dislocated. There is a big fragment on the posterior wall, and also there is a rotated chunk of bone on the backside. And also, I think there is a lot of comminution on the posterior column.
Okay. What are you worried about?
And also, you see, there is also the problem is that the whole weight-bearing dome is more or less comminuted.
Yes.
So
So-
this is, but classically, you see, the iliopectineal line, ilioischial line, both are intact. Both are
Yes,
intact. So
yes.
this is the injury which has blown out the posterior wall and the superior weight-bearing dome.
Okay. So this patient comes to you at 2 o'clock in the night. What are you going to do with this patient? Reduce it, leave it alone, or for the benefit of all of us, sir?
No, whenever,
There is no neurodeficit.
No duty.
No neurodeficit.
if there is no sciatic problem, there is no neurodeficit, you don't have to jump into the skeletal traction or whatever and reduce and rush into the OT. If there is any sciatic palsy, immediately you have to rush to the OT for the reduction, not for absolutely primary fixation, because you have to somehow reduce the hip to its level to relax the sciatic nerve, because that is the only urgency. If if there's a male guy, if he is not having any sciatic or neural injury, you can just put a skin sort of traction, you wait, and next you operate as with your CT scan next day.
Okay, coming ahead with the same question to Rajput sir. Sir, wouldn't it be prudent to reduce it in the ER, which is the standard protocol at the majority of institutions, or and then put on a surface traction, or are we worried that we may further worsen the injury?
No, so the dictum with these ones is that you are looking at a static X-ray. We do not know what happened at the accident. We do not know what somebody else did to him before he even is come to your place. No, onlookers and bystanders try to help a lot. So in these fractures, you give one gentle attempt in emergency. That's it. One gentle attempt and keeping a traction if possible, but don't try under GM maneuvers in emergencies. So
Okay.
don't do that. But try this one. If this is just subluxation, it will come back and you keep it reduced under the dome. That's important. So first gentle reduction, and that's it. Try to reduce it, but no more.
Okay, so coming back to Anando sir, so we have somehow tried to reduce the hip in ER. The hip got visibly reduced. These are the X-rays on the right side. So what are we worried now? What are our concerns? How to proceed from here? This was the presentation X-ray. On the right side, it was post-reduction in the ER. We took an attempt of reduction. We reduced their hip. And now what to do with it?
Now, if this is the X-ray at ER after reduction, then I will give a skeletal traction at the time. Then I will wait for planned open surgery and after doing the CT scan of the pelvis.
Okay, so it is very clear message from Anando sir that there is no role of non-operative treatment for the benefit of all of us. This fracture mandates surgery. This fracture pattern may look deceptively stable in the post-reduction films, but this is an unstable hip and this mandates surgery. So for all the juniors like us, this is a take-home message.
Only one message I want to give, Argo.
Yes,
That is, even sometimes after reduction, sciatic may be caught up. So just after that gentle, what Rakesh has told, just gently putting surface traction or skeletal traction, as Ananda told. Again, you check up that.
Yes, sir. Yes, sir. That is a dictum.
Because
Yes.
every point you have to keep an eye on it. Before reduction, post reduction. Okay, even if after reduction it goes, very rarely does so, then you have to wait in.
Yeah, yeah.
Yes.
Okay, sir. Now to Prutush, sir. Sir, what are you worried? Once you are reduced the hip, we have planned for surgery. What will be at the back of your mind that what will be you thinking? What may be the problems I may be facing? Neurovascular injury is out of picture. Sir, yes, sir, that is clear. Coming on to Rajput, sir, what are the difficulties that we anticipate what are the things that come in the back of our mind when we are dealing with a posterior dislocation with a significant wall fracture?
Yeah,
What are we preparing?
So one, you have to know by CT scans how many pieces you are going to look at. Whether
So,
you have.
This is the CT scan. Sorry, this is the CT scan. Actually, why I wanted to bring this before the CT scan is that one very clear thing that we should understand, we should look for intra-articular loose pieces. This is a very important bottom line why we are not running beyond 3D and we need to see at the axial cuts in 2D, because we need to find that whether something is inside the joint. If it is, we have to make every attempt to remove it, otherwise our operation would be a failure. So, please, sir.
So now it's an emergency.
Yes, sir. Yes. No, sir. No, sir. It does not. It does not. Many times the labral things gets into the hip joint. Many loose bodies comes out in the hip joint. So we have faced it. So that is the reason why I'm bringing up this case.
So you would
Yes.
have a eccentric, still it looks concentric.
Another point, you have to look for whether any impacted fracture
Yes.
of the posterior
Yes.
superior wall is present or not.
Do you see in the axial cut, sir? Ananda, sir?
Yeah. On the posterior, large fragment may be slightly impacted on the posterior side.
I think what Jiten sir is asking is a very, very good question. whenever you see this, whenever suppose you see a hip dislocation without a posterior wall fragment, you reduce it, then you have to check the hip stability in 30° and 70° of hip flexion under general anesthesia. If it is stable, then it is stable. But if you see this sort of fracture where there is a posterior wall fragment, nowadays there is no percentage wise. People primarily told if it is less than 10% or classically 20%, you can go on to conservative, but that percentage is not now valid. If it is unstable and it is a big chunk, and also there is an impaction over the superior dome, weight bearing dome, then you have to go for surgery. So if there is instability at 30° and 70° of hip flexor under general anesthesia, that hip has to be considered as an unstable hip. So it has to be fixed.
Now, actually, yeah, this same test is called tornado test. What you do, this sort of case, when you put in the OT, just before going into the dripping and all, we do that test. We, under CM control, we flex and then give the all sorts of, in different angles, we give some, a telescoping test sort of thing, so that we can see how much unstable it is. By that, you can really assess your scenario, because there are a lot of tough capsule is there. If the capsule is very much intact, it may appear to be a little stable. So you can judge your quantum of instability, and then you can plan your fixation, judging that.
Another one question probably Orgo was asking, that was a very good question. Then if the classic picture, you have to see the axial cuts, what you have been given. As because from the X-ray, we are expecting that there is lot of comminution or the marginal impaction at the superior dome, then your coronal cuts becomes very important.
Yes.
So because you can see this impacted fragment, which is the dislodged fragment, intra-articular fragment, that is a very important issue. Pointer ache. Bolchi. So this is the impacted fragment which has gone in, and there is you can see the posterior wall fragment, which has posterior wall part which has gone there, and this is another one fragment. So
I think this fragment, Samantha, we can't call it impacted. That is incarcerated fragment. That's called incarcerated. So if you want to look at impaction, if you're not used to looking at it, just trace this circle here and trace this circle here. This seems to be flattened out. So if you now look very carefully, this is where the impaction has happened. If you just trace this round, it's looking very round. Whereas here, that roundness is gone. It's been pushed back. So that's the impacted part. So it's been crushed behind.
There it is just marginal.
Yeah.
Right angle to the goes much more down. Here this little change.
So we have gathered from axial cuts that for the benefit of all of us, that we have got loose bodies inside, we have got impaction, and which needs correction, because that hugely affects the functional result. And with the 3D, what we happen to plan is the approach. Ananda sir, what approach would you like to do for this case? Just have a look on the CT and
extending high up. So what I can do the usual coca lung and back approach with the flip osteotomy of the crater.
okay, so once you are committing to do a flip osteotomy, seeing the superior weight bearing dome, you are committing yourself in a lateral position, because you cannot do it in a prone position. So cocker Langenbeck in lateral position with tentative flip osteotomy. Okay, so proceeding further, this was done. Comments, Nandi sir, comments please. What could have been done better? I mean, I think everything could have been done better, but let us try to analyze.
No, actually, Orgo, as there are two screws, this screw is now the position of the screws. This should be little away from this. The way we put the screws, it should be little eccentric, not straight away, because in that case, though I understand that it is in the posterior column, there is chance of violating the joint if you go in this direction, but perhaps the fracture fragment dictates you.
No, sir, no screws are intra-articular. All screws are
Okay, I understand.
Yeah.
Now, the thing is, there are only, you got two big pieces. There's not much of comminution, I believe.
Yes.
Had there been much of confusion, then we can think of spring plate or other things.
Yeah.
But you can straight away put it, and if you go by this, I think it's a good congruous reduction. That is the primary job, and a good stabilizing plate. But only thing, why you go so up? Unnecessarily, you no point in putting such a screw, such a long plate. You could have get away with a small thing, like, because that much of exposure and putting a screw there is a very tiring job. I don't know how you must have struggled to put this one. Retract a lot, and all these knobs over superior gluteal things are here. So superior gluteal vessel injury is much more in retracting. So you could get away with a smaller one rather than going so up.
Yes,
That is the only area where I criticize. Otherwise, it's fine.
Before doing this case, I was unaware of a flip. I was unaware of a HO. This is my failure. Probably if given to me, I would have produced a better X-ray probably, and I would have contoured the plate better. Self-criticizing, I would have gone with better purchase in the ischium with the screws. I would have, as I was mentioning, I would have not projected beyond the ischium. The plate is projecting beyond the ischium. The screws would have been better directed. I would have probably used a spring plate. I would have addressed the impaction better. I would have grafted. I would have contoured the plate better. So these are my pitfalls, which I have kind of tried to learn. And use a shorter plate, of course. A 6 or 7 hole plate is sufficient for a column, for a wall buttress. And one more thing which I gathered, I've seen many X-rays. Only screws for the posterior wall are not sufficient. It has to be a buttress plate which will supplement the screws. Otherwise, your fixation is weak. So going ahead with the next case. So the patient is bhalo as a patient. Misty khaiye sir. Awesome. No. But that is what, sir. Anything goes wrong in pelvis, it will go to people like you, sir. You will change the socket and send the patient back. But then probably for us, sir, then okay.
6-7 years এমনিতে কাটিয়ে দেবে তারপরে ঝামেলা
Acetabulum leads to death. Pelvis bleeds to death. So that is what. Yeah. Thank you. না একদম স্যার আমি এটা 5 বছর আজকে পেলে বোধহয় একটু বেটার এক্সরে করতে পারতাম স্যার মানে এটা 5 বছর আগে করেছিলাম so this is one more case Swarnendu sir diagnosis please
I think if you see that your
point blank sir diagnosis or shall I project the CTs I should go faster then
no you have to go fast na
yes
iliopectoral line is broken. So this is classically a low anterior column fracture.
Operate, conserve.
No, you have to operate. You
have to operate. Like Rajput sir, operate. Okay. These are the views. Age sir, 45, 46. So the ilioischial line is intact, sir. So it is just an anterior column injury.
Ilioischial line is
Intact. So this is the CT. Any views in management? Nandi sir?
No.
3D?
Actually, yeah, that is very important.
This is where a 3D comes really handy.
Yes. Now you have to operate it because you just see this fracture. Had it been, this is an anterior column fracture. Had it been a little low anterior column fracture, even to this area, you can jolly well get away with conservative.
So plan of action.
This needs surgery.
Plan, sir. How do we plan this? Approach, plates, screws only.
Approach in this case, as it is at the level of iliopectoral, I want to do iliofemoral approach, that modified Rameshan's technique.
Okay.
I can do this by only iliofemoral approach, and if required, I can go with stopper. But
sir,
as it is very high up, we can go away with and that typical same screw.
Sir, isn't it uncomfortable for a iliofemoral approach because the iliopubic eminence has been breached?
Yes.
So anything proximal to the iliopubic eminence has to be dealt with an iliofemoral, and anything distal to the iliopubic eminence probably should be dealt with some other anterior approach.
That is stopper. You can go always at stopper here. Stopper and lateral window.
This can be done with both the approaches.
Yes.
You can do with your stopper. You can do with your iliofemoral also.
Okay.
Because with your ASIS osteotomy, you can catch hold of the fracture, you can put your clamps, and you can put the your.
Put that
long
in-out screw here.
in-
You can
in-out
put that
screw.
in-out
Only
screw.
in-out screw
Yeah.
and no plate.
And if, no, you can also put the plate.
Okay.
If you follow that technique, what our master of master
Yes, yes,
Dr.
yes.
Nail has taught us,
It will
even you can bend the plate,
Yes.
Yeah, you can bend the plate and
bend
put
that,
it over
put
there.
2 screws, even with the, only with the.
Only illusional you can get away.
But if you are happy with your stopper approach, you are confident enough, you can do with the stopper also.
So what are the forces which we need to neutralize here, Rajput sir?
I'm not still very clear what we are dealing with here. Just go back a bit.
Yeah. Sir, we are dealing with a anterior column.
But you seem to have a blow here.
No, there is the anterior column is imploded, sir. That
Yeah,
is
it's
what,
imploded.
yes,
So that's why I saw a roof like.
yes,
such.
yes, yes,
So
yes.
here you can't put screws. You have to
Yes,
put a
that
plate.
is the reason why I'm harping on
This
the
is-
question.
Whenever you have comminution, where there are a couple of pieces, you can't put screws in those.
True.
It's
That
a
has to be
plastic
put a
unit.
plate. Number two, you need to look very hard at your 2D CTs, because you may have dome impaction in these ones. But these are slightly older population. These are like 40 plus people and even minor. So you need, not just this, you need to look at all types of
Yeah,
2D CTs. You might find
Coronal-
only one section where there's a dome. So it's very common. 30% of these people will have dome impactions. And if you miss that, all your good work is going.
So this is a take home message, even in the in all the cases of acetabulum injury, we should look for dome impaction because that hugely affects the impact of the surgical outcome.
Orgo, I want to give one message. Just go back to your fixation or whatever.
Fixation.
No, just fixation or an AP X-ray. Yes, no, keep that, keep this 3D also.
Okay.
Now look at this. These are the fracture as it Orgo is asking the force. Whenever you do the Colles fracture, you just reverse the force. That is the basics of orthopedics, trauma surgery. You understand the mechanism of injury and you reverse it and the fracture usually fall in and then just put plates, screw, whatever. And this is the fracture. The force is coming from the GT area, trochanter. So, and it is displacing like this. So in that case, even if you are struggling with the reduction, as even after iliofemoral with iliofemoral approach, you can just simply put a sand screw in the trochanter and pull it back. It will fall in position. So
but
that
then-
is the basics of any fracture, any trauma surgery. And
So what Nandi sir wants to highlight is that we need to counter the medial pushing force by a inside plate and we need to counter the superior going forces by a superior plate. That is what is the message probably. Am I right, Nandi sir?
no, actually, I am going with very basic message.
yeah.
You understand the
So-
mechanism of injury and reverse it.
So
This is a very
kindly
simple-
criticize, sir. Nandi sir, this has been done. Kindly criticize, please. Feel free to criticize if anybody from the dais wants to.
Yes,
podium wants.
perhaps you went in stopper with lateral window.
Yes.
That was
Stop
your-
out lateral window.
I think there is some mismatch in the superior, that greater sciatic notch area.
This was probably
Otherwise,
my first topa, sir.
Yes.
Where-
Otherwise, as far as the dome is concerned, the whole concern, as I'm telling repeatedly, all acetabular surgery, just look at your dome, superior acetabular weight bearing dome. If you can reconstruct weight bearing dome over the femoral head, your job is done. Whatever little idar-udar, that is not going to affect the function. So I think this patient will have excellent postoperative result and not go to Chandan very early. So
This patient eventually had an excellent post-operative result, but probably retrospecting what if I would have done today, I would have definitely put an infrapectineal plate, or I would have probably used a plate with an overhang medially. Well, a superior plate with an overhang medially, definitely to counter the medial force, because there's something very funny going around the sciatic notch area. We see a spike and that demands buttress because we are doing nothing to the quadrilateral plate. We have just neutralized the superior plate. And the plate contouring is very, very important. We should, off late, I am trying to use malleable templates, which are really handy. But 5 years before, I did not. A plate lagiye beriasi setai যথেষ্ট আর কি মানে
You can give additional.
Yes, sir. It is nice, sir. It is good. It is good. Yes.
এখানে যে লাইন ডোমের উপরে ওই যে যেটা anterior খোঁচাটা,
হ্যাঁ স্যার ওটা কোয়াড্রিল্যাটারাল প্লেটের খোঁচা স্যার
lateral foot এর খোঁচা,
ওই
ওটা
জন্যই
তো
বলছি কি স্যার মিডিয়ালি বাট্রেস করা দরকার ছিল ইয়েস No,
No, not early weight bearing, not early weight bearing,
minimum 6 weeks
not early
6
weight.
সপ্তাহ বেড রেস্ট পেলভিস অপারেশন হয়েছে 6 সপ্তাহ শুয়ে থাকবে না এই
As
হচ্ছে
it is a
বিষয়।
it's a biplanar injury actually, so we have to give some support from the buttress on the quadrilateral.
Yes, that is why telling, na.
Sir, So this is the third case. I shall go in quickly.
5 minutes left. Almost time.
So kindly, I mean, if you
Go
want to see
quickly.
the X-rays. Anything, Sonendu sir?
ঠিক আছে এগো না একটু সিটি স্ক্যান দেখা সবই তো মোটামুটি এবার আর 1 মিনিট আছে এক্স্যাক্টলি ওটা 11 উইল ফিনিশ
হ্যাঁ স্যার, হ্যাঁ স্যার, হ্যাঁ স্যার, ব্যাস। এটা কি করতে হবে স্যার?
because as a convener you have been allowed for 3 cases.
And due to lack of presenters also.
না, lack of presenters.
No,
sir.
no.
Gatis দিচ্ছি স্যার।
Presenters are all sitting here. With no problem.
Just quickly get going.
Okay, so this was done.
Because every case has to give some message to the audience. Yes.
So this was done. And this was the pre-op. Happy? Not happy? I am unhappy. I am unhappy. So anybody?
In that case also, I would should buttress the quadrilateral also.
Yes,
plate also.
yes, yes. So it is very prudent, and that is the only message I wanted to give. Once you are opening by an AIP, do not hesitate to go in for an infrapectineal plate. And I would definitely like one last question. I have seen Swarnendu sir using a suprapectineal plate with an overhang. What is your idea? Which is better, sir? Infrapectineal plate is better or a overhang plate is better? Do you get the feeling of buttress with the overhang plates, or you are more comfortable doing the conventional way with going a contoured infrapectineal plate? What do you
So
feel, sir?
probably you are mentioning the plate which has got the extension on the medial
Extension,
side,
yes,
like
yes.
your calcaneum plate. It
Yes,
has got
yes, yes.
two varieties. One is the
yes,
suprapectineal, was the infrapectineal.
yes, yes,
The problem is that sometimes your quadrilateral plate is completely been blown off.
yes.
You cannot do something on the medial side. So
Okay.
it just buttresses beautifully on the medial side. So that is the advantage. You don't put any screws over from there.
Okay.
The purpose of the that plate is also the similar ones. What you have put, you can put this plate both supra and infrapectineal, but that plate only buttresses on the extensively comminuted piece like quadrilateral surface. So
Okay.
that is the advantage of the plate.
Okay. Okay. No, what I was trying to say is, sir, the quadrilateral plate, when we are using an infrapectineal plate, I personally feel that we are having a stronger buttressing effect rather than only a overhang with superior screws. It is indirectly.
No. This plate is also available in the infrapectineal variety. So this is available both supra and infra.
Yes, sir, but it is for the available vendors. It is only with the supra, sir.
No, it is available both ways.
Okay, then probably that is a better option. Something should be going from here to here.
Yes,
from inside.
because the whole force is medial.
Force is
Because
medial.
if your screw trajectory is going from medial to lateral,
Yeah.
so that buttresses
Buttresses.
beautifully. Because what Sujit sir was telling, because the trochanter is the force which is hammering the hip inside.
Hmm.
So your force, you are distracted with your trochanteric screw, and then you are putting the plate on the medial side. So that is the best buttress, not on the superior side. So I think exactly
Yeah,
we are
yeah.
at 11. So concluding remark from Rakesh.
I think I was colleague convener, fantastic session, and
Thank you, sir.
I think we need to come out with our failures. Otherwise, we'll never learn. And also, discuss between ourselves. We do have a Bong Astrology group, and I think I should thank Gigi Kar for initiating that endeavor. It is a very vibrant group, and we now have people from other states also who have joined us, and even they keep on posting cases. So if any of you are doing established surgery, join that group. It's called Bong. It's a part of WBA, by the way. So join that group, and you can post your cases, learn from that. And in fact, post before you do something, and then post after doing something. Then you will see the difference. Get people's opinion. Do whatever you want to do, but get the opinions. There's no harm.
True,
So
sir.
I think I thank Samanto, Anando, and
Thank you, sir.
Sujita for helping out with this session. Thank you, Argo.
Yeah. Thank you, sir. Thank you.
I will request the other two presenters just to come on the dais to have a photograph of this session, please.
Good morning, everyone. So we are going to start on which is Vishwajit Sen Best Paper Award. So I would like to invite Dr. Pratyush Chatterjee sir and Dr. Kunal Sengupta sir to chair this session.
We are already here. So we shall let Kunal chat there. We shall start the session. I think Professor Jitendranath Pal is here. Shubhadeep Mandal here. As with all other competitive sessions, we have to make a roll call to see whether all the presenters are present. And then Ananda is there, Arnav is there, and Pradeep Kumar Ghosh, I don't know him. Pradeep Kumar Ghosh is here? Okay. So we shall straight away come to the session. Professor Pal, Jiten, please.
Good afternoon, everybody. Should I start?
Yeah, please.
Already 7 minutes late.
So, Chairman, sir, I am presenting here my work on therapeutic study on outcome of non-operative treatment in isolated tibial shaft fracture. For many centuries, the non-operative treatment was the sole method of treatment, but during last 100 years, various operative procedures developed, of which intramedullary nail is most popular and
I
widely
would request
practiced.
the audience to keep silence, please. Yes.
And it has lot of advantages. Along with that, limitations are there in the form of infection, knee stiffness, reoperations, gadget dependence, and of course, cost. Non-operative treatment is also involved with the limitations, malunion, non-union, and ankle stiffness, as described in the literature. Our hypothesis is ankle may be relatively resistant to stiffness for prolonged immobilization. Malunion may not interfere with the functions, low-cost therapy, and can be done in any setup, and it is free from the complications of operative methods. So our research question here is to estimate the therapeutic efficacy and complications of non-operative treatment of uncomplicated, isolated tibial shaft fracture and in adult. So aim is to understand the efficacy and complications in terms of its applicability in the clinical practice. The primary objective is to note the efficacy, and secondary is, of course, to note the complications that may be known or unknown. The demographic data, as it is here, is 136 patients, of which 47 is excluded because of children, and 89 is included here. The gender, size, and age is also mentioned here. Associated fibular fracture was in 65 cases. Location-wise, it is common in the distal. Orientation-wise, it is spiral. And most common involvement mechanism is road accident. So inclusion criteria is the tibial shaft fractures in isolated way and in adult, whereas exclusion criteria are associated injury, open fracture, segmental or ghostly comminuted fractures, and non-ambulatory patient. So technique involved here, on the day one of presentation, the limb is applied with the long leg above knee slabs, bivalve. And at 7 to 10 days, it is converted into cast either
or new cast is applied depending on the situation. And finally, at 4 to 6 weeks, it is converted into PTB, and the technique of PTB is demonstrated here. So first the middle segment is taken, and then it is well molded, and then the proximal segment, and finally your leg segment, a foot segment is included. And the final result is is like this. Now this case, which united in 13 weeks, has this kind of a result in the ankle and looking good shape of the leg. So by efficacy, the rate of union in this series is 98.8%, and union time involved is 13.41 weeks, failure in one case which was treated with femistar bone graft. But complications is quite high in this series. The malunion in 42% out of 89, and in the form of shortening, delayed union, angulation, stiffness of the ankle, but no stiffness of the knee joint. So even then, Jonah-Udes criteria, the results are excellent in 64, good in 17, fair in 6, and poor in 2. But when we critically analyze with the statistics, we compared the present series data with two meta-analysis, and the relative risk ratio is very low in failure. So for failure of union time, reoperation rate, and deep infection. But the malunion is very common, and it is, as it is mentioned, the relative risk is 11.5, which is quite high as compared to the Duan X et al. Meta-analysis. So this is one case demonstration. It is a short oblique fracture, or you can say frankly oblique fractures with some rotational component, united in 13 weeks, and the result is such. So another case, another bad case, where presented at 3 weeks later than the injury, and it takes time for union 16 weeks, and there is restriction of the dorsiflexion of the ankle, and that case falls into the fair group result. Coming to the discussions, 98% union rate as compared to the intermedullary nail is 95.5%. Mild malunion, this is very important, mild malunion that do occurs in frequently, but they are really mild and usually do not interfere with the functions. Ankle joint tolerates prolonged immobilization, reoperation requires only bone grafting, simple procedure, and can be switched over to any other procedure also. So the take-home message of this speech is non-operative treatment is definitely one valid option, particularly in the developing countries where there is lack of logistic support. But one should consider that this is not conservative treatment, the area to be ignored, but it should be an active, operative, supervised method so that we can get the best result. Thank you for patient hearing.
Questions from the audience, please.
Convert them from above knee to below knee. What do you do? What do you continue with?
I've already mentioned that is on the first day of presentation. It is the bivalve slabs are applied with corrections of the rotation, and then at 7 to 10 days, and sometimes the patient may come at 7 days. Then this is not needed. We do apply above knee cast in corrected position and reduction. And then at 4 to 6 weeks, we convert it into the PTB cast. That is the technique involved.
Sir, PTB, for how many days you have to keep the PTB?
Yes, that is till the union is obtained. And this period is usually in our series is mostly the average is 13.4%, 4 weeks. So this period is to be included, but in some cases, delayed union, but the union potential is there. In that cases, we can exclude the foot part of the cast, and it is working as the leg cast. That is the improvisation you need to take in some cases.
Sir, one more question. For PTB and this POP cast, the patient, whenever the patient works up, our usual experience is there is blockage of the lower part, foot part. So you have given something extra foot.
In the sole, that is the problem, because if you apply something in the foot, that will increase the height, and the patient will find difficulty in walking. So usually what we do, we use a thin chappal under the PTB cast and allowed to walk.
Thank you.
And in the normal side, what do you do, sir? You are using a thin chappal in the affected side.
Yes,
And the normal side,
the chappal side, if it is a little high, it is good. Even then, if it is not, even then it is that height is tolerated by the patient.
sir, what do you think is preferable, to do the PTB cast with a POP bandage or synthetic cast?
Yes, I usually first PTB, I usually do with the plaster of Paris cast, because I have the enough opportunity to mold it properly. But while by the strength, it is more in the fiberglass. So it can be, if you have need to change, then you can convert it. But I do follow, I do prefer the plaster of Paris cast, because it is though little weaker, but it is the molding ability is very good.
Professor Pal, I have got a question. Jiten here. Now, yes, I agree with you that with the plaster of Paris cast, the PTB, particularly for PTB, it's more suitable plaster than the synthetic cast. But I have got a question. Your title said that isolated tibial fractures.
Yes.
But in the first case, at least, it wasn't an isolated. There was a fibular fracture.
Yes, isolated means the fibular fracture is isolated tibial fracture, which is associated with the fibular fracture. What I mean that in the demographic data, you have noted that the 60% was having the tibial fracture along with the fibular fracture. So that is also considered as isolated. And the meaning is it is not involved with the other side or the femur or head injury or something else. That is different.
I think Jiten meant exclusion of any other long bone.
Yes, exactly.
Fibula, tibia, almost brother.
Yes.
Okay, last question.
Yes.
Sir, my only question is, if we are, whenever we are doing a conservative management, or else if we are putting up a cast to a patient, we always are in the habit of taking serial X-rays. So my question is, can we prevent the malunion if we do a wedge casting?
Oh, yes. In past few of the cases, I found that while they putting in the long leg cast, there is some angulation, and that can well be corrected by wedge corrections. I am cutting the circumference, 3/4 of the circumference, and then without anesthesia, I am correcting that, and I achieve very good corrections of the angulations.
Professor
But
Pal,
rotation cannot be corrected.
thank you very much. His session is over.
I must thank Jiten
Please collect.
for
comment.
being bold enough to go for a paper which I now the younger guys do not know anything about plastering. They all go for our surgery. And this Jiten has shown how we learned ourselves. We used to do plastering for long, many years. But I think the younger guys should know also how to do plastering.
Yes,
Okay. That's the great message he has given to all of us.
Thank you.
That's
Professor Pal.
Sarmiento. Thank you.
Thank you. Shubhadeep Mandal. Hello.
Shubhadeep, you can start.
Myself, Dr. Shubhadeep Mandal, is honored to present my prospective study on the assessment of sagittal parameters in high-grade spondylolisthesis and correction of these parameters by instrumentation and TLIF in Indian population. Professor Gautam Bhattacharya played the role of mentor in this study. So the aim of my study was to assess the improvement in the sagittal parameters. Among the global parameters are sagittal spinal balance, SVAD measurement, the segmental parameters in the form of thoracic kyphosis, lumbar lordosis, the relationship between pelvic index, pelvic tilt, sacral slope, measurement of L5 incidence, and assessment of the local parameters such as sleep degree, sleep angle, lumbosacral kyphosis. We also assess the functional status. For that, we selected 20 young patients with high-grade lytic and dysplastic spondylolisthesis, and after surgery, we followed them for at least 1.5 years in a mean value. The radiological assessment was done with the help of a whole spine X-rays and local X-rays. This is an example of a high-grade dysplastic listhesis which had produced an unbalanced pelvis scenario, and after surgery, we created a balanced pelvis. Not only the sagittal deformity, the coronal deformity has also been taken care of. This is another example of a high-grade dysplastic listhesis with an unbalanced pelvis, and after surgery, we offered a balanced pelvis and balanced spine. This is an example of a high-grade lytic listhesis with an unbalanced pelvis scenario, and again, after surgery, we achieved a balanced pelvis, balanced spine. This is an example of a high-grade lytic listhesis with again an unbalanced or retroverted pelvis, and after surgery, at the end of 2 years, the reduction is well maintained, and even after 4 years, not only the reduction is maintained, the radiological fusion is also evident. This is an example of a high-grade dysplastic listhesis with an unbalanced pelvis, and again, the pelvis has been in a normal balanced position after surgery. So, in sagittal balance, spinal balance measurement, 2 cases preoperatively we had positive value and 18 cases had negative value. After surgery, we had 1 case of neutral value, and all the retroverted pelvis previously came into the negative value after surgery, which is much appreciable. SVAD measurement, the mean value was -2 cm pre-op, and after surgery, it was -1 cm, come down very much. No significant change was found in the thoracic kyphosis in our study. The lumbar lordosis showed a significant change in post-op than the pre-op. The mean value of pelvic incidence in our study was 65 degrees. Now coming to pelvic tilt, it was shown to be significantly reduced in post-op. The mean pre-op value was 25 degree, post-op 19, and it helped in creation of the balanced pelvis. Again, the sacral slope seen to be significantly increased than the pre-op, and again it created the balanced pelvis. The L5 incidence was also seen to be significantly changed and came down than the pre-op. The sleep degree, which was preoperative 64% mean value, significantly changed post-op to 11%. The sleep angle has also seen to be significantly changed and helps in achieving the normal alignment of pelvis. The lumbosacral angle, which was preoperatively kyphotic, the mean value of 20 degrees, post-op the mean value was in lordosis around 4 degrees, and the correction of lumbosacral angle mean value was 23 degrees. The most important pelvic incidence lumbar lordosis mismatch was seen to be significantly improved than the pre-op, 16.5 degree pre-op and around 23 degrees post-op. And this is the most important parameter in creation of a balanced pelvis, balanced spine. The ODI score was also seen to be improved at postoperative 6 months and 1 year. We had a deviation of plan in our study population where we had bound to instrument the pelvis to increase the stiffness of our construct in a young patient, and at the end of 5 years, this is the most long-term follow-up. The reduction is well maintained and there is significant bony union or bony fusion. There were few complications, superficial wound infection in 2 cases, neurogenic bladder developed in 1 case, which gradually responded to treatment with the help of a urologist in another 1 year. Aggravated radicular pain, mostly L5 radiculopathy in 3 cases, but they responded well within few weeks with medicines. No incidents of pseudoarthrosis and implant failure till death, and radiological loss of reduction at lumbosacral junction in few cases, but mostly they are clinically not significant. Few limitations were there as it is a prospective study and the study population is relatively small and a longer follow-up is expected. These are the references. So in conclusion, the posterolateral instrumentation with interbody at L5S1 is an effective procedure in treating high-graded lytic and dysplastic listhesis in young persons. A significant reduction in the severity of listhesis can be achieved, and we can also restore the global sagittal balance by correction of the lumbosacral kyphosis and pelvic tilt. The correction on L5 incidence and sleep angle has been reflected radiologically and clinically posture of the individuals. There is functional improvement also. And though surgically demanding, the technique is safe and reproducible and the long-term outcomes are very satisfying. Thank you.
Question.
The longest follow-up is around 5 years. That boy was our early patient. And sir, already around 23-4 patients has been operated, but the follow-up criteria is at least 1.5 years. Around 20 patients had served that. So we had included only 20 patients. We are expecting to enlarge the study population and can. Sir. Data analysis, the p-value is assessing the p-value to whether to see the data are significantly changed than the pre-op or not. Measurement of p-value. Yes, sir.
But he has given the what about his cases?
This is series of cases, I think.
This is series of the cases with the analysis. Case series, prospective case series, case series.
So we were doing excellent job and our paper is also fantastic. Only one comment. In the last 2 days, Professor Dilip Sengupta has already taught us that whenever we are dealing with an informative, we should put the screws in caudal direction as far as practical.
Sir,
No. That is proximal dorsal.
Said that no.
It's a
Osteoporotic.
Osteoporotics.
In dorsal spine.
In dorsal
Dorsal.
osteoporotics. I can't do that. But
Sir,
what is your feeling?
sir, basically,
Putting the screws in caudal direction or different direction?
sir, actually there is controversy in screw direction and correction of this type of listhesis in elderly person is a different issue. So, but in younger patient, we have a good bone stock and the distribution of our screws should be according to the lumbar lordosis what we want to achieve. So that's why the direction of L4 or L3 or sometimes these screws are along the cephalad direction because we want to create or we want to distribute the force of our screw according to the lumbar lordosis what we want to achieve. So
One question. Why there was a neurogenic bladder?
yes, sir.
Listhesis bladder.
Actually, we had only one case of neurogenic bladder, and there was multiple hypotheses in postoperative development of neurogenic bladder. One is when we are reducing the L5 over S1, there is significant length gaining along the lower lumbar of spine, and possibly there is stretching of the sacral nerves. So that's why that is the most plausible cause of causing the neurogenic bladder. And there are other scenarios such as we had to put the catheter in these patients for 2 to 3 days. There are some pre-existing urinary tract infection issues. But what I think that probably the stretch at the lumbosacral junction had created this neurogenic bladder issue, but gradually that faded away. with the urodynamic medicines.
So why did you fix up to L3?
So not all cases we had fixed up to L3. Some of the cases L3 and some of the cases up to L4. That depends on the amount of force we require to do as much as correction.
Why did you try to reduce it fully?
No, sir, we didn't want to reduce it fully. The reduction maneuver starts as long as the patient is anesthetized, then on positioning, then on laminectomy and resection and then we have to identify the L5 nerve roots and we have to clear the L5 nerve roots because these L5 nerve roots are at the highest risk. And then we instrument and as much as possible, we had to reduce it, but we never tried to achieve 100% reduction.
Okay, thank you. Dr. Mandal, please come and
Find the L5 root
collect your
first.
certificate. Professor Anand Kishore Pal, please. Anando.
Pointer.
Okay. Good morning, everybody, and respected chairpersons and senior colleagues. What theme I'm going to describe, that would be the bread and butter of the orthopedic surgeons. So evolution of the novel approach for symptomatic relief of the low backache in all age group of the individuals. All of you know the low backache, if it is a chronic, there is a two component, not only the nociceptive, but also the neuropathy components. There are several limitations of the pharmacological management along with that cause maximum relief up to 3 months. That is why we try with a non-pharmacological therapy. So there is a 50 patients were selected with mechanical low back pain of 15 years to 87 years age between 20 years, it is from December 22 to see whether it can provide significant relief of pain at least 4 to 6 weeks. Patients were divided into 4 groups as per Quebec task force. As you can see here, there is low back pain only in 7 cases, which the one had acute low back pain and the pain above the knee. With 17 cases, low back pain below the knee, 14 cases, low back pain above and both the knee in 12 cases, of which 2 had acute onset, 2 had failed back syndrome even after adequate surgical decompression. We excluded those cases where there is a neurodeficit. So the cases were selected once the diagnosis is confirmed. 2 patients came in our clinic in wheelchair and 1 in the stretcher before injections, and they went back by their own feet. So it is properly counseled and confirmed the diagnosis, and before the selection of the gate is done, that has to be blocked. The documentation is done in the proper manner. So this basically it is the mixture of the cocktail, 3 ml of 2% diclocaine, 30 milligram clonidine, 20 milligram methylprednisolone, and distilled water to make the 10 ml solution to be injected in aseptic precautions in 4 to 5 bottles in divided doses. Clinical response was assessed in VASCOR before and immediately after injection, as well as the 2, 3, 4, 8 weeks, where the patient is also assessed by the OSOST Disability Index. As you can see here, the OSOST, this is a 10-year, 10 questions with 5 points each, and that has to be awarded 0 to 5, maximum marks 50. Once is multiplied by 2, it comes into the percentage. And then that is it is regarded the minimal to maximum disability, 0 to 20 minimal, 0 to 21 to 40 moderate, like this. So how to select the gates for acute low back pain? So this is the beta 1 gate. It's a 2 to 4 centimeter anterior to lateral malleolus. Beta 2 gate is just posterior to lateral malleolus. Beta 1D is a 4th web space. It is a beta 3 gate is a just posterior to medial malleolus. Beta 4 gate is interosseous space in the superior tibial joint. And there is a quadriceps gate. Sometimes it's selected whether we have suspected higher level disc prolapse. It is 4 to 6 centimeter above the patella in the quadriceps. Now, especially for the chronic low back pain in the coccydynia, another 2 gates, the PSIS gates through the dimple of Venus is selected for the injections. Now, there is an overwhelming response, as you can see here. So this is a 10 years sciatica. It is gone almost completely. The sound is not coming. And and satisfied immediately after injection, patient can sit without pain. And this is another interesting case of the low back pain with right sciatica for 1 year with recurrent exacerbation. For the last 7 days. And what is happening even just after injection, you can see here. Properly. It was almost very difficult. See, so this is another case, the failed back syndrome. As you can see here, patient was adequately decompressed out elsewhere, and it was unable to walk properly without stick. It's a significant relief of pain immediately after injection, even without stick, as you can see here.
ওই যে আগে ঝাঁকি মারতো টান মারতো সেটা এখন আর লাগছে লাগছে কোথায় ইনজেকশন দেওয়া হলো আপনার কোথায় কোথায় দেওয়া হলো পায়ে কোথায় কোথায় দেওয়া হয়েছে
Immediate relief immediately after injection. See what is happening. This is the case.
বলুন কি সমস্যা ছিল আপনার
পা ফেলতে পারতাম না। একদম যেখানে বসতাম সে উঠতে পারতাম না, কেউ না বললে পারতাম না।
তারপর সে এখন তারপর ইনজেকশন প্রথম ইনজেকশনটা কতদিন আগে দেওয়া হচ্ছে
This is two injections. Significant relief. So all the patients shows the immediate relief of pain with improvement of vascular preoperatively 9.5 to 2, which maintained up to 3 weeks, followed by mean 3.5 up to 6 weeks. One showed the anaphylactic reactions relieved immediately after intravenous decadron and the oxygen therapy. The osmotic disability index preoperatively was almost above 60, which is maintained 11 immediately after injection till 3 weeks, followed by 21.5, 6 weeks, indicated mild disability with high satisfaction after single injection, except 3 patients who required the second injection. 2 patients was it has disagreed. They are not satisfactory relief, and they are advised to take the second injections in our series. There is an overall 96% success rate persisted in 6 weeks or more. So how it works? So see, this is the inflammatory. So every pain, everywhere in the body comes to the brain by this inflammatory. If there's an inflammation, inflammatory markers, and the pain-producing substance that produces the depolarization of the nociceptors, and this action potential propagate to up to the brain. But the problem is the nociceptors, they're not pseudo-unipolar. This is basically, see, this is the pseudo-unipolar is function. So any external fixator, any factors like the PIVD that causes pain over there, whether the internal factors or the neuronal damage, which is the basis of the chronic pain, that can cause pain in this manner. So if we block the sodium channels at the nociceptor level, that can definitely gives relief to this area, to the complete blockage of the perception of pain to the brain. And there are several workers they suggested. So that the Satish Chandra Gore, this first in 1980s, he suggested that is a mechanosensitization, which shows the upregulation of the sodium channels. And there are several immunohistochemistry study which prove that. There is a Arvind Devakar, they told there's not only the mechanosensitization, but also chemosensitization, the physical factors are there, and diagnostic Gore test can be converted to the therapeutic test. So our experience in the distal sodium channel block is technically easy and effective procedure for the relief of the backache. If selected gates are blocked in appropriate location. Lignocaine, clonidine, and the low-dose steroid produce the prolonged effective pain relief, reduce the dose of the analgesic. Immediate relief of pain cause the immense satisfaction to both the patients and the treating physicians, and break the pain anxiety cycle, which encourage to make the physiotherapy. And this peripheral pain portal block with selective physiotherapy that can cause long-lasting pain relief. And pain portal block is highly effective in acute back pain that can cause permanent relief of pain through satisfactory relief is obtained in the chronic pain also. So pain portal block provides the significant pain relief, which encourages the patient to perform the specific physiotherapy. There can be considered as a novel way of symptomatic relief in mechanical low back pain. Thank you.
This is very good demonstration of a technique, but I suppose this must be your original work. And in that case, how you have selected your sample size And do you think that sample size is adequate or not? Now, number two question is what is the type 2 error? That is the power, how you demonstrate your power in this study.
Absolutely right questions you have asked. So I have actually now I have been transferred to Jalpaiguri. And now I have there are two centers in Calcutta in my private clinic, and Jalpaiguri is a government sector. So that is I have taken the 50 patients of the last 2 months. In 2 months, there are 250 cases of low back pain I have already examined, and I have asked there is a 80% power has become there is imposed to negate the beta error. What is beta error? What is alpha error? Alpha error is basically when the null hypothesis is actually this is true, but I'm deliberately negating the null hypothesis, which is the commonly done by the experienced the authors. But that is alpha error, and then beta error, whether null hypothesis is false, I'm still taking the null hypothesis. That is why, yes. In my case, that is I'm asking. So that is I have given the 80% power to select this at least 50 cases of these 250 cases. So that is why that is okay. Thank you.
Good afternoon, sir. There are two parts to my question. One is this pain cocktail which you are using. Is it the same thing which we use in arthroplasty patients? Because in my center where I did my residency from, my boss used to have that habit of putting a pain cocktail, and that is the first part. Second part of the question is, sir, how do you signify this gate pathway? I mean, do you use the dermatomal level? That is how you make it, or how do you ascertain which place you're injecting? Thank you.
As we have gone through this presentation, so there is a pseudo-unipolar nociceptors. Nociceptor pseudo-unipolar. So if we block the peripheral gate, that can block the gate. The same effect which are doing the root block, that same effect can be achieved by the peripheral gate. That is the principles of the Core. Okay, and that is also according to the physiotherapy books, as you can physiology books. So that is the your nociceptors. So that is how, if we block the peripheral gate, that can block the perception of pain to the central side. That is what. And next question is, yes, it is right. In your arthroplasty clinic, before doing the actual arthroplasty, if we give some pain relief to the patients, that can encourage the physiotherapy, that increases the muscle power before the actual surgery, which will provide the maximum benefit. This is the actual regimen. There are basically the 3 sets it can give in a grade 1, grade 2 osteoarthrosis to defer the TKR, or otherwise, if we give some TKR to be done within 1 month, you can give the single sort of injections. So for 4 to 6 weeks, there is significant pain relief, and we can have some time to develop your quadriceps.
And what will happen after food?
Certainly pathway. I wanted to know, how will you know?
Yes, I've already shown it. So if we block the peripheral gate, so that is why all the pain which goes inside the by depolarizing the action potential, that will be blocked to reach the brain. That is the gate. So the gate controls you.
What is the frequency of this injection? How many injections?
Most of the I have seen in 50 cases, only 3 patients require second injections. Again, that can be repeated. Maximally 3 injections can be repeated. If it fails, then go for the another modality of actions. So at least sometimes it is a bilateral sciatica. So in that case, if you give injection in the single leg, you can ask the patient to come on the second day for this other leg.
It's a good paper, there's no doubt. But in our days, supposing you have these low back pain are 2 types. One is the local, one is the sciatic type. So there are 2 types of pain. So in our time, I'm not very specific. We used to, if the patient is not relieved by sciatica, then we used to give epidural steroid. There was a system, and still I do it, and patient gets a relief for at least 3 to 4 months. But if it is a desiccated one, probably this will not act, because it's already a desiccated one. But how will you treat this same method in your neck pains, where you give the injections?
Neck pains. Yes, there are several other portals, sir. Bapada, see, this is that. Can I give some? Can I have some slides? Slide.
It is like the trigger points which we studied in our.
So basically theory is there are several factors, external factors, internal factors for the pain. Suppose there is a desiccated disc. Okay, so that is not only you cannot guarantee that is the only cause of pain. Okay, so even that is why even after the discectomy and the laminectomy, the pain may persist. That is why there is a failed back syndrome concept came. So there are several, yes. So that is how. So if we make the steroid, the epidural steroid, that can block over here, but the pain that the cause persists over there. So that is the main problem. That is why if we block the peripheral part, so if we take over all the effects, not only the external, the internal, that is the one, that is the beauty of this technique. Okay, and what is the second question?
Cervical.
Cervical, yes. There are several gates in the upper limb. For the there is alpha gates. For the lower limb is the beta gates. For the trunk there is the TAVI gates, T gates. There are several gates are there. Even there is some acute myocardial infarction. There are some other gates for the TAVI gates. For the neck pain, the gates are basically in the suprascapular point, infrascapular point. This is one, and the occipital point. These are three gates for the neck pain.
Thank you very much.
One question.
Yes.
I'll be happy if you share me that.
That will make the game changer. That will be ultimately become the bread and butter of all orthopedic surgeon. If you have a master.
You said the effect lasts only for 6 weeks.
No, definitely not. That's just I have already discussed. If it is acute pain, that can cause permanent relief of pain. If it is a chronic pain, because chronic pain is a multifactorial, even the psychological factors may be there. That is in that case also, it can give relief up to 6 weeks.
Thank you. Thank you. Excellent. Okay. Please.
Pardon? No. There are several cases done without MRI.
Then-
the 3 or 4 cases I have seen, there's a failed back syndrome. You have already done MRI.
Then how did you know the source of the pain? Is it?
That is why I'm telling
deferring
whatever
the
source of the
physical
pain.
acupuncture?
That is why I'm telling whatever source of the pain. I've seen the documentation. Only the radiograph and is sufficient enough, and your clinical acumen. And those who have already came with the MRI, I have taken that MRI, and I have shown it. Whatever the source of the MRI, it may be external or internal, or every factors can be taken care of. That is the beauty of this technique.
Okay.
I have a question.
না আর হবে না টাইম নেই আচ্ছা অভিজিৎ বলো
This work has been is being done by Diwakar Jain and to a certain extent by Prakash.
Absolutely.
Quite some time.
Absolutely.
Even before 2019. So it looks like a mixture between witchcraft, acupuncture.
Absolutely,
and
Dara.
very significantly, this, as you said, this might become sometime something. But the segment you're taking is so diverse.
Absolutely.
From 15 to 87, and what kind of
Yes.
lesion, if whether there
Yes.
is posterior arthropathy in the zygapophyseal joint or not, as I Anish and Gupta said, whatever you do, unless you assess that, you cannot take out the pain from the low back pain. So all of this is, I think, is in a very, very early stages that we have to know. And the take-home message should not be that let's give in some injection.
See there.
Okay. No further discussion. We are running short of time. Sorry, Anando. Please accept your certificate. Shubhadeep.
This is already there.
Anyway, very well said. New thing. Arnab Kaul, তুই পুরো গন্ডগোল করছিস। There is a fight between the two chairpersons. এর আগে এটা অন্য উদর পিন্ডি উদর ঘরে দিয়ে দিচ্ছে আর আমাকে দোষ দিচ্ছে। আচ্ছা Arnab, please.
Yeah. Good morning, my senior teachers, my colleagues. So today I'm going to talk on a very common topic, but the data we have has got immense capacity to use it in further research in future. So is the assessment of vascularity of the femoral head after post-traumatic fracture neck of femur in a variable period. What is the background thought of, because it's a very common thing, fracture neck of femur, and In our country, especially in a government setup, the majority of the patient come from very low socioeconomic status, and they are field workers. They have to squat, they have to sit cross-legged for their activity of daily living. So we, in a setup mind, we always thought that head preservation should always be tried, as we are taught from our senior teachers. So post-traumatic osteonecrosis is a major complication of fracture neck of femur due to its characteristics blood supply. It is estimated to be from 10 to 30%. So we need some idea of the femoral head vascularity depending on the age, sex, and duration from injury and type of fracture. So in our study, we have assessed histologically all the femoral heads which were sacrificed because of hemiarthroplasty. So our materials, we use a longitudinal observational study comprising of 32 patients of 55 years and above. We collected all the sacrificed femoral head after hemiarthroplasty. The female was 53%, male was 47% of our study group. So what we did that we marked the femoral head after sacrifice. The depressed area in the head where the ligamentum teres is attached, which was marked as foveal or apex area. The junctional area with the neck marked as the base area. Rest of the head was divided by two lines in 4 quadrants, that is the superior anterior, superior posterior, inferior anterior, inferior posterior. And total 6 areas denoted by dots like 1 dot, 2 dot, and so as. And after cutting each, we are small pieces and putting them into 10 into 10 separate polythene bags with 10% formal saline, and we send it to pathology department. Next day, again, the pieces were put into a sulfuric acid solution to decalcify, because unless we decalcify, you cannot assess the vascularity. And after staining with eosin hematoxin, we examined the different quadrants under a microscope for vascularity changes and tissue necrosis. The earliest microscopic sign indicative of bone ischemia are seen in the marrow space. Starting from the second day, there is loss of nuclear staining of the marrow cells and large round and ovoid spaces filled with fat appears. There was fatty necrosis started. The fatty and hematopoietic marrow becomes then ghosted and the small vessels show evidence of ischemia. And after 15 days, the osteolytic lacunae are empty and the trabecular surface is devoid of cells. At the border of the necrotic zone, there is a proliferation of capillaries accompanied by fibroblasts and foamy histiocytes, which were responsible for the breakdown of necrotic fatty material, and that dead bone is partly removed by osteoclasts and substituted by newly formed trabeculae. That is, alternatively, oval bone is laid down on the surface of the dead trabeculae. So by observing such changes, the duration and the amount of avascular necrosis has been determined. So we can see the difference from this to this, that with the duration, the amount of fatty necrosis and avascular necrosis is also increased. So then the results to analyze, the maximum number of cases were found between 55 to 70 years age group. 25 cases were displaced and 7 were undisplaced fractures or minimally displaced. Of the 32 femoral heads, 10 heads were found in the first week, 14 were in second week, 6 in third, and 2 heads were in fourth week. The time duration represent the date of injury until the date of surgery. So there is a chart showing the relationship between the fracture and the percent of necrosis of different quadrant of femoral head. And what is interesting, I want to look upon to analyze this chart very critically, because if you see that the foveal area, and foveal area in always, it is the leastly affected in avascular necrosis of the hip. Whereas the others areas with the duration, the others areas, the chances of necrosis or percentage of necrosis increases with time, but the foveal area remains more or less or little affected. So that is one data, and the time, the amount of necrosis increases with the amount of duration. That is well accepted by already. So in case of undisplaced fracture, the percentage was 7.82%, and whereas the displaced fracture is around 20%. And in cases of male, it was slightly higher up, but that is not statistically significant. And this is the whole patient's data. We have collected all the data according to the segments that were involved. So in our statistical calculation, decrease in the vascularity of all quadrant of the femoral head is comparable with increasing time. That has been already in all literature. There is strong correlation between the displacement of the fracture along with the necrotic signs. No significant difference observed between the sexes. The highest amount of avascular necrosis changes observed in 35.16% in a female patient who was operated 27 days after the injury, while the least changes was observed in 3%, and that was in a female patient who was operated just 7 days from injury. So our study shows a significant difference of vascularity changes of displaced and undisplaced femoral fractures, probably more damage to retinacular vessels and more tamponade effect of the intact capsule. And this study also shows the viability of the femoral head gradually decreases with the increasing of the duration. More the fracture duration, that is less vascularity. And we observed that in first week, 8 to 10% of necrosis happened, and viability of the femoral head around 90 to 92%. Whereas in fourth week, the necrosis is highest around 32 to 35%. So after studying the different quadrants of the femoral head, only the apex part or the foveal part survived till late, maybe due to intact blood supply through the ligamentum teres. Though we thought that in adults, it does not give any value to the femoral head. But in our study, we got that. And we have lots of study regarding the assessment of femoral head vascularity, but most of them using radiological assessment. Very few of them are having histological assessment. And the results we are getting from this study will help us to have an idea in whom we can predict the femoral head is still vascular and we can go for an MRI. So our take-home message would be, as India being a developed country and more than 50% of the population still living in the villages, so we must give it a chance to preserve the femoral head in such patient, and it will be really helpful. We have given some guidelines in choosing the right candidate. So from the above discussion, head preservation surgeries for fracture neck of femur are very justified in middle and old age active group in minimally displaced fractures within 4 weeks instead of head sacrificing surgeries. So the place of the femoral head is not in the anatomy specimen room rather than within the hip joint. So that is why we should try to preserve it. Thank you.
Questions, please.
Very well conducted study, very good study. But my question is, what is the clinical relevance? Because when the avascular necrosis is there, does it interfere with the union rate or future formation of the avascular necrosis? How this can be correlated in your study? That is my question.
Of course. Sure.
Yes, sir. Very good question. And the thing is that we are still continuing the study and we are still analyzing the data in different aspects and manoeuvres. Like up to this, we have managed to put on the behavior of the fracture pattern, displacement, duration, and the sex. But what we are extending the relationship of osteoporosis, other comorbidities of the patients like diabetes, hypertension, whether other medications they are taking, and the pattern of fracture in a detailed manner. So what we are actually trying to get is that our own data, which could be utilized as an evidence that if you do a head preserving surgery, so you have this backup data along with you, then you feel confident you have something to show. Because the area and the age we are going through in near future, you have to give evidence for everything, whatever you are doing. So I think whatever trend we are seeing also in a very young patients also, we see in our government setup patients are coming, total hip replacement or other thing has been done at a very young stage. At least we should give it a try to save the femoral head. And if we have our own data in our own population, depending on all the possible variabilities, then that will be very useful for us.
Any more questions?
Okay. We've seen dislocated hips with fractures, without fractures, lying around for 6 months, 1 year, 2 months. They don't seem to go under AVN. So pure fractures and dislocations generally do not cause AVNs as such. It's actually our attempt to fix and revascularize which causes AVNs. So
Yes.
the heads of which are not undergoing revascularization actually remain dead and thick and sclerotic. So how is your study helping in that aspect? Because unless you are revascularizing, you are just chopping them and taking them off. So unless you kept them and saw whether revascularization could be put somehow, some different type of revascularization you could attempt or protect the hip in such a way that revascularization did not cause collapse. That is what I think as a clinician we are aiming.
Yes, sir. And that is exactly, and that is our future thought also. So that if different scenarios, as you told, in a chronic dislocated hip or in a already established arthritic hip where we are sacrificing the head. So now we are extending the study that it will not be limited to fracture neck of femur. When we are doing a sacrificing the head for the surgery like a total hip or something, now we are actually taking consideration of all those cases also. So we are trying to assess and determine what are the possible variabilities that can affect the vascularity of the femoral head or associated comorbidities, injury pattern, osteoporosis level, everything possible. Now we are taking into consideration so that we can have a data, and possibly we can expand the study in merging with the radiological assessment as you suggested, like putting a contrast MRI or something, and then or detailed angiography, MRI angiography to understand the vasculature pattern in a dislocated scenario or in an arthritic scenario, that how body has changed the femoral head vascular supply.
Actually, Arnob,
Yes,
you are first sacrificing the head and then assessing its vascularity.
Yes, sir.
Well, as in your concluding remarks, you have said that in younger patients with fresh fractures, with not much displaced fractures, it is wise not to sacrifice the head. That is a known conclusion.
Yes, yes.
No, known conclusion that if the patient is young, the fracture is fresh and not much displaced, don't replace it. So what new did you achieve by this study?
So first thing is it's our own data in our own patient scenario. Second thing is that nowadays we are seeing that even after a 2 weeks old cases also people are sacrificing the femoral head. So well, like 45 or 50s within 50s, right thing. So that is what that is a message I want to give, that we have our own evidential data that at least up to 4 weeks you should try. You should try, and later on there is always a possibility to change it. And
yes, Arnav is a very good basic work which I've given to Rajiv Raman, and he has received the MA, the gold medal in the Delhi conference.
yes, sir.
Actually, the point is, as Pratyush rightly mentioned, what is the new thing to be added? Just I'm giving you, even if the revascularization can start from 2 to 3 weeks onwards.
Yes.
Is already, there are some vascular study. Trueta is already discussed that.
Yes, yes.
So in that case, if you take the longer injury, so as Dr. Rajput said, is rightly, it's very valid point, but it is very difficult that once in attempt of revascularization, then you have to take in the femoral head. But you can take the femoral head even that you are going to sacrifice.
Yes.
But you can take this study. Is there any evidence of revascularization we've seen in those cases where the 3 weeks after?
Yes, sir. Yes, sir. I have shown it.
That is one. Second, that in which quadrant it is seen? At which quadrant the revascularization starts to, that is maybe the new point which may be added. And in that case, you can recommend that even after 4 weeks, you can save the head.
Yes, sir.
Now, how does it revascularization occur in a sacrificed head?
Never know. That may be our data that in which time revascularization starts and from which quadrant revascularization starts, and what are that is much more valid interest in I think in this subject.
So yes, now we are expanding it, that we will take all the heads whenever possible from all sources. Like we are doing a total hip in arthroplasty, we'll also take that head and see the pattern. And the best point sir has told already, because at the border of the necrotic zone, here in our study, we are actually observing the necrosis part, how the necrosis is happening, because we can't observe the revascularization in a already sacrificed.
That's right.
So we are actually observing the necrotic part, and in there also we have seen that after 15 days, actually if there is a process which is already started, that the body has started to deposit newer bones at the periphery of the necrotic zone. Yes, newer woven bones.
No, last question, please.
The question is, no, there's an ethical part to this study. An undisplaced fracture leg femur, you're taking out the femoral head and studying it, where it should not be done and should be tried to be preserved.
Yes.
These are human beings.
Yes.
You do it in an animal, then it's all right. But as a human being, in a young patient or whatever patient, in an undisplaced fracture neck femur, for the purpose of study, you think this should be done?
No, sir. We have not taken any undisplaced cases. We are all the cases were planned for hemiarthroplasty, and those heads we studied.
No, but you had a younger age.
No, sir. That was a mistake. But that was minimally displaced, which were meant for hemiarthroplasty. All the cases which were put for hemiarthroplasty, we took the heads. Because after as per the standard criteria, old 55, More than 55 years, 55 years.
Old patients, old fractures.
Old
we have
fracture.
Already scheduled it for hemiarthroplasty and
Those
they are-
headed we have studied.
Okay, thank you, Arnab.
Thank you,
Please
sir.
come and collect your
Therefore,
certificate
55
and see the name, whether it is rightly written.
So therefore, 55 an undisplaced fracture is being put up for hemiarthroplasty. At the age of 55, an undisplaced fracture neck femur is being put up for hemiarthroplasty. Is it right or wrong?
No, definitely.
That is
the best you want to go. You should resolve.
Okay, Pradeep Kumar Ghosh.
My study is the outcome analysis of different types of trochanteric fracture with femoral nailing. This is a case series of trochanteric fracture is very common nowadays, but it is common in elderly patient, but also due to high velocity trauma and motorcycle accident, young individual also suffer from this type of complicated trochanteric fracture. And this type of trochanteric fracture with subtrochanteric comminution, sometimes it is difficult to manage. But our gold standard of trochanteric fracture undisplaced type 2, type 1, sometimes bird grabbing type 2A. DHS is the gold treatment still now. The technique of placement of hip screw device is familiar to most experienced orthopedic surgeon, and DHS is good option for treatment of stable trochanteric fracture. This is a case, it can be easily managed by the DHS and it is all familiar to every orthopedic surgeon. But in the study, I have managed unstable trochanteric fracture with intertrochanteric fracture using capillometry nails, which shows good functional outcome. My aim and objective of the study first is pre-operative evaluation of the fracture pattern. First, fracture pattern, you have to evaluate it first. Then you have to decide which surgical fixation you are perform in this case. And after surgical fixation, our aim is early mobilization of the patient and rehabilitation to ensure a return to baseline functional mobility and to assess the outcome on the basis of clinical and radiological parameters. Study period 1 year to or long 2 years. Sample size is 20 patients have taken. It was a prospective study. The patients were examined thoroughly with emphasis on radiological and functional status. All the cases were treated by capillometry nails. Postoperative follow-up done at 2 weeks, 6 weeks, 3 months, 6 months, and 1 year. And radiological and functional outcome were analyzed. The parameter used in this study is clinical parameter to be determined by the modified Harris hip score. All we know, a radiological parameter like neck shape angle to assess the varus and valgus angulation, posteromedial cortex and position of the lesser trochanter, and also sentence lines. This is modified hip score. All we know, total score is 100. Excellent is more than 90, good 80 to 90, fair 70, and poor is less than 70. Age distribution is, these are age distribution of this case. Sex distribution is male is 8 and female is male is 12 and female is 8.
fracture type, what happened, classification, most of the fracture are type 4 and 3 and some are type 2 fracture. These are the modified hip score. This is the case number 1, come with this type of fracture, trochanteric fracture with intertrochanteric extension. And after giving brackets, I open the fracture and just I put a SS wire to properly reduce the fracture. After reduction, reduce the fracture. And I first after putting SS wire, I given a K-wire to stable the neck. That during reaming, that it's cannot rotate during reaming. And this is the final result. Patient is now well now, but he is not able to come due to his after 1 year he is now busy in field work. He is not so clinical photograph. In this case, not present. And this is the case number 2. This is also a difficult fracture. It is more comminuted 4 to 5 fragments. It is very difficult. I just open the fracture. Also, I given SSR. I've given 4 SSR. After giving 2 SSR, I tried to reaming, but it was difficult to ream. That's why further 2 extra SSR are given. This is the result. He sent me the photo from his home. This is case number 3. It is also this type of fracture. It was also a critical fracture, and I just open the fracture and reduce it by intercapillary nailing. This patient came in my chamber after 6 months and also in. This is a case. This is female patient came after 1.5 years. This case came done outside with not fracture with outside with a short femoral nailing with failure. Came with me. I have done with long PFN and with bone grafting. It's a good good union occur after 1 year. Patient came in my chamber. This is a old case, old female patient, 73 old. This is treated conservatively but failed to unite and patient cannot walk. Done with trochanteric nailing. This is done by elderly patient also. I have done this case by PFN-A2. This is medically, medically unstable patient. Anesthetist told me to do a short PFN. I have done it. And this is a failure case done outside with the DCS, and it's failure. And it's also I've done it with interline nailing with good outcome. But PFN is a good choice for intertrochanteric, unstable trochanteric fracture, but PFN is good option if fracture is well reduced intraoperatively. Otherwise, it will failure. If reduction is not done properly, then it will lead to failure.
I have to stop you at this stage because your time has passed.
This case.
Just 2 questions from the audience.
Okay.
Just 2 questions from the audience, please.
No question.
So all your cases, you are showing this two screw system where one screw on the top is way shorter than the other one. Is there a specific reason for that, or that's just how you do it?
No. The second screw is for to prevention of the derotation.
I agree that it's way short than what you would normally do, but why, is there any reason for that?
So two screw seams.
What the general people think about this one?
My question now, so many wears you have put on. Don't you think the fragments will become avascular?
No,
3,
sir.
4 circumferential wears.
This was a long fragment.
Long
and
fragment.
Long fragment. When I reaming it, it was.
But
difficult
what the others will say
it
about
was difficult to
wearing?
reduce the fracture.
One question, last question.
Sir, you have shown that this paper is on trochanter fracture. But most of the cases you have shown that these are all
Subtrochanteric. That's a very pertinent question.
But subtroch can be included within trochanter. Okay.
All are
4 or 5 classifications.
That's that.
Trochanteric fracture also extended to the subtrochanteric region, most of the difficult case. In trochanteric fracture, that can be easily managed by the dynamic heat
I
screw.
think
But
that your paper should have that approximate femoral fracture.
Right. My question, I have not got the answer. So many wearings. What the Rakesh ball? So many wearings.
I agree with him, but they can all be done close now. You don't need to open up in such a big way. You can do close wirings. We have enough nipple wiring sets now.
No, Rakesh, they are very expensive.
We have Indian versions that quite easily have.
No. Just see the case. If done,
We have to stop
it
the
is done
discussion. We have to stop because somebody is waiting online. Somebody is waiting on. Organizers have warned me that you are going just before closing the session. Professor Dilip Majumdar will speak about our this competitive Bishwajit Sen. He will introduce about Bishwajit Sen.
So thank you, organizer. My dear friends, 4, 5 places in Calcutta, we never used to miss the classes. And one of them is Dr. Bishwajit Sen. Many of the, I can't see many of them, but I can see Tapanda, who was there, who was a student of, not direct student, but he used to take classes. I can see Abhijit Sarvadikari here. Where is Shivaji? I don't know. Tapan Sarkar was with us in 77, 78 when we used to do classes in RKM. So Dr. Bishwajit Sen, on which the paper, the competition went on, but many of the juniors, they do not know who was this man, the legendary man. Dr. Bishwajit Sen passed it MBBS from the medical college and FRCS from London. He was the second generation orthopedic surgeons in the country. He returned to India in 1965 and joined RKM in 1966. He came and organized the orthopedics department there. And the first associate with him was the Nikhil Majumdar, who is still living. And he is with us. And others like Ramendu Home Chaudhary is not here. He has got 5 innovations actually. He has got 5 innovations. Innovations in orthopedics. Sense nail, all you know about the femoral neck fracture. It was a very minimal invasive that he used to do. 15 ml blood is lost there. And he could finish by 22 minutes. So approach to odontoid fracture by intraoral approach that we have seen him. Thymectomy in rheumatoid arthritis, this was abandoned later. Glenohumeral osteotomy, he has demonstrated in NRS in front of Professor A.K. Saha. Glenoidal osteotomy. Lastly is the BD vac drain, that is the Dibendu Gove, who went to Australia, went back to Australia, and both they combined, they do this negative section. This is still available today. He was a Psi publication, he's Psi for product, but he attended all the meetings and read papers and conferences of the orthopedic chapters of the ASI in those days. ASI in those days was the chapter. And he also used to encourage Nikhil Majumdar to present papers in his research, on his research. He was a modest gentleman and was loving in nature. He used to encourage the youngsters to do more work and research.
Sir Harris Platt, when he visited Calcutta, he highly appreciated Dr. Sen's work and he asked him to publish this work, but he never published. Towards the end of his life, he suffered from schizophrenia and did not able to come to RKM. He remained secluded for 4 years and turned into a spiritual pursuit for the rest of his life. He passed away, leaving behind Dr. Meera Sen, Professor of Plastic Surgery in SSKM, and a daughter well settled abroad. So thank you, my dear friend. This is in brief about the great legend, Professor Dr. Biswajit Sen. Thank you very much.
Okay.
Now this is time for a medical legal session, and the talk is on medical negligence and do we need to worry. It will be an online discussion. VJ Purushottam will be the speaker. And I would like to welcome on the stage the chairperson for this session, Dr. Obhijit Sarvadhikari and Dr. Dipanjan Payan. Online session. Presentation. Dr. Sarvadhikari will say a few things.
I think most of the people who are here are of an age who started worrying about the khaki envelope that might arrive anytime. And one of my most evocative kind of readings out of a very favorite author of mine is Catch-22. The feeling that you've done the best and even then you're being victimized. It's kind of crystallized in a few lines. So just note it down and doing it. And then we go over to the professor. It's like the colonel, he's been asked by Usarian, the so-called hero, that what have I done wrong? I did everything right. And the colonel says, that's not what justice is. The colonel jeered and began pounding the table again with his big fat hand. That's what Karl Marx is. I'll tell you what justice is. Justice is a knee in the gut from the floor, on the chin at night, sneaky with a knife, brought up down on the magazine of the battleship, sandbagged, underhanded, in the dark, without a word of warning. Garroting, that's what justice is. When we have all got to be tough enough and rough enough to fight Billy Petrol from the hip. Get it? So that is the kind of feeling you might feel when you get one of those brown lifafas. And I hand over the stage to Professor Purushottam for his reading on that.
Thank you very much, Professor Sarvadhikari, for that pre-note to start my talk. Am I audible?
Yes, sir.
Am I audible?
You're visible, but not properly audible. Just a second.
Is that okay now?
Yeah.
I'm audible now?
Yes, sir.
Yes, audible. Yes, sir, you are audible.
Okay, thank you very much. Good morning, everybody. In the first outset, I thank West Bengal Orthopedic Association for having given me this opportunity to interact with you all. Wonderful Sunday today it is. I'm here. Sorry that I'm unfortunate. I could not come in person to West Bengal, which I would have loved to come. Anyway,
today's topic is about medical negligence and should we worry about it? Let me start sharing the screen. My screen is visible?
Yes, sir, visible.
Yeah, thank you very much. So you all know that last 2 decades has been an uphill task for us in terms of medical negligence because the cases are so much on the rise, and every time when we get to hear about it, more and more cases are going against the doctor or hospital for small reasons, that because documentation is wrong or communication has gone wrong. Now, we know in 2019 and 2020, there was a discussion about amendment of the CPA Act. So we rejoiced, we thought it is all gone. We are no more in the service of Consumer Protection Act, which is again wrong. Let me first tell you what is negligence. Negligence is nothing but which deals with law of torts. It's not the criminal negligence what we talk about. It's the law of torts, civil wrong, which defines as a breach of duty caused by the omission to do something which a reasonable man, guided by those considerations which ordinarily regulate the conduct of human affairs, would do or do. But if you look at the last sentence, that is doing something which a prudent and reasonable man would not do. That is what it amounts to, negligence. And in medical negligence, a failure on the part of a doctor to exercise his or her skill, care and caution, which are required for a professional, that is of a professional. So this is all about negligence in simple terms. Now, briefly, we should know what is this tort law we are talking about, unless the against that criminal law which I mentioned. It is the amount of damages incurred which is determinative of the extent of inability in tort law, whereas in criminal law, it is the amount of damages not counted there, the amount and degree of negligence that is determinative of liability. So they are all dealt with the sections of 304, 337, 338, whereas the tort law deals with 80, 81, 88, which we are worried about. Should we, if at all, we are worried about. So let's briefly about Consumer Protection Act. We all know it came into force in India in 1986. And we also know, like I told you, it was amended in 2019. Medical services were included in CPA in 1995. How? Why? What was the reason that medical service was included in Consumer Protection Act? It was a case that was heard between VP Shanta, a patient, and Indian Medical Association. The Supreme Court declared service rendered to a patient by a medical practitioner, except where the doctor renders service free of charge to every patient or under a contract of personal service. By way of consultation, diagnosis and treatment, both medicinal and surgical would fall within the ambit of service as defined in Section 2(1) of the Act. Therefore, medical practitioners are also liable for deficiency. So this is how 1995 is the year when our health service was included in the Consumer Protection Act. We know now what is Consumer Protection Act and what is why medical profession was brought in the ambit of Consumer Protection Act, considering health is also a service, kind of service. Now, if you all remember, there was a big confusion in 2019, 2020. In fact, in the beginning of the pandemic, there was a news that the new bill of Consumer Protection Act says health is excluded from the service. So we all rejoiced. We thought health is taken away from the service of Consumer Protection Act and we are happy about it. No, it was wrong, because the amendment of CPA, which was first drafted in 2018 and again redrafted in 2019, what they, in the draft, they dropped the word healthcare from the list of 13 services. Now you would say, yes, healthcare is taken out of this, but what is the real meaning of that is when they defined services in the new draft, they wanted to include as many services as possible in the word. What they did is they included 13 services and then went on to add one sentence saying includes but not limited to. So therefore, all the another, we have about 160 services. So out of 160 services, the 13 services were mentioned here, but they say it clearly said that amendment clearly said it does not limit or excludes other services other than this 13 was there. But if you go back to the ruling of the Kerala High Court in 2021, it clearly said health service is one of the services which is still in the ambit of Consumer Protection Act. So that euphoria of that initial thing that health service is taken away is gone away. It is no more there. And we all know, I'll briefly go through the levels for some of the youngsters here who would want to know about levels of forums. District Consumer Forum is the lowest level where it has 3 members sitting, of which 1 is woman, and 20 lakh is the capping. State is about 3 members, again 1 member being a woman, and 20 to 1 crore is the limit, whereas the National Consumer Dispute Redressal Commission is 4 members and 1 woman, and more than 1 crore is the amount. So this is just about comic relief here. So what the law looks for, let us look into that. What is that all about, this medical negligence, and what about the CPA Act is looking into our profession? Actually, if you look into the torts, 3 limbs of torts law, that is civil law, are a legal duty to exercise. And next is breach of that same duty. If there was a duty, like between the patient and the doctor, treating doctor, or the hospital or nursing home. The second one is breach of duty. If the duty is breached, whatever the duty which is undertaken, for example, if the patient comes to you and you have taken up the patient to treat, now if there is a breach of this duty, and third one, has it resulted in the damage? So the duty, breach, and damage is the 3 limbs of the torts law. Now, what are those 3 pillars of the breach? Now, the word breach is very important here. One is reasonable care and caution. I must tell you, these days it is not just reasonable care and caution. It is also looking into utmost care and caution, not just the standard degree of care, which is actually by mean of their proclamation, it is only reasonable care and reasonable caution. Again, we have to be careful that it is looking into the utmost caution also, and reasonable skill and knowledge. Now, for example, we are treating a case of distal end of radius with plaster of Paris. Now, have we given reasonable care? Like, have we explained the patient what are the options of the treatment? And have we taken enough caution to give suitable anesthesia, like hematoma block or regional block, or enough padding before applying the plaster to avoid some complications like compartment syndrome? These are the things which are reasonable care and caution which we are talking about. Now, what about this reasonable skill and knowledge? You don't need to have higher skill. We know there are some experts who treat fracture distal end of radius with 1 click of their hand and get beautiful reduction. No, it is not that. Did you do like that, Dr. XYZ? No, that is not the question here. If you are able to do a reasonable reduction and reasonable treatment with reasonable skill and knowledge, one would think that this is a subjective word. Yes, again, I would admit that is a subjective word, but in most of the cases which I have followed, it is the law looks whether reasonable skill or knowledge that gentleman or the doctor or the practitioner person had. You don't have to have highest degree of care and skill. You don't have to proclaim I am the best in that field. No, you don't have to. The beauty of these things is we spoke about duty, breach, damage, and in the breach, care, caution, and skill and knowledge. Now, definitely the onus of proving that there was no reasonable care, there was no reasonable caution, there was lack of reasonable skill and knowledge, then the onus is definitely on the petitioner to prove against the above. So it is always the onus is on the petitioner to say that these things were not properly taken up, like reasonable care and caution, and things were not done accordingly. This is one of the oldest tests dating back to 1950s, where Bolam versus Frayne Hospital is considered as the test in considering whether there was medical negligence or not. Just briefly about this case, this was a case where the patient was undergoing ECT for some neurological disorder. While undergoing ECT, the patient fell down and sustained some injury, and he sued the hospital and doctor for not being cautious about treatment. But by looking into the parameters of the test, the way the method of the test was conducted, the court ruled out that there was no negligence by saying a failure to do some act which a reasonable man in the circumstances would do, or the doing of some act which a reasonable man in the circumstances would not do. I think you all got this point clearly here. And if that failure or the doing of the act results in injury, then there is a cause of action. So the Bolam test, though in the UK, it has been taken out. There's no more mention about Bolam test. There is one more called Bolito test. These are the ancient and old tests, but still in the law of medical legal issues, this Bolam test holds good in India as far as argument is considered. And I have to mention, because there are many instances when the court proclaims this case is of highest negligence, that is gross negligence. So how was it defined? It was defined in a case pertaining to Srimati Madhubala versus Government of Delhi in 2006. The court classified the negligence as lata kalpa, that is gross neglect. I will tell you what amounts to gross neglect in orthopedics. Levis culpa, ordinarily neglect, that is not really amount to the gross neglect, and levisilma culpa, which is slight neglect, which can even not be contested if it is slight neglect. So when is it gross negligence? Something like what you see in the picture, where somebody has left the instrument in the body while doing surgery or while doing something. So now I'm just to put some picture what I could get hold on. Res ipsa loquitur is one of the things. Things speak for itself. There need not be any, case where you have to defend. You have to stand up and say, no, that is, because the thing speaks for itself. Something like wrong patient. You have operated or you have treated a wrong patient, wrong side, not on the required limb. The wrong limb has been operated or treated. Contraindicated treatment or drugs. When you know that this treatment cannot be given to this patient, or this medicine cannot be given to this patient, if you have given and you are not qualified. Now again, here is the question in many of the talks where I go, the audience asks whether who is authorized to, for example, to do arthroplasty in orthopedic field, whether he has to have a fellowship, and what fellowship should he have? No, the court here doesn't look into that matter. If you have a degree of orthopedic surgery, that is MS degree, they definitely accept whether you operate on whichever the specialty you are. So, but not being qualified to that level, then you do something, then that is gross negligence. Surgery without consent will definitely be a gross negligence offense. That amounts to section 92, 93 of the tort law, where which can be considered in criminal negligence also. Now, just briefly, why are we at the receiving end? One, we have this noble profession tag where miracles are grossly expected. People think we can do wonders, though we know the fact that many of the times we will not be able to break the case, some complicated cases. Overassurance, this is from our side. We have a tendency to give overassurance or claiming that 100% recovery, though knowing that there won't be like a bit of deviation from the oath what we have taken. Thin line between complication and negligence. We never know. The complication is different and negligence is different. We all know certain things in the best of, for example, infection, in the best of our care, best of our setup. Still, if the case lands up with infection, that could be a complication, but it's not necessarily a negligence. So there is a thin line whether it is a complication or negligence in few cases. So we have to defend how best we can defend in that point. Malpractice, again, thin line between need and greed. Let's not talk more about it. Professional rivalry, rat race, these are the things which is, in many cases, I have followed about 43 cases so far in the district, state, and national consumer forum. In many of the cases, it is us, we give up the clue to the patient that this is the problem. This should have been done like this. This could have been done like this. So professional rivalry is one of the key points why we are at the receipt. And orthopedic, I would say, all of us know X-ray speaks for itself. So, and deformities are the things which are obvious, like unlike in medicine or surgical cases, which may not be seen properly to the common man's eye. And some important causes in orthopedic, we all know poor results, wrong treatment, infection, wrong side, nerve, vessel injuries. There are many things, many in the list. But I would say whether it is orthopedic, obstetrics, or whatever the subject, the main thing is improper communication and documentation. We fail to communicate properly with the patient. That is important in defending our case. If the communication is not proper, we will land up in a lot of problems. And documentation, lack of documentation also will result in such scenarios. So now the question is, having understood what is negligence, what is Consumer Protection Act, and what are the rulings we have against us, and how difficult, how we are on the soft target for in this scenario, and so some of the common mistakes. Do we need to worry about it? I would say, yes, we have to worry because cases are on the rise. People, the advocates are hunting out for the cases. There are some agencies in the Western world, there are some agencies, they advertise. Are you a victim of some bad treatment? They just place an ad in the newspaper and draw the patients to them. Yes, we need to worry about the increasing trend where the patient and the advocate is looking to hunt for doctors and hospitals if they do go wrong. And no, why no? Because there are a lot of avenues, a lot of things that has flown through in the last, I would say, from the landmark judgment in 2005 to now 2017, 20 to 17 years of good handling of cases. We know that we do not have to worry so much. Judgment clarifying criminal versus civil negligence. Hello. I think there was a brief disconnection.
You're okay now?
Can you see us?
All okay. Sir, you can continue.
Yeah.
Just share your presentation.
Sir.
Can you see the,
Not yet, sir.
okay. What's happening here?
Yes, sir. It is visible.
It's visible now? Okay.
Yes, sir.
So a doctor accused of rashness or negligence not to be arrested in a routine order unless it is necessary for furthering the investigation. Whether the arrest demands the possession of the doctor for further investigation or collection of evidence, he should not go for arresting the doctor. That was the landmark judgment we had in the case of Jacob Matthew versus State of Punjab, which further said a private complaint may not be entertained unless supported by prima facie evidence given by another competent doctor to support the charge of rashness or negligence. And again, investigating officer before proceeding against the doctor obtain an independent, competent medical opinion. This clearly says that it has to be supported by an evidence or an expert evidence from another doctor saying that there was negligence. So this was brought in the year of 2005. Many of the advocates also overlook this judgment, and we should be definitely aware of this, which gives us. But you know, in one of the panel discussions where I was also involved, and one of our police commissioners of Bangalore, he went on to say, "Doctor, we arrest you for one reason. One of the main reasons is to see that your property and your physical injury is not attempted when things go wrong. So we come there and arrest you only to make a scene, to say that the law and order situation is taken into control. Otherwise, the damage to the property and to you would be more." So that was, I don't know how best we can agree with that. But by law, they are not supposed to arrest you unless it is a culpable gross negligence. So, my dear friends, you have to be aware of these 11 guidelines of Supreme Court, which definitely props us up to keep us in good enough comfort zone to think that not everything is against us. There are certain things which covers us. The first is, we discussed negligence. It has defined in the 11 guidelines the Supreme Court gave in 2007 of that. Negligence is a breach of duty or an act which a prudent and reasonable man will not do. That is what? That is definitely. Second one is, criminal negligence to be established by the prosecution must be culpable or gross, not merely negligence based upon an error of judgment. An error of judgment is not a negligence. Medical professional is expected to bring a reasonable degree of, we discussed, not the highest or level. I discussed it in the earlier slide. A doctor would be liable only where his conduct could fall below that of the standard of a reasonably competent practitioner in the field of work. That is, in all these guidelines, what the Supreme Court is proclaiming is a reasonable care and caution and standard degree of care and standard degree of skill and knowledge. That is what is required. Difference of opinion cannot be cited as negligence. For example, there are two methods of treatment. Like, for example, in an upper femur, if there is a treatment choice between PFN and DHS, and if the doctor has taken up DHS and it has failed, you cannot say simply say that DHS was the reason because he decided to go with another choice which is not as popular. No, the difference of opinion cannot be cited as a negligence. If it is an acceptable treatment, it has to be within the limit, and it can be defended. The sixth point proclaimed is that just because a professional looking at the gravity of illness had taken higher element of risk to redeem the patient out of his suffering, which did not yield the desired result, may not amount to negligence. Beautiful this is. For example, if the patient has to be, the limb has to be amputated to save his life, or in other field, something has to be done to save the life. He takes some risk, the doctor takes some risk. That cannot be, and it ends up with the death of the patient or some gravity of the losing of limb or something pertaining to that patient, just because he overweighed the risk and took up the risk to execute a treatment. It cannot be. Merely because a doctor chooses one course of action in preference to the other one available, he would not be liable if the action chosen by him was, again, the same example what I give can be taken up here and tell that if the doctor practicing has chosen one of the methods of treatment, which is standard, which is considered as one of the standard methods, maybe it is little old, but if he has taken that standard treatment, care of treatment, then he would not be liable if the action chosen by him is supported. This is beautifully told, like, it would not be conducive to the efficiency of the medical profession if a doctor had to administer medicine with a halter around his neck, like we see in this horse. So every time if the doctor has to think, I have to do this, shall I do this, shall I not do this? So if I do this, the patient will go to the court, or every step, if there is some hindrance for the doctor to execute his professional capacity, then it will be a problem. This is what this means. It is our duty not to harass or humiliate medical professionals unnecessarily so as to allow them to perform their duties without fear and apprehension. It's very good that it is telling to the legal fraternity that our duty not to harass or humiliate medical professionals when things go wrong in spite of their standard care and caution. So doctors at times have to be saved from such class complaints who use criminal process as a tool for pressurizing them or hospitals. We know many a times these things are happening where some NGOs, I'm telling some of the groups who will be waiting to pounce on the doctor or the hospital if something goes wrong, because they have some personal grudge or vendetta against the hospital. So we have to be, the Supreme Court declared it, we have to save them from such complaints, the tactics which is an extorting tactics or something like that. Lastly, they say the doctors are entitled to get protection so long as they perform their duties with reasonable skill and competence. Again, if you look into the entire talk of this entire scenario of medical negligence, it is emphasis is on the reasonable skill and competence, and nowhere else we are talking about highest level of skill or highest level of competence here. And it's very good, very encouraging to see that Supreme Court says that the legal system has to give some protection to doctors when they are in their standard care and caution in executing their treatment or duties. So all these 11 parameters, guidelines that is given to the Consumer Protection Act practicing redressal forums in the district level, in the state level, or the national level, has to be aware of these 11 points while dealing with any case. So in one of the cases where I was following up, the advocate was not aware of this, in fact, these 11 points, and he was so focused about the points which the charges were made. And when he looked into these points, he said, correct, these are the points I can claim and I can put across in my argument and try to win the case. And in the state forum, when it's pointed out to point number 7 and 9, then the sitting chairman of the members of the Consumer Redressal Forum agreed, yes, this is the Supreme Court guideline and we have to go with this. So, my dear friends, what I'm trying to tell, do we need to worry about medical negligence and medical legal issues that is happening around us? Because since cases are more and awareness is more and more with the public, yes, we have to be. But we don't have to worry, because there are several, if you're on the right track, if you have practiced standard care and caution, and you have your defense is, your documentation is very good, and your what do you call, communication with the patient is reasonable, then definitely there is a cause to defend your case if you are on the right track. So this is all what I wanted to say. But look at this cartoon. This is what is happening now. On the third day, God created trace. On the fourth day, some idiot walked into it, damaged himself. On the fifth day, God was slapped with a frivolous lawsuit for reckless negligence. So this can happen. This can happen. This is just a cartoon to say that it can happen to anyone if there is this system of medical negligence is taken. So what you do when you are in trouble? Don't panic, be calm. This is very important. Discuss with the senior colleagues. Always, I get many of the times when some members of Karnataka Orthopedic Association get into this problem, they call me, they ask me what to do, how this has happened, how to go about. So discuss with the senior colleagues about the case, about going ahead with the case. Just don't yield to the out of the court settlement, which is thrown away by the patient. Talk to the patient, very important. Talk to the patient. You have to sit with the patient and explain, this is complication which has happened despite my best effort or despite reasonable care and caution that I have given, but we will try to rectify that. Appear sympathetic, because you know, it is for him or her, it is loss of limb or life, endangering life or limb in question, locomotion in question. So all these are very, very relevant to their emotional settings. So you have to be sympathetic with their problem. Keep proper records. Documentation is the very, very important aspect of defense, and never overwrite, never overwrite. Many a times overwriting of the documentation that is produced to the court has become an evidence that doctor has tried to conceal something. Don't overwrite. If you have to change something, just put a slash on that word, and above you can write whatever has to be written. So documentation in the beginning has to be proper. Know your lawyer, discuss the case in entirety. Like I told you, no, we are the one who are defending it. It's not just the lawyer. Lawyer is the media we have chosen to represent our case. Lawyer knows legal points about defense, but the case can only be defended by the technical points what one knows, that is the doctor. So the doctor has to give, for example, in one of the cases, one very popular advocate from Kerala, one night he called me and asked, Dr. Purushottam, what is the difference between closed reduction and open reduction? In fact, you know, it's a small thing for us, but that eminent advocate who deals with consumer cases, he did not know what is the difference between closed and open. So what I'm trying to tell is the doctor has to feed them important information regarding the case than just letting the advocate take his own course of action. Procure relevant supporting documents. In the beginning, only textbooks like Campbell, all that was required to be produced. Even then they asked for standard book. But if you have something supporting your action or your treatment by way of a good article or journal, you can support it with such documents. Respond to the court on time. Never neglect. This is one of our biggest mistakes. We don't act on time. Respond on time to the court. So one of the strongest lines of defense is error of judgment. Medical negligence is there. Duty, care, caution, breach of duty, damage, everything is there. But the 11 Supreme Court guidelines are there to protect us and draft our defense. Everything is there. But one of the strongest line of judgment is error. An error of judgment. When you take a decision to treat one case with a knowledge what is reasonable, what is the standard, and it results in bad outcome, the error of judgment is not negligence. Decision of the treating doctor at the time of deciding can be proved as an error of judgment. It was not intentional, something like that. So, but again, it's highly subjective. The error of judgment can be. So defense has to be stronger to prove that it was an error of judgment rather than a negligence. So finally, what's in store for us? We know the consumer is the king is the phrase of this Consumer Protection Act. So cases will definitely be on the rise. They will look for like how it is in the West. We may reach that level. We are yet to reach to that level where every single or small things are challenged in the court. Communication and documentation is the key to avoid such problems. You, the doctor, should be in control of the case while drafting the defense. Many legal experts feel if health service is taken out, CPA, the violence against doctor and hospital will rise. Truly, this was the discussion we had recently with a set of lawyers. They feel that if health is avoided, taken away from the CPA, Consumer Protection Act, definitely violence, because at least to some patients, there is a way to challenge the treatment or the injustice in their own word, what has happened to them by way of CPA. But even if that is taken, the violence like directly attacking the patient, I mean the doctor or hospital staff will be on the rise if the CPA Act is taken away. So I conclude my talk here. Thank you and have a safe practice. Thank you again to the organizers of West Bengal Orthopedic Association for having given me the opportunity to talk about it. I'm sorry if the slides had some visual lack because of online talk, and my audio was also not proper. Thank you very much.
Thank you, sir, for your nice presentation. Thank you.
Thank you very much for your very illuminating talk with so many pertinent topics that you have touched. This was very necessary. Thank you very much, Professor Purushottam.
Thank you. Thank you all.
Now we will end this session, and thank you, chairpersons also. And now we'll start the Assami session. Coordinators, please come on the stage.
Good afternoon, everyone. Now we are going to start the Assami session. So first I will like to call the chairperson, Dr. Haripada Giri, and Dr. Pradeep Kumar Ghosh, kindly take their seat. And first I'd like to may I call Dr. Aniruddha Sinha Sarkar to start the session by his first speech on Elizaro fixator aided bone transport in a case of massive tibial bone defect and consequently the comminuted femur fracture.
Just before beginning of the next session, I think WBA have so many cases pending against our members, and we should have a panel of lawyers so that and expert group amongst ourselves so that we can draft properly and efficiently take care of the cases. That's a appeal, and that should be noted. Okay. So now next session on Assami, West Bengal. It's as I have been entrusted with the as state representative few months back. I would like to youngster Aniruddha Sinha Sarkar to continue the session as coordinator. And before that, a small introduction I would like to give that we'll at the end of the session meet and form a formal body of Assami West Bengal so that we can take the Assami and deformity correction in a systematic manner so that juniors can take up. After this session, we will meet. So to Aniruddha Sinha Sarkar, please.
Good afternoon, everyone. And I welcome you all today to the Assami session. And we start here with the fond memories of Dr. Priyojit Chatterjee sir, who had been very instrumental in this session for last years. And today we have with us national faculty Dr. Amar Soni sir from Gujarat, Dr. Subroto Basu sir, and we have our chairpersons here already here. So I start
with my case. So this is a case of a road traffic accident in a 27-year-old male patient with type 3B open fracture who presented after 12 hours of injury. And he did not have any comorbidities. So this is how he came, and this is the picture. So we'll proceed. So how to plan this case? I asked the faculties, everyone.
Hello? Can you?
Sir,
Okay.
this was the picture when the patient came to the emergency.
Neurovascular status?
Sir, it was no, there was no neurovascular injury. It was intact. Sir?
Audience of the panelists were the.
Yes, type 3B.
It is a good,
Yes.
vascular injury, not.
No, there was no vascular injury.
Then how will you manage it?
Yeah. So,
Hello, audience. It is a good.
yes.
There are three options. There are, we should think logically and scientifically.
Sir.
Though Elijah of session,
Yes, sir.
it's not mandatory to do all the Elijah of alloys. So, yes, there are two options we know. We can do the reconstruction, standard reconstruction with the, say, some X fix type of thing to be applied, and early thorough debridement
Okay.
and early skin coverage. So, osteoplastic reconstruction that be involving plastic surgeon and or orthopedic surgeon. That's the best protocol that has been established in the UK. So,
Okay.
after that, when the infection is over, then skin cover is there, then can we proceed in two ways. So we can reconstruct with dual fibula, or we can go for Ilijarov and bone transportation.
Okay, so I'll proceed. I'll show how I have managed this case. Yeah, sure, sir.
And, what can be done?
Sir.
Debridement of the
Sir.
excision of the loose pieces of bone, what
Sir.
are there.
Sir.
Then after that, you have to do a muscle flap to cover them.
Sir.
And you can do external fixation.
Okay.
That may be the limb reconstruction or bone fixation.
Sure.
After that, when the wound will be okay, then you can do Elijah fixator and distraction of stereolysis
Okay.
for the final.
Sure. So we all agree with the this distraction oxygen is very much essential in this case. So this is how I have managed. So first we have done a debridement, and there were many loose. The bones were crushed, comminuted, and we have excised. I mean, I have already planned that we have to do bone transport anyway. So with Ilizaro, so I have made the ends transverse, so that we could do a good transport and docking at the later stage. I had put X-Fix first, and we did not have any plastic surgeon there. We don't have the place where I work. So this is another way of doing. So the wound already shrunk by itself with dressing, and this is after around 3 weeks. So the bone loss was 17 centimeters. It was a huge bone loss. Sir. So
you went for primary wound closure, but the loose suturing.
yes, sir. Yes, sir.
No, you don't allow to have gastrocnemius flap.
No, sir, it is not required. In these cases, it is not
required.
Sir, if there was any exposed bone, it would have been better. But in cases of Ilizaro, where we have only soft tissue.
And not required, it's not the right type, I think. already you have submitted that there is no plastic surgeon available at your place. But if plastic surgical cover is the surgery available, that is one option.
Yes.
And of course, with the other option is, if we plan for docking and shortening with Dolsport, we need not do any plastic surgical muscle flap or type of reconstruction or rotational flap.
Yes.
Because with the bone transportation, not only the bones, even the soft tissue also lengthen, and that defect can be corrected. But I beg to differ with your first management. I will rather ask you the question: why have you not as you have planned the bone transport? Why have you not done it in the first sitting instead? What's the harm if you put the Elizarov in the first place?
Hello, one thing, please.
Sir.
It is a presentation. You have time bound 10 minutes. So you finish the
Okay.
presentation.
Okay, sir.
And then.
Sure. Okay, I'll proceed. Actually, the presentation will answer the questions. So we had a 17 centimeter bone loss after this. So we started with, I planned for bifocal bone transport, but there was comminution at the proximal, during the proximal corticotomy, there was posterior comminution. So I was not confident with transport from that segment. So we went on with the unifocal transport from the distal side. Sorry. So this is how the wound healed. You can see that even with the dressings and all, the wound had healed. We did not, the skin coverage got there. And this is during the transport. We made the fixator very rigid and like not rigid, like we maintained the fixator. Patient came for follow-up regularly. There was minimal pin tract infection. And so there was like no much deviation of the translation of the fragment, transport segment. So this is after like around 7 months of the transport. So we can see that there is a good formation of the this regenerate, and that is the docking segment. So after a total fixator time of 15 months, this is how the bone had formed. So this is what the patient also had a very good knee movement, but ankle was stiff, and there was no infection. There was no post-op infection. Only some pin tract infection was there, but there was no post-op infection. So this is after maybe say around 1.5 years, the patient can walk. There is some limp, but which is getting corrected with time, but he is happy and he can walk.
Yes, now open for discussion.
Excellent.
Please.
I
have one.
Yes.
Girida, I have one question.
Would
I have one comment.
Sorry.
Dr. Giri, I have one comment.
Sure, sure, sir.
Sir, 17 centimeter transportation through a single osteotomy, it is a very difficult thing.
Yes, sir.
So for this long bone loss, it is better to go for trifocal osteotomy.
Yes.
Either trifocal osteotomy, or another thing is you can create a deformity. That means you can shorten the limb, and afterwards, when it unites, you can lengthen the limb. This is one method of treatment, that you can create a deformity, let the bone unite, then lengthen it. So 17 centimeter, you are lucky that you got 17 centimeter of lengthening. But it's sometimes it's very difficult. And we can consider for trifocal lengthening.
Sure, sure, sir. Sure, sir. Sir, I totally agree, sir. Actually, I really wanted for bifocal, at least bifocal transport, but I had problem with the proximal osteotomy, so I was not confident. Later on also, I could have done after 2-3 months, maybe I could have done again in that same area, the proximal osteotomy. So later, another osteotomy proximally and transport could have been done. So, but there was some issues with the patient, like monetary issues and all. So,
yeah, my query was, would a fixation of the fibula help in stability? Number 2 is, how long did it take?
Sir.
And number 3, was there any final shortening?
Sir, there was, fibula. Actually, first I thought that maybe you would have passed a rationale or something to maybe make that in, but after we have put the Elizarov fixator, the alignment was good. The alignment was good, and we have passed the wires in such a way it was parallel. The joint lines were parallel. So fixator was, I mean, it was good. I mean, fixation was good.
I understand.
Yes,
But
sir.
transporting a fragment for 17 centimeters
Sir,
without any lateral support.
sir.
Go back to the next slide. Go back.
I have one question.
Sir.
The fantastic case. I have not seen that so long transport 70 centimeter. in,
Sir.
Kurgan also.
Sir.
They always suggest two sides. for
Sir, yes, sir. Yes.
8 centimeter.
Yes,
And my question is, when you are transporting this long way,
sir.
can you use one intermediary wire? They usually suggest two olivers from two different medial side and lateral side and transport through this dot. So you have not deviated in this
Yes,
case.
yes.
There is chance of deviation.
Yes, it is there.
And another thing is that always we do when we make an reserve plate,
Sir.
we fix the head of the fibula with an olive or something.
Yes.
And the distal lateral malleus also, so that the fibula is not. You
Sir.
have done this.
Yes, sir, I have said
I
done.
think this is the question of Dr. Shraddha sir.
Yes, yes, we have transfixed in the proximal tibiofibular, distal tibiofibular. We have the wire we pass. We have fixed in those cases.
Next.
Okay, now I proceed to the next case. So this is another case. So it is a 27-year-old male who had an RTA. He came within 4 hours of the injury, and we can see the type of injury. There was type 2 open wound, and a part of the bone fragment was penetrating through there. He did not have any other comorbidities. Okay, so what I have done, this case also, there was a too much bone combination, and I went for, I planned for Elizarov reconstruction. So in this case, as the wound was not much contaminous, wound was relatively small, I went for the primary Elizarov fixation. And so we had just put the fixator on. And what we did was, we did not do any osteotomy in this during this time. And we waited that till the wound gets quiescent, it gets healed. After that, in a second stage, we will do the corticotomy and do the bone transport. So we can see, so after the 3 weeks, we did the corticotomy. And also I made the distal part of the proximal segment transverse, little bit transverse. I could not do it fully, but to aid better docking during the next time we need docks. So we did the corticotomy, and we started with a latency of 7 days. The patient started partial weight bearing. So as there was also distal femoral fracture also, it was a simple articular fracture. It is, if you can see, it is fixed with a CC screw there. And so due to that, we also had, and the fixation was not stable at the distal femur side. So we had also put one additional ring at the proximal tibial segment, so that for better stability, and patient did knee movement regularly. We had shown how to do the knee bending and all. He used to do at home. So we did the bone transport. And after that, there was no infection actually in the post-op period. So we had a plan to do this after the transport is over, plate fixation along with bone grafting. So pin tracks, we ensured that pin tracks were dry, and we did that the same setting itself. And we started even antibiotics maybe 7 days prior to the this surgery to avoid any infection. And so this is the way we have done. So in the leftmost picture, we can see the position of the limb. We have used this lithotomy stirrup. So we can see the lateral view of the femur in whole. And it is a very good way of seeing it. So we first we had fixed the transport segment along with the proximal segment with the X-fix, so that it does not, otherwise the regenerate may get disrupted. After that, we had removed the fixator. And then we did the plating along with iliac crest bone grafting. So at 16 months follow-up, there was negligible limb length discrepancy of maybe 1 centimeter. But then the problem only thing was his knee was stiff because post-operatively he could not do very good knee movement. And so this is after around 2 years. So this is how he walks. So his knee is stiff. The patient can do his regular daily work. He is happy with that. Okay, the judges.
Okay.
Yes, this is my last slide here. Sir.
Yes. Amorson is there. Amorson sir is there.
Simple question.
Sir.
You said the patient is happy, but you know the patient is not happy. Why? Because he cannot bend the knee.
Sir.
He cannot bend the knee. The patient, we are happy, but happiness of patient depends upon the complete.
Okay, sir.
Right. It's not the osteosis in the young started at the expense of the knee. Amorson sir or Dr. Subodh Amorson sir.
Yes, sir. Yes.
Sir, would you like to make some comment regarding the knee stiffness and what would have your plan?
Yes.
Sir, in such cases, we can offer patient cortisoplasty after a few months of internal fixation. Basically, such hybrid fixation needs to be protected, and once regional consolidation is good and union is good, one can opt for minimal invasive cortisoplasty, and these patients will invariably get a good knee range of motion with cortisoplasty.
Sir, before the if you have got the patient on day one, I think you have acted differently to save the knee movement because there are enough space was there, though some degree of knee stiffness might have, but putting the ring across the knee joint in the proximal femur in chest case is not mandatory. I have seen your cases. If you highlight and plan it, that will be enlightening.
I would say that even if we have not extended the frame below knee, patient many a times end up with knee stiffness. So just extending frame below knee is not the sole cause. This patient needs to do good rehab, and if patient is not doing adequate rehab, even without frame extending below knee, patient are having high chances of knee stiffness in such cases.
Okay.
Dr. Subodh sir wanted to say something.
Nowadays, there is another fixator available that is called alpha fixator. Alpha fixator is a monolateral fixator, but we can do 360-degree fixation on that by putting additional attachment. And along with this, there is a hinge system so that we can give knee movement from the initial period. So you can fix the tibia by a 360-degree ring in a monolateral fixator along with a hinge over the knee so that you can give movement from the beginning. So it is a good choice for the fixation when required very close to the joint.
And any just to the amount of angulation, you can see the lateral view. Any comment of Soni sir? Yes.
Sir, it's quite acceptable.
Okay. So thank you for the papers now. I think Dr. Soni should waiting. Soni sir.
Yes.
Soni is waiting, so he should be allowed. Thank you for participating. The Asabi was being chapter. Okay.
Should I share my screen? So my screen is visible.
Yes, yes.
So good afternoon, everyone. And at the outset, I would like to thank West Bengal Orthopedic Association for giving me an opportunity to present my work. Today, I'm sharing a case of limb salvage with ELISA method. This young lady had 9-month pregnancy and she was going to hospital, full-term pregnancy, and she sustained grade 3B tibia fracture, and she had on right side closed tibia fracture, lower fourth. So initially, emergency LSCS was done and debridement and external fixator was applied. Even X-ray was taken post LSCS, post external fixator, and in course of 20 days, 6 repeat debridement was done under general anesthesia. And at that point, the index surgeon suggested her below knee amputation. So patient and relative were keen for salvage, and in pursuit of limb salvage, they traveled all the way from Kenya to India for limb salvage. And this is the situation when she presented to us with external fixator in situ. And this is the clinical picture. One can see that there is a gross contamination. The slough is there, bone, muscle, tendon, everything is exposed. And she had undergone multiple surgeries before coming to us. So classical orthoplastic approach, as sir was suggested, that would require a debridement and external fixator, early flap cover, and change over to internal fixation once soft tissue cerebrals, and then later that such patient usually requires a bone graft. In contrast, if one wishes to treat such patient with Eliza method, one can apply a frame on day one post debridement. Split skin graft can be done on same sitting or at second stage. In such cases, I usually avoid corticotomy at the time of index surgery because when soft tissue samples, corticotomy should be done. Docking and such patients generally do not require bone graft. So this is how a frame was planned, means a tentative area of resection and the pre-operative planning was done. This is a prefabricated frame where frame is configured in such a manner that one can do 2 corticotomy between first and second ring, second and third ring. Last ring is carbon ring for better visualization of lower part, as the lower part is very small. This post-debridement clinical picture, one can see here that there is a large area extending from middle third of leg up to the ankle joint, and everything is exposed, and there is a large gap post-resection. This immediate post of X-ray, there is 15 centimeter bone gap. Frame is configured in such a manner that at later stage one can do double corticotomy. In such cases, I do not do osteotomy of fibula at the time of index surgery. Carbon ring is for better visualization, and one should always apply foot ring in such cases to prevent equinus. Once soft tissue stable, I did a double corticotomy at the end of 4 weeks and did transport. This is a closer view of proximal ring where one can see here that there is 3 wires. One is a fibular wire, one is transverse wire, and one is a medial face wire, and 2 anteromedial and anterolateral half pin in first ring, while a transported ring will have a medial face wire and anteromedial half pin. Foot ring is essential so that distal fragment will have an adequate leo arm of fixation and it will prevent equinus. So once frame is applied, one should give a latency post corticotomy of 1 week. Dissection is started at initially at 0.25 mm 3 times a day, and later on after 1 week increased to 4 times a day. Such patients invariably have some pain. If pain is not tolerable, one can reduce rate or reduce rhythm. If pain is too much, one can stop dissection of diaphyseal corticotomy for a few days and restart again. How I monitor the rate and rhythm, I apply a tag on each and every rod which are to be dissected and compressed. The purpose on applying all 4 tags is if patient is not doing even dissection, one can easily know that patient is not doing proper dissection. And at the follow-up, one can easily see that in 10 days whether this ring has shifted 10 mm or not. If ring has shifted more, means patient is doing faster dissection. If ring has shifted less, that means patient is doing slower dissection. And these tags are changed at each follow-up period. So these are images during transport, and this is pre-docking. One can see here that at pre-docking, the fibula is intact. At the time of docking, fibula osteotomy is done. And because we have compressed tibia acutely, there is some overlap of fibula. And that limb line discrepancy is addressed with post-docking dissection. If one is not doing post-docking dissection, then patient will have some residual limb line discrepancy. This is a clinical picture pre-docking, post-docking, and one can see here that the wound has held beautifully. And each patient with such large gap will invariably have skin invagination, and I do not consider it as an obstacle, but one should do open docking in order to remove that skin invagination and fibrous tissue, and in order to give good optimal outcome. Patient left India at 4 months and came back after 18 months due to COVID pandemic. And at that time, regenerate consolidation was good at both corticotomy side and union was good. During this 14-month period, she had 2 follow-up visits at local place where once a foot frame was removed and once the dressing was done. No radiological follow-up was there from Kenya. This is a clinical picture when she presented back to me. We did clinical testing. We removed all rod at fracture site and corticotomy site and asked her to stand and walk. One can see here that she is in her comfort zone and walking comfortably without any support, without any connection at corticotomy site and docking site. Post-frame removal clinical picture, pressure garments given to reduce the swelling, foot drop splint given. Radiological outcome, one can see here that all parameters are within normal range and there is no limb length discrepancy, no axial deviation, and good regenerate consolidation and good union at docking site. This post-frame removal, one can see here that how comfortable she is while walking and walking unaided. So if we evaluate this result with Pele criteria, the bone results are excellent in terms of union, no infection, no deformity, no lip discrepancy, and cross-sectional area is same as of native bone. Same way, functional outcome is also good, no pain, no need for walking aids or brace, no deformity, and no loss of motion as compared to previous range of motion. And she is able to return to normal activity of daily living and do all work. So this double cortical tendon trifocal osteosynthesis significantly reduced her stay in India. Her frame could have been removed at 12 months, but she couldn't come because of COVID pandemic. And in spite of being in extended duration in frame, her healing index was 34 days per centimeter. So ultimately, the goal is to prevent infection and achieve union. And a happy patient is one who is walking unaided and returns to pre-injury occupation. Many a times we see that such patients are being advised amputation elsewhere because many surgeons have not witnessed optimal outcome, functional outcome of carefully done Elizao surgery. And as suggested in standard textbook, that such patients should be treated by orthoplastic approach at tertiary care center, but in India, still the cost is main constraint. And many of such patients end up in peripheral center like us, where an orthopedic surgeon has to deal single-handedly such cases. And Elizao method gives an opportunity to treat such patient single-handedly without help of plastic surgeon. But there is a caveat. It has steep learning curve. One should learn the art of segment transport. Thank you. Thank you all.
Thank you for your nice deliberations. He does Elizao with the regularly and unbelievable cases which are amputated, advised amputation in so many places, comes to him and he does miraculous things. We thank you for your kind participation.
Thank you, sir.
I think no one can make any comment in one. Otherwise, I would like to ask President to give thanks on behalf of the business. Thank you, Dr. Suni. Okay.
Thank you, sir. Thank you, sir.
Thank you.
Thank
Thank you, Dr. Amar Soni. May I call
Thank you,
Dr. Amir Kumar Bera, kindly deliver his speech on Elizao-aided correction of Manus valgus deformity.
Wait, as a presentation. Screen. What else? Okay. I have been asked to show few cases while Elizao ring fixator is mainly for tibia, but in the upper limb we are dreaded of it. Tibia is the most common, next the femur, and in the upper limb it's dreaded. I was also very much dreadful because of vessels, nerves, tendons, muscles, so many nerves, and less exposure than dexterity of the movement of the fingers needed. But I was forced to do Elizao because I work in a peripheral setup. In infected non-union, it's the best thing, I think. But after doing some cases of upper limb cases, this case presented to me. So what are the options I would like to have? So many of us with not conversation with Elijah, I'm sure they do it in other ways. One, two options are there. Anyone? Rakesh, how will you manage it? Okay. So if anyone would like to comment, so I thought I can try it bone transportation. So I did it, tried it. I was very much skeptic about it. You can see these things. Now with the gradual transport, now you can see the movement, finger movement, in spite of so many ways. That if you follow the anatomical cross-section anatomy, okay, so he can do all those things, and you can see the videos. He can move and flexion, extend as well as move the fingers. Okay, so I was a bit skeptic. Now new bone formation is there. So this is the final X-ray. So this is my first case.
Any question from the audience?
Or comment?
Any comment?
Why not? Why?
What is the indication of elixir of in this case? If it could have been solved, because it could have been solved by a just fixator. Ulnar shortening, cut the radius, distract it by a just fixator, and you can make, we have done lots. Even you can do a plating. But Ravi Bharadwaj has shown these cases. This is a simple procedure. Huh? Yes. Yes. Ulnar shortening.
So there are so many procedures are there. How will you build the cat? That's another way. But it's I think it's easier. You have no donor site morbidity. You are not to whenever you try to convince the patient that you have to cut the normal bones, they do not agree many times and it shortens. So that's the thing. So to cut short the, I have already told that there are so many ways, but okay. Supination, pronation, yes, it's compared to, you can see, go back to the video. Shoulder, right. Pronation, supination, as you can see even the fingers movement, it was pre-operatively hot, was there. There is no decrease. There is no decrease at this I can say, okay. There is no X-ray. I would like to have the X-ray, clinical photographs next time, okay, incorporate. Thank you. So my second case. Definitely there are other options, but I think it's a good option not to cut the normal bones, and this is the answer I have to. So we can ask this. So this is another case of so this is defect. You can see infected fracture both bone forearm, treated elsewhere, presented late to me like this. So there are two options I had definitely. So I had to reconstruct two problems to reconstruct the druge, distal radioulnar joint, and lengthen the radius, as well as then there is problem of defect non-union. So I took the elixir of ring fixator, distracted the distal radioulnar joint, and there is some new bone formation. Then I had the option of corticotomy, but I am not skeptic about it. So I had put it, take the fibula, and after the druze is at the level, I have grafted here with the fibula. This was my very early cases, lost to follow up as it happens in Elizabeth cases in hospital in particular. So find that that's the union we achieved. That's the thing. Then again, some residual deformity was, and that was corrected. Sorry. You sit down. Okay. That residual deformity was again corrected with this. This is the two cases in the upper limb, apart from humerus. I think. Okay.
Okay.
Pronation supination definitely restricted. Even with this, they had late cases, yes, no. Functions. Okay.
Very recently, I have treated a similar case with masculate. I will show the result in the next meeting.
Okay.
Masculate technique with the bone cement and antibiotics.
Yes. Hello, muscular technique. Sir, please.
Yes.
Can I make a comment?
Sure, sure.
In the second case, what you have done, we welcome it. But during that procedure, the function of the fingers you have maintained, and that should be stressed very strongly to the patient. That is number 1 point. And number 2nd point, I am to mention the second case, about the second case. In such a case, in 1981, we did a similar type of case. What we did and whether fragment of that is ulna, took the graft, inserted over there, a KOR passed, and the graft was there, and prolonged and in 1.5 years, united very well with a good function. That was the case of Professor Hemant.
Okay, that's
That was the old method, but it is something new, and with the Elizabeth, with the less invasive method, ultimately the less invasive method, we must welcome it. Thank you.
Thank you. Yes.
You have got the function outcome of both the patients. And
He-
you have not told the follow-up figures.
Yes, I had actually a case series, but out of that, 2 cases has been posted because of the other constant. That's why it's not included. Okay. Definitely that should have been there.
Thank you, Professor Amir Kumar Bera. May I invite Dr. Anindo Sarkar to come on the stage and deliver shows us his Elizabeth cases. Thank you.
Good afternoon, everybody. Good afternoon, our national faculty, Dr. Shoni and Dr. Bashmi not late. After that fantastic cases presented by Aniruddha, Dr. Bera and Dr. Shoni, I want to present some simple case that can be done everywhere, and that cases we face every day. And I think no much expertise is required to do this by simple procedures. My first case, a 60-year male suffered from type 6 tibial plateau fracture, treated elsewhere with closed multiple screw fixation, presented with genu varum deformity with screws in situ. Okay, this is my first case. Should I carry on or someone tell some? So this is the axis deviation. This is a full length X-ray I have done. This much is the mechanical axis deviation. To show plan, I thought I can plan anything. So plate fixation after osteotomy, bone grafting can be a good option. But I thought I may do something more less invasive and simple procedure. So I fixed it with Elizarov, and I have made one oblique osteotomy below the level of tibial tuberosity, and I have placed my coda on the head of fibula. This is the site of osteotomy, and I gradually distracted it to the desired corrected position. And this is the corticotomy done through a 1 centimeter long medial incision. It is really minimally invasive. The 3 rings I have used, 2 hinges and 1 distractor with an X-ray after 13 days of distraction. It is almost corrected. Full correction after 1 month is carrying weight with the fixator, and full length X-ray after 7 weeks. The mechanical axis is fully corrected. After 7 weeks is the clinical pictures. Walking without support after 7 weeks. And consolidation at 12 weeks, frame removed. Follow-up after 7 months. And this is a walking painless after 7 months. This is a simple case we can do by several procedures, but I thought this is a very simple method that can be done everywhere with minimum infrastructure and very less experience. We can do it. Any question?
এটা মোস্টলি কি অস্টিওটমি প্লেট ফিক্সেশন করবে না এটা করবে একটু হাত তোলাই যায় কমন পিপল কি করবে মানে আমরা কি করব
Definitely there are scopes of Drawer College told one thing. He told I use the Elijah principle, but I have not used the Elijah fixator for last 20 years. So it's not that always Elijah fixator to be applied, but principles, if we keep it in mind, that's really a boom, and that should be always utilized. And definitely this can be corrected by osteotomy in a single sitting. That of course there is less chance, but cost is a bit higher. And most important benefit of this thing is that you can get post-operative correction, because if your pre-operative planning is not good, then you cannot adjust with the plate fixation. That's the greatest benefit, because many of us will agree that when we are doing the deformity correction surgery, tibial component as well as the femoral component is there, and we are not correcting everything. So that's definitely number 1. Number 2, however, I would like to have a question. Are you happy? Because when the patient is walking with some degree of valgus, and there is also a femoral going. Was there, have you calculated that proximal femoral, the distal femoral angle, that are normal? Okay, these are the 2 questions. Okay, but actually, a good job you have done.
Can I comment to what?
I am going the previous X-ray. This is the mechanical axis deviation corrected. So it is not valgus at all. It is fully corrected, and the mechanical axis is going through the lateral tibial spine. I think it is not valgus.
No. If you do not calculate proximal tibial angle, distal femoral angle, mere procedure, this line will not tell that is okay. Okay. Anyway, let us forget about it. I think next question.
Anand, I have one just question. That is, while you have removed the proximal screws, did you face any difficulty in putting in the proximal wires?
No, I think I could pass wires with the screws, but with the screws, I don't think there is much problem to. Two screws were there. There are 2 screws were there, so I could pass the wires with the screws, but I thought it may obstruct the way of the wires. So but actually I want to tell one thing. This procedure I have done about 7 years back. Nowadays I don't use Elijah, but I use the principle. The unique thing of this operation is that the oblique osteotomy. That is an incomplete osteotomy. I have not cut the lateral cortex, and that is far low, and it is not hampering the quadriceps mechanism, as because it is below the level of the tibial tuberosity. And I have put the coda on the fibular head, so the fibular head is not, the fibular length is not obstructing the correction. So I did not worry about the length of the fibula.
It is more or less
osteoarthritis knee by LRS.
Yes, I have shown it in the lab surgery.
Like that.
Yes, yes. Thank you. Yes.
So I want to do one comment. Manindo, I want to make one comment.
Yes, please. Gone.
If in this case, your cora is at the knee joint, we are cutting it much below that cora. So as per osteotomy rule 2, there should be some lateral displacement of the distal fragment for proper correction. So what is our experience that the deformity within 15 degree, we can correct it with osteotomy and plate fixation. When it is more than 15 or 18 degree, Ilizarov or any type of X-fix is the best choice. At present, we do it with hexapod, but up to 15 to 18 degree of the varus, it can be corrected with plate, but more than that, external fixation is required as the distal fragments need some lateral displacement. Otherwise, the deformity is not properly corrected.
Thank you, sir. Thank you.
Okay, thank you. Next.
So, my next case is a 35-year male with failed osteosynthesis. That is the presenting X-ray. So, I am presenting the case at first. So, I thought I am not to do an arthroplasty in this young age, and he is a carpenter. So, I thought to do some osteotomy at proximal femur for pelvic support, so that after bearing weight, the limb is not displaced proximally. And I have done one distal femoral osteotomy for lengthening and correction of the valgus deformity created by the first osteotomy, and lengthen it, and then I have corrected the mechanical axis to make the limb parallel to the opposite limb. And this is the bone synthesis. This is the full length X-ray. And this is the single limb stance. You see, when he bears weight through right limb, there is, to keep balance, there is some tilting of the upper ear, but the abductors is working. It is clearly shown there. And this is the clinical view, and after 8 months is walking without head. So the idea of presenting this case is that actually Ilizarov hip reconstruction is narrated on 1992 by Professor Ilizarov. What was done with Ilizarov fixator? When I thought something I should do with these people around 13, 14, up to 40 years age of old, where I thought arthroplasty is not the correct option for them. But I thought the Ilizarov in femur is a complex with that so much hinges and something. So I have to design something which should be simple. So I choose the LRS, use the same principle of Ilizarov, and which was narrated in Dr. Paley on 2004 in his famous paper. And I use the LRS fixator with simple 6 screws, tapered screws, and I obtained that result. This one? This one? Actually, the thing is that the abduction osteotomy at proximally, it is for the pelvic support. When you do that on the table, we adduct the limb as much as possible, and we do the osteotomy at the level of the ischial tuberosity. And like that, I can get abduction about 45 degree or more. if we get an abduction below 45 degree, 20 degree, etc., we cannot get the pelvic support. So the abduction should be more. And for that, the mechanical axis deviated laterally. We have to correct it. So I do an distal osteotomy to correct the mechanical axis and make valgus one. And with the same sitting, we can do some gain of length by distracting the distal corticotomy site.
I have two questions. Why there are so many options that there in case of the even this case of osteosis here. So there are scope of abduction osteosynthesis with bone grafting, and there are now newer generations of with the improved arthroplasty. Scope of arthroplasty was there. I'd like to hear comment from Master Sound Sony if he is there. Are you online, sir? No. Okay, most likely not. So, so I'd like to have the other's opinion, please, in this regard.
Basically, for this non-union neck femur, we all used to do the bachelor osteotomy and the Shanks osteotomy and all that pelvic support. And the whole principle was to make the proximal fragment abducted so that it gives a support. Here, the osteotomy that is done is not doing anything. It is not giving a pelvic support. Now, because you've created an abduction deformity there, you're correcting it by the lower osteotomy. And the thing is that even if you're lengthening it, it's an angular lengthening. The neck is the real lengthening is not happening. So this is a method, and you have shown it, and you've done it in your own way, which is okay. That's fine. But I think the easier option would have been if you have contemplated arthroplasty, that is okay. If you had contemplated a real old-time bachelor or a Shanks osteotomy, that is also okay. If you have thought of a valgus osteotomy in these cases and fixation, that would also have been there. There are many methods of skinning the cat. You have chosen one method, which appears on open site to be a little deformity producing rather than deformity correcting.
Actually, I have shown this case, but actually I am supposed to do this Elizabeth hip reconstruction in the septic hip like things that their head is absent. The age is around 13, 14. It's like that. IHR is most 13, 14. No, this is for 35 years old. Ideally should be done at below 16, 17, where we cannot do.
In the Tom-Smith arthritis, actually, it's more advocated. This type of pelvic support osteotomy, osteotomy should have been a bit at the lower end of the ischium, adapting as much as possible. Anyway, that's it. You have shown a great thing.
Whatever name he gives to this, what you're trying to achieve is a pelvic support osteotomy. The subtrochanteric osteotomy you have done and based your whole thing on is not at the level of ischial tuberosity. It's at least 2-3 inches below that.
No,
so there's much more proximal. And then all this deformity wouldn't have happened.
No, actually, this is the site of osteotomy that is actually narrated by Dr. Pale or Professor Elijah Rao. The site of the osteotomy will be that at the level of the ischial tuberosity after full adduction. It is not in this X-ray. It is not shown.
I think Agarwal has made it clear. If you go to that, you adduct the limb.
Yes,
and
then it
at
will.
the level of the ischial tuberosity.
Yes, yes.
That's better option. Okay? Previously, what you told.
It is adapted.
You have done a good job. Any comment, final comment from Subhuto regarding will you advocate this kind of osteotomy in neglected fracture neck of the femur? Rather old fracture. Yes.
No, actually, we did it for Tom-Smith arthritis and other septic arthritis. I never did it in fracture neck femur.
Yes.
And second point.
Yes.
Second point, Onindo can do the osteotomy a bit higher.
Right.
At the level of ischial tuberosity.
I think
that will be a good thing.
I think, Dr. Basu, if you agree, it's not advocate in skeletally immature patients because you cannot put the procedure at that time. So there to prevent everything, you can do it. Okay, thank you.
Okay, thank you.
Thank you.
Thank you for your good presentation.
Thank you, Dr. Anindya Sarkar. Yeah, okay, sir. As we are running late also, so we are concluding this assembly session. I will hand it over to Professor Amiya Kumar Bera.
Thanks to chairperson, and I will call all those who have presented the paper so to have a photograph with our chairpersons, and so that we can do the assembly next way in a much organized way with basically our workshop also. Okay, please. Worship.
We from Punjab welcome me to conduct a workshop in the
We are proud to, we are proud. I will call upon the dais Dr. Rajiv Raman, please. Our president, please have it. And Rajiv Raman, both he has taken the assembly group a bit forward, and Mohanty sir, please. He has already invited me for his workshop. He is planning a workshop at his institute at Odisha. Okay, KIMS. Okay. Okay. And I am honored to have. Thank you.
Good afternoon, everybody. After a wonderful assembly session, we move on to the conference debate. So the topic today is hemi or total hip arthroplasty for fracture neck femur in 70-year-old patient. So may I call upon stage the panelists, Dr. Inuit Sardar sir, Dr. Utpal Bandyopadhyay sir, Dr. Anand Mandal sir, and Dr. Swarnendu Samanta sir. Okay, so may I call the first speaker, Dr. Chandan Pathak sir, to say a few words about hemi replacement.
So to go on with the fracture neck femur in a 70 years old, hemiarthroplasty versus THR. So we are talking about treatment modality. There's no scope of fixation. It's all plasty. Let's debate. Now, if you search in the literature or not in the literature, if you search in Google, what is the average life expectancy of Indians? You'll find that in 2022, it is 70 years, 70.19. And if you search literature, what is the incidence, maximum incidence of fracture neck femur? It's between 70 to 75 years. It is almost maximum. And after that, the prevalence is between 70 to 80 and 8 years plus. So it's more than 70 years, you get 65% to 75% of fracture neck femur. So what makes fracture neck femur so special? Because it is the second commonest fracture after the vertebral fracture in elderly. And is neck femur fracture at all a problem? Basically, it's not a big issue. Issue is underlying medical comorbidities, dementia, Parkinsonism, diabetic neuropathy. Those things make fracture neck femur a problem fracture. Now, mostly the neck femur fracture comes to trauma surgeons, general orthopedic surgeons. And how I, as a surgeon, I'll be deciding whether I'll be going for hemi or total hip. Because we must understand that medical complications occur in neck femur fractures if we delay the treatment beyond, say, 2 days. It's written 24 hours, but to stretch it for 2 days. After that, the complications increase multifold. And you have to consider medical and psychological profile of the patient. And very, very important is what the patient expects after the surgery. And social and economic status of patient, these are very, very vital issues. And most important, expected lifespan of the patient after surgery. Now, there are non-modifiable risk factors in this age group. You cannot modify. Muscle weakness, deteriorating eyesight, very, very vital issues. And these I have already told. Neuropathy, Parkinsonism, and balance, deficit in balance and coordination. These are very, very pertinent and practical problems. Now, what the patients expect, say, suppose a 70 or 75 years elderly person is walking with comorbidities normally, do his or her normal activities, suddenly, unfortunately, got a neck femur fracture. Then the whole scenario changes, the whole life changes. Suddenly, the patient is bedbound. Toilet, that is the biggest setback, and he or she is forced to use bedpan, forced to use urinal. That is the biggest psychological and physical setback. So suddenly the whole world changes, and the expectation absolutely reverses. So immediately they think about whether I can do walk without stick or with stick independently, whether I can independently be able to go to toilet, and definitely considering our socio-economic status, the operation or cost must be cheap and durable treatment option. সস্তায় পুষ্টিক or খাদ্য. And most important that I should not be dependent on others. But after hip fracture, always remember that overall functional status suddenly decreases. Social independence decreases, mobility decreases, and what increases is all frustration, depression. That is documented, and that is added on to the financial burden providing health service and morbidity. Now, if we have a fact check on elderly hip fracture, you'll find that 1/3 of the patients following hip fracture, they die within 1 year. That is a very, very vital issue. And the same famous quotation from Watson Johnson holds true in 2023, that we come to the world under the beam of go out through the neck femur. Now we can come back to our original topic. The neck femur fracture is 30 years old. So consider diabetic neuropathy, Parkinsonism, comorbidities, and most of them are not a very high demanding patient. And think about more than 75% are geriatric population living in rural areas, and more than 85 or 90%, they do not have any medical insurance. Social economic status is very poor. So my natural choice is hemiarthroplasty. Why hemiarthroplasty? I've already told. Most of the fractures are handled by common general orthopedic trauma surgeons, and hemiarthroplasty is a surgery that is being taught to all the senior residents, all the residents, PGTs in their training period. So it is universally acceptable treatment, and approach and exposure is known to all. And why it is scoring over, in which area it is scoring over THR? In dislocation. See the dislocation rate. In hemi, it is less than 1%, and in total hip, it is up to 22%. And if we have to convert to THR from hemi to THR, it is less than 2.5%, even in less than 75 years of age. And how long a bipolar lasts? Literature will say that it's 12.5, 13 years. And proponents of total hip arthroplasty, like my very good friend Rakesh will tell, definitely. So I'm just summarizing before him that total hip arthroplasty will give a better longevity of implant, 20 years plus, better pain relief, mobility, better quality of life, and it is better suitable definitely for high demand patients and for a younger age group. I do not have any objection to that, provided that the patient can afford. And if we consider this HOPE trial, they have compared between Hemi and total hip, a short-term study. And it is proven that in short-term follow-up, there is no difference in outcome between Hemi and total hip. This article, Geriatric 2020, they have a systematic review and meta-analysis of RCTs. And this summarized that total hip replacement is a more complicated and costly procedure and greater risk of post-op location. And on the other hand, THR offers better and long-term function and longevity. So the choice is between Hemi and THR requires a very good estimate of patient's life expectancy. The benefit of THR are reaped only in long term, and hemiarthroplasty is clearly preferred option among patients with a shorter life expectancy. So can we measure life expectancy? This is a paper that has predicted that it is in women that if you have dealing with 70 years old patient, 100 minus the age, say 70, remaining 30, divided by 4. So that is 7.5 years of average life expectancy after neck femur fracture. So if we consider hemiarthroplasty in a properly done hemiarthroplasty, it will last for 13 years and that will serve your purpose. This is one of my patients, bilateral neck femur. It was hemi done 5 and 7 years back. So there are many ways to build a CAD. In hemi, you can choose your implants. So to conclude, choosing the right correct options for a geriatric patient, sometimes this is a very easy. Relatively moderate to low demand patient, hemiarthroplasty is the best choice. Younger age, healthy, very active, and definitely pocket friendly. So THR, you can consider that is a very good option. And between these extremes, in between those category of patients, life expectancy is the most important. So considering 30% mortality after 1 year, more than 75% geriatric people, they live in rural areas, and majority of elderly population are women. And 90% of Indians do not have any sort of health insurance. And hemiarthroplasty is an easier, cheaper, and predictable option for them. My choice is hemiarthroplasty. And you must have seen this. One of the famous columnists, in spite of getting THR for neck femur fracture at a premium cost at one of the premium hospitals, still unhappy. So not only the best treatment available can give you a best result. And just before coming, I've received this X-ray, and I'm thinking still what to do. Thank you.
Well, that was a clear case of wiping the.
So those were some strong points in favor of hemiarthroplasty. So may I request Rakesh Rajput sir to speak in favor of total hip replacement.
So Rakesh is there to defend. The
Normally we do defend in debates, but I actually completely agree with Chandan. So there isn't a debate. I think in the beginning he started off completely in favor of a hemiarthroplasty, and slowly we head off towards a thing. And it's like a cricket match. You know, when you are Virat Kohli, and that's what Chandan Pathak is, you can play any format, T20, 1 days, and test matches. But when you're a Cheteshwar Pujara, which is what the total hip replacement is, it is trying to find a place. Acha, test match to khelte deven. Well, I'm happy. So I think that's where the THR is. It's trying to find a place for some cases of total hip replacement. And let's explore this. So this is what we are going to talk about. Typical or one of the typical types neck femur fractures. Some patients will require a total hip replacement. Not all of them will be doing very well with a hemiarthroplasty. We've all seen that. We've seen failures of hemiarthroplasties. So it's not like we are going to bombard everybody with THR. We need to select our patients. We need to know our own limitations. And I think all the studies which I'm going to quote, you will see that the cemented stems are slightly outscoring the uncemented stems. So let's start with one of the being, I was thinking that Chandan will actually bring over this and I'll skip over, but he hasn't brought up. Cochrane review is actually supporting him. So look at this review, and when Cochrane comes, MJ Parker is always going to come.
So 119 studies, 102 RCTs. This is huge numbers, 17,653. Now you look at the mean range. This is exactly the range at which we are talking about. Okay. And if you look at this, one conclusion or one result is that cemented hemiarthroplasties or cemented total hip replacements are doing better. Next, if you look at the result, any benefit of THA compared with hemi is likely to be small and clinically appreciable. But remember the line just before that, no evidence to suggest even a bipolar is superior. So how many of you actually do routine bipolars? So stop doing that if you believe Cochrane, right? Now look at their conclusion and look at the last line. This is the same review with all these thousands of patients being THR may be inappropriate. This is the statement. And that's why sometimes I get bewildered by this Cochrane. Treatment for a subset of people, but we have not explored this, right? So they wash their hands off completely towards the end. So that's not really a journal or an article we need to really look at. Let's look at New England Journal of Medicine. So again, huge number of patients, 1,945. Now they are looking slightly more fitter patients above 50. Okay. Then most of them will be around 60, 70-year-old group. So in 80 centers in 80 centers and 10 countries. So huge, spread of this trial. The primary point which they are looking at is whether any second operation was done for that hip, which means could be a revision, could even be an open dislocation, debridement, whatever. The second operation was done. And the secondary endpoints could be some other complications which didn't need operation like DVTs, small draining wounds, or one dislocation which was closely reduced. So all these complications, including death, right? So primary endpoint, if you look at this, 8% were with hemiarthroplasty groups. If you look at just dislocation, 4.7%. So I don't know where Chandan got 22% dislocation rates. Even in these huge trials, 4.7% dislocations if you are doing THR, and still 2.4 dislocations if you're doing hemi. So hemi is not that innocent as you actually think. Function, even they themselves are admitting that moderately improved function in a THR group. The mortality was same. So you're not killing any more person by doing a THR. But there were some more serious side effects which occur in THR group compared to a hemi. And that is expected. If you do a slightly bigger operation, you will run into a slightly bigger complication rates. So what we need to do is to stratify, pick up the winners who are going to do better. So for that, you need to have a surgeon. And Chandan very elaborately said that if you are a surgeon working in periphery, trauma surgeon, sometimes you do hemis, go ahead and do a hemi. No arguments with that. So if you're a surgeon who does THR and this patient comes to you, some of these patients you are very nicely to do a THR in the setting. So the same surgeon, he might be going to some other place in a very remote place, is better off doing a hemi and not doing a THR. So in his own setting, the same surgeon might do a THR, the same surgeon in a different setting might do a hemi. You choose your patient. That's very important. Choose your patient very well. Okay. That's important. And that's how we are going to focus on. So you need to be able to measure somewhere which patient I want to do a THR. Do we have measuring tools? We didn't have it before, but now we have. So what we look at is the functional activity. Of course, I can keep on classifying as to how you achieve the functional activity. Then is the expected bone stock. This again, we can look at our X-rays and in general about a patient expect what bone stock could be. We expected longevity. This is something again we need to expect. Now Chandan said that we people are living at around 70, 75. Remember, you are taking infant mortality also into that. We have a huge infant mortality. If you take away people who have lived up to 50, the chances of them living to 85 is very high. So people who have already lived about 50, which is the patient who is going to come to you with neck femur, his chances of living longer is very high. So forget about average expectancy, look at expectancy of these patients who are coming to you. Then look at the ASA grades. If you have ASA 3 and 4, very well, go over and do a hemiarthroplasty. But if you have ASA 1 and 2, and some of these patients are, you need to be offering them something better. And of course, you can look at their body reserves and other comorbidities. So now let's look at the literature. So this is a, Mohit Bhandari group, again, one of the meta-analysis group. And they actually found, if you look at short term, which Chandan also mentioned that you need to look a bit longer. Short term, you will not find much difference between any of these two groups. Not even with mortality, not with dislocation in this group. Okay. But if you look at the other meta-analysis which came from in the core from North America, clearly THA was scoring over the hemiarthroplasty. So, I can keep on going with this. This is the Chinese article from Feng Wang. Again, they looked at many articles and again, they said bipolar hemiarthroplasty is safer, but the results are better with THR bipolar will have erosions from 5 to 7 years and will start having painful. So they were very clear in this. This is where it's in. So despite higher dislocations, the bipolar was weaker compared to a THR in their trials, right? We agree there's a higher dislocation rates. Why does this happen? Because these patients never had the chance to become tight. They never had arthritis. So they are lack soft tissues, no fibrosis. They had very good range of movement. And this is immediately after your surgery, they're going to go back to have a very good range of movement. And they're slightly more active compared to a standard trochanteric fracture. Do we have a solution to this problem? If we can solve, then the chances of you offering THR increases. So we need to solve. One solution would be a bipolar. Okay, dual mobility hips. So do we have an evidence? And yes, here is an evidence. Again, an article from one of the Korean journals from the young Hatcha groups. So they are clearly telling us that if you do dual mobility, it is so strong, the stability is even better than actually a hemiarthroplasty. So if you do dual mobility, then you get very good stability. Again, another article which is clearly telling us of all the things, dual mobility has the best stability. Now, if you have a fracture, do we need to offer dual mobility to everybody? Now, that's the answer. The question is no. We can sit with this patient, find out the vertical offset, find out the horizontal offset, choose your approach very well, restore normal biomechanics. You really don't need to see. If you see the x-rays, this one on the right side and the left side, they almost look as if they're template of each other. So if you can reproduce these things and you're a good arthroplasty surgeon, you can go ahead and do arthroplasty for this. Now, look at the modern literature. What is it telling us? Is dislocation a problem? If you look at this literature and look at the last concluding slides, no, dislocation is not an issue at all in these ones. They had a problem with periprosthetic fractures and something similar like infections, but that will happen in both groups. So no issue with actually dislocations. But believe me, dislocation is slightly higher in case of THR. So what can we do? One was dual mobility. Second is approach. Clearly, the anterolateral or direct anterior approach is scoring in this aspect over a posterior approach. But you don't need to change your approach. If you're a posterior approacher person, stick to it and close the capsule very meticulously. Spend time there. So if you close it very well, you will reach almost the same level as an anterior approacher. So the indications, I think, independently mobile patient, no cognitive dysfunctions, as Chandan was elaborating in a very this way. Chronic renal failure. Some patients have chronic. And why do we say that? Okay, you want a hemi, you want a quick one. No, their acetabular cartilage will erode very rapidly. So offer them THR rather than a hemi, unless they're dialysis and they won't last for 6 months. But if they are well tuned into their dialysis, and if they come with a neck femur fracture, offer them THR because their acetabulum will erode in no time. In 4 to 6 months, the acetabulum will erode. That's how this is our experience too. And if they're steroid users, osteoporotic, pathological fractures, they'll break many more things. So I think in concluding, I won't take 70 as a mark, but as 75. So below 75, over 75, sedentary, less invasive procedure, cemented stem would be the way to go forward. Do a bipolar hemiarthroplasty or a unipolar, really not my concern. But if you are above 75, physiologically active, pre-existing arthritis, some other problems which may need directly to the arthritis or something like that, or trauma, a better functional outcomes. Again, a cemented stem using a THR would be a better option. And if you are doing a THR, choose an approach like an anterolateral, which will give you better stability. Try and use larger heads if you are posterior approach. Try and use dual mobility if you're a posterior approach. You will get improved functional scores, slightly at a higher risk of dislocation, and slightly at a higher risk of limb length discrepancy also. Because what happens is you are loose, you try to tighten up. So I think these are the references I have taken. So I'll skip. This was a hemiarthroplasty done for this patient, subluxated, because you missed the osteophytes on the inferior brim. This had to be revised. These are the nice guidelines, and they are themselves recommending that you need to fix some fractures. You need to do hemiarthroplasty for some, but quite a few of them you need to do THR also. If you're active, no other walking age you are using, and no other serious comorbidities, and you are expected to live longer. These are the patients who will do much better with it. This is nice guideline. You see, these are UK guidelines and very well reputed guidelines. So now you choose your patient. Are you looking at a 70-year-old or you're looking at a 70-year young? So if Bapada had a fracture, would you call him an old person? He is around 70, I think. So would you call him old? So what does he need? He needs something THR, I think. Okay, thank you. Sorry? Abner, dual mobility, you are too active.
Thank you, both of you. I think you had an excellent debate. Everybody was fiery, brilliant, and to the point. It's a debate, and both of them have emphasized their side of the case properly.
So the rebuttal for 1 minute for Chandan.
Yes.
Yes, Rakesh.
So whenever you see any debate, as you see in the slide, it's always noise pollution. Everybody will speak up, shout, and hardly there is any conclusion. So I do agree that THR is a surgery of choice in these categories. If you have associated degenerative problems in the acetabulum, healthy and very active patients with minimum comorbidity, life expectancy is 15 years plus, and definitely monetary factor is not issue because Rakesh was telling about dual mobility. For your information, it is no less than 1 lakh. So it's a monetary issue that is concerned. Now, same problem may have multiple answers. So suppose this predominantly medial condylar, medial compartmental osteoarthritis. Rakesh will definitely vouch for, say, unicondylar, UKR, and a poor person like me will definitely jump towards total knee. And you have other options also. So HTO. Now, uni knee, if the predominantly medial compartment is involved, why not to replace only the medial compartment? Why TKR? Valid point for the sake of debate. But in neck femur fracture, acetabulum is unaffected and virgin, then why not hemiarthroplasty? That is my question. Because at this age of 70 plus, it is going to last for 13 years at least, and mortality after 1 year of neck femur, it is 30%. Consider everything. And this is Shastro Sati rate. And you can see hemiarthroplasty and total hip. It is quite a big difference in rate, more than 35,000. Is it a factor of propagation? And I agree, but this is a video, the sound of National will be happy that after neck femur fracture, we'll expect that our senior people will at least comfortably walk and perform their regular activities. There is no harm in that. Think optimistic. And why hemi to choose? And in hemi, moderate bipolar hemiarthroplasty, modular bipolar hemiarthroplasty definitely will be the choice. Use a stem like shoulder platform stem, a stem of standard taper for future revision if it is needed. No fight between hemi and total hip at the age of 70. The guidelines are clear. Hemiarthroplasty is a clearly natural choice for obvious reason in majority, and THR has its own share in active younger elderly population. And hope we could make our points clear. And I think the audience who thought that our 40 years of friendship with Rakesh will end up in something like this debate, I think possibly they are mistaken. So nothing will happen like this. We'll end.
Yes.
And hope we could make our points clear. Thank you.
30 seconds for Rakesh.
I think I've already told that I actually agree with Chandan in most of the points. So there's not really a debate here. We could probably answer questions from the hall and use whatever time is left.
Any question from the audience? Yes, Papa bolo.
তুমি কি করাবে এটা বলো আগে।
না লাইট ওটা অন আছে, অন করে দাও।
হ্যালো হ্যালো। আমরা বড় হয়েছি অস্টিন মুল করতে। ছোটবেলায় অস্টিন মুল করতাম, টমসন করতাম সিমেন্টেড। We saw those patients 70 years এর উপরে করতাম বা 65 এও করতাম, এবং আমরা দেখি তারা 10-15 বছর থাকতো এবং ব্যথাও হতো, চলতো। নাও কামিং নেক্সট আমরা এলাম বাইপোলারে কিছুদিন করতাম, বাইপোলারে দেখে দেখে পরে এলাম টিএইচআর। অটোমেটিক্যালি আস্তে আস্তে আমরা ইমপ্রুভ করছি, কিন্তু প্রবলেম হচ্ছে রুরাল এরিয়াতে এবং সেন্ট্রাল এরিয়াতে মানিটারি প্রফিটের কথা বলতে bipolar process is the দাম হচ্ছে 35,000, ফিক্সড বাইপোলারের দাম হচ্ছে 7,000 টাকা। তা আমি ফিক্সড বাইপোলারও করতে পারি। If monetary concern is there, আমি জানি that there are more advantages in bipolar modular than fixed bipolar, but still we can do a fixed bipolar. যেখানে আমার মানি কনস্ট্রেইন যদি থাকে, তা আমি 5 times less টাকা দিয়ে আমি একটা মডিউলার বাইপোলার ফিক্সড বাইপোলার করতে পারি।
No, that is true.
Practically, আমার মনে হয় everything depends upon the monetary factor also. Not only the whatever you are saying, the other things are okay, that more of
Social factors, monetary factors, and need of the patient.
আমি আপনার কোয়েশ্চেনটা ক্লিয়ার করে দিই। There are cases which will be clear cut group of hemiarthroplasty. You go ahead with unipolar also, no problem. There are clear cut cases who will require THR. For those, you do whatever type of THR you can. The intermediate case where you're not able to make up your mind, use a bipolar with a stem which could be converted to THR if required. That's the only message I would like to give to your answers.
So there
That way you won't go wrong.
I hope Dr. Akbud also will agree. The best leader, whatever you have documents you have produced, it's the only to be done by arthroplasty surgeons. That's gives the best results. Those who do regular, not occasionally 1, 2, 3, 4.
Same like Elizabeth.
Right, okay. So I think for juniors, this passage for the whole message should be very clear. That if you are really only arthroplasty surgeon, mainly arthroplasty surgeon, do significant number, then it's good for do the THR. Otherwise, better I hope we should be cautious about better refer to serious those who are arthroplasty guys or bipolar. That's my.
I think we are not talking about the expertise. Who is going to be who is going to do the heavy or who is going to be the THR. I think the clear-cut message should be given to the audience, whether at 70, whether you are going to do the bipolar or the THA. Indota tomar ki mot?
The human being is a strange person, and no two human beings are identical. There will be some with 70 who requires a THR and are comfortable with it and live very well with it. There are some who require the hemiarthroplasty, and the hemiarthroplasty will be also there. The question comes from those who are going to finance it is a problem, because what the children want and what the family want is another big issue. Some want to spend, some don't want to spend, some want a quick recovery, very quick recovery, and everyone wants least complications. So this is a debate of that sort. It's a debate which in every orthopedic surgeon's mind, and which is there in every 70-year-old with a fractured neck femur's mind. It is how you place it is the real issue. What are you going to do? There are points in favor of both sides. There are points against both sides. But ultimately, it's the orthopedic surgeon who convinces the patient and the patient party as to what he is going to do. So that was the whole center of the debate.
I think after every debate, there should be a vote.
First, I want to congratulate both of them.
Yes.
I think we've seen some fantastic, both sides fantastic.
You
can't fault any of them. They had their points, they chose the right ones, and they chose to oppose each other. Because Chandan and Rakesh are classmates, I believe. So it's an excellent debate. And that's the whole issue of it. What you do is ultimately your choice and how you read your patient.
So just for the sake of the ritual.
I think vote এইভাবে হওয়া উচিত না. Would anybody here do THR for few fracture neck femurs? In general, so I have accepted that. You shouldn't do it for everybody.
We can think about total hip replacement for elderly, whose cognitive functions are okay, demand is high, so social and family support is optimum, and community ambulatory with very low comorbid index and without other major medical problem. And of course, but in this category, I think 25 to 30% elderly people will fall in this category. But rest 65 to 75%, they will have some of the problems. We cannot think about total hip replacement. And another thing, what Bapada raised the issue of finances, and also Chandanda raised the issues. But all of us know some of the cost of some of the hemis are at par with total, if not more, for some modern implants. That's also an issue. What Rajputta was trying to say the modern hemis, the cost of the modern hemis are no less. That is also an issue. That should.
So all I asked was, should Cheteshwar Pujara play cricket or not? Because he can't play T20 and one-day matches. Should he be allowed to play cricket or not?
I think always when both are in the same team, whenever there is a debate, this is a ritual that there is a vote. Okay, nobody is defeated, because before the start of the debate, I had a very important meeting between Rakesh and me, that who is going to win. Chandan is the winner always, because he is currently the president. So no way me and Rakesh is going to fight. So at the end of the discussion, suppose in this hall, be very honest to your decision, that at a 70 years of race neck femur fracture, who is for the hemis? না পরে আসছি, দিনেশ তোর কাছে আসছি। Who is for the hemi at 70?
No. So I think the debate,
এত কিছু বলেই দিয়েছি, প্রেজেন্ট প্রোফাইল মানে 70 তে
debate is, would you do hemi for all or would you do total hip for some? That's the debate.
No. Question is that দেখো, whether at 70 most of the people will be having something. So who is না আমরা তো সবাই যারা প্র্যাকটিস করি, সবাই তো 70 years এ হেমি বা টোটাল হিপ কেউ না কেউ করেছি। Who has done more hemis and who has done more THRs? More hemis কারা?
More heavies are more in number.
So I think these hands are all risen only because Chandan is the president.
But
so Rakesh, so whatever we have discussed before. So Rakesh, whatever you have discussed, we have discussed before that Chandan should be the winner. I think both are winner, because this debate will be going on for another 20 years. So I think this was a good presentation from both the sides. Into your final comment.
As I said before, this was a great debate. I enjoyed it. I think everyone did. And that's the whole purpose of this entire exchange. We learned some things, we learned a lot, but we will make our own decisions when we face a 70-year-old with a fractured neck femur tomorrow.
Thank you all for this nice debate. I learned so many things from you also, but I must tell two things first. Many of our pupils in the rural areas have not their commode type of. First, ensure that there is at least a chair commode before doing any prosthesis, maybe hemi or maybe otherwise there will be. And at the same time, have a thorough discussion with the patient and their guardians about the subsequent care. Then you can avoid many problems and you will be successful. And scientific things should not be just by the voting only. I disagree with you.
Thank you. I think thank you. You take a judicial discussion. I think after the medical legal aspect of that thing, we all agree that you discuss with the patient, you take your right decision, because totally is always there is a high chance of dislocation when what Tapanda is referring to, whether you use the commode, whether you have to cross-legged, all these issues are there. I think you discuss and take the decision right. Thank you.
Thank you to all the speakers and the panelists. And now we move ahead to the arthroscopy session.
Thank you, Chandan Pathak sir and Rakesh Rajput sir, for this very fruitful debate session. Now, I welcome you all to our arthroscopy session of this WBOACON 2023. So, I would like to invite Dr. Shanandu Shamandu sir and Devapi Rai sir to chair this session.
Good afternoon. Yeah, good afternoon and welcome to the arthroscopy session. So I would not waste further time because we are already running late. So I'd like to call upon the first speaker, Dr. Deep Chakraborty. Deep Asha.
Good afternoon, everyone. There was a really very interesting debate by Dr. Rajput sir and Chandan Pathak sir. I wish there was a third person who wanted to fix it. Let's see if it comes out in the future. Anyway, my name is Dr. Deep, and I will be discussing the topic knee arthroscopy portals and diagnostic grounds.
Think you change the slides, please.
Actually, here it's coming that one. Okay, there are a lot of indications for knee arthroscopy, chiefly being ligament reconstruction, meniscal repair, meniscectomy, synovial biopsy, chondroplasties, all this, and incisional drainage. The only thing you should know as a beginner to how to learn arthroscopy is try and learn triangulations very fast. We have skill labs. We have to go and try out on patients only when you are little skilled with both the 30 and 70-degree scopes. Okay, I started doing arthroscopy because I'm a good gamer, so I caught it up a little faster. On the basics, the position is very important. There are two majority of the ways that can be the knee dangling or in a TKR position or on the table. Supine position is very important for an arthroscopy to be carried out. It gives us the ability to flex the knee completely. Tunic is always essential, and a leg holder is always should be standby to give a varus or valgus stress, so that we can also have a figure of 4 position. We like to do our arthroscopy in on the table in a TKR position because it requires less number of assistants, and almost the vision is almost better and clearer in this way. Basic instrument sets you should have when setup which always has 30 and 70 scopes, but we have learned our way and we can do most of our arthroscopy with 30-degree scopes alone. Although there is an option of 90-degree radio frequency ablator that can be used, but you can use and not use depending on your choice. Coming to the basics of the portal, you should always remember whenever you're doing arthroscopy, there might be some patients who are thin, there might be some patients who are little fat. So try and go ahead and always have the bony surface markings done, including the patella, tibial, tubercle, the joint line, medial and lateral joint line, the patella tendon, and the proximal head of the fibula. You should also understand about how a vertical stab incision and how a horizontal stab incision works. But whenever you're doing a vertical stab incision, you'll always get a good play in the superior inferior direction, and medial lateral direction will be restricted. And horizontal is exactly the opposite. Will good play in the medial lateral direction, and upper and superior inferior direction play would be limited. So you should know how to use these incisions to your advantage whenever it comes to the time. Speaking about inflow fluid, normally normal saline, ringer, lactate, glycine, all have been used, and there has been a lot of debate about it, but universally ringer lactate has been accepted and is more physiological to body fluid. Now coming to the main talk, common arthroscopy portals. There are 4 main arthroscopy portals which can be used to address almost all the pathologies in the knee: anterolateral, anteromedial, superolateral, and posteromedial. Coming to each one in detail. So anterolateral portal is around 1 centimeter above the joint line, 1 centimeter lateral, and 1 centimeter inferior to patella. All this has been described in theory, but we like to go around 0.5 centimeter below and lateral to the inferior pole of the patella. Anterolateral portal has some limitations. As such, the visualization of anterior horn of lateral meniscus is deficient. Posterior horn of middle meniscus is also not very clearly seen. Okay. there are some precautions that has to be taken. The portal should not be too near the joint line. That means it should not be too inferior, which can damage the anterior horn or lateral meniscus, and it can also make your maneuverability very difficult. Too superior will also make the femoral condyle on the way, so that you are having difficulty seeing the posterior structures. Coming to anteromedial portal, it is 1 centimeter medial to the joint line, 1 centimeter inferior, and 1 centimeter medial to the patella tendon. This is mostly a principally a working portal. Like in this video, we are seeing we should the tip of that. First, we use a spinal needle, so that the spinal needle points exactly through the posterior horn of the middle meniscus. This is the way how we approach, so that we have a good angle and the incision should be placed there. Coming to the posterior medial portal, this is 1 centimeter. There are numerous ways how you can reach and connect this portal. It is primarily 1 centimeter above the posterior medial joint line, which is in line in the posterior border of the medial femoral condyle. There is a soft spot between the semimembranosus, medial gastroarcade, MCL. On the contrary, we can also reach the same spot with 2.5 centimeter below and posterior to the medial epicondyle. The structures at risk will be saphenous vein and nerve. This can be addressed with trans illumination view after you have achieved a anterolateral portal, and the light source light can be seen through the skin, and you can make a incision depending just safeguarding the other neurovascular structures. This is the way how we actually go around and make a posteromedial portal. Using a modified Gilchrist view, you can go all the way through between the PCL and the medial femoral condyle to the posterior compartment, and we can and then we can have a knife and we can go ahead and make a cannula. Posterolateral portal has also been described, but we don't need it so much. It is just 1 centimeter above the joint line between the LCL and the biceps tendon. It helps us to visualize the lateral horn of PCL. Coming to the transeptal portal, although this is not very commonly used, but for bony avulsions of the PCL and for the complete synovectomies of the posterior compartment, this is a very good portal that needs to be learned. Septum is as you can see in this MRI, a septum is a triangular septum which is divide the posterior compartment of the knee into posteromedial and posterolateral segment. And this part, you can see the posteromedial segment is little wider and bigger than the posterolateral segment. This is how it should be addressed with the scope in the anterolateral and first a posterolateral, both the posteromedial and the posterolateral portals have to be made. Only then we can come ahead and go and do the transeptal approach. There's a small video which is showing the video from the posteromedial portal and how we come, the shaver is coming from the posterolateral portal and is shaving up the synovial folds and the fat tissue so that we can get a very good view. There's a very good view you can actually see through the condyles. There are other named portals, but they are not very routinely done also, but we can use the high anteromedial and high anterolateral portal to do all the PCLs that you come across. There is also a superolateral portal.
I think your time is over. Already you have crossed 1 minute or so.
I'll just finish by, there is another superomedial portal that is just necessary to the patellar tracking and to complete the synovectomies. Okay, sir, I'll just finish this stuff.
For discussion, we can have a couple of questions. So, you have anything to say, Rajesh?
How do you mark your portal in obese patient?
Sir, it is a little difficult, but we give a lot of time to identify the bony landmarks in the first. If we get the bony landmarks right, then we are happy. But we always go in and again keep doing it, sir, as it goes.
Basically, in obese patient, the marking the portals are very, very difficult.
That's right.
Primarily, the anterolateral portal which you mark, that is the most important one. Otherwise, all the portals are more or less done by the needling technique.
Everything, it's little difficult, but we have to spend little time.
Very difficult. Very good. Excellent presentation. Thank you.
Very good. Excellent. So, you can call upon the next speaker.
Next speaker, I think Dr. Obhijit Sher, ACL reconstruction tips and tricks.
Good afternoon, everyone. So my today's topic of discussion is ACL reconstruction tips and tricks. So basically, there are two kind of ACL deficient knees. One group is copper and another group is non-copper. Copper group means those patient with ACL, torn ACL, those who does not show the signs of instability, and the non-coppers, they has torn ACL and they shows the signs of instability. So when we plan for ACL reconstruction, the key of the successful ACL reconstruction is proper patient selection. So if the patient has only pain, isolated ACL tear, and he or she does not have any instability, so don't operate upon these patients. If the patient has instability, we must operate. If the patient has ACL tear and along with that they have meniscus or cartilage injury, then we should operate. And another very important thing is when we deal with chronic ACL tear, most of the patients will have this quadriceps wasting. So we need to rehabilitate this patient. Otherwise, we have difficulty in post-operative period. So graft thickness consideration is another important thing in ACL reconstruction. Like in this study, we can see that minimum 8 mm thick graft should be used. If we use lesser thickness of graft, then there is high chance of failure. And if we increase the graft thickness, there is increment of 0.5 mm thickness graft. There is decrease in the incidence of failure rate, but the study does not show any benefit of increasing the graft thickness more than 10 mm. So our graft thickness of choice will be 8 to 10 mm. So the diagnostic round is very important. Sometimes in hurry, what we do, we harvest the graft before doing any diagnostic arthroscopy. But if we have any slightest of doubt in our mind, we must go for diagnostic round. There are two kinds of ACL reconstruction. One is anatomical reconstruction, another is transtibial reconstruction. So this transtibial reconstruction basically is a history now. So what we do in transtibial reconstruction, we drill this tibial tunnel first, and followed by through this tibial tunnel, we drill the femoral tunnel. So in this type of reconstruction, basically what happens, what happens with this reconstruction, the femoral tunnel is very vertical. So we achieve anteroposterior stability, but we cannot achieve rotational stability. So basically, this is transtibial technique is basically a history now. So another technique is anatomical reconstruction or transportal reconstruction. In this technique, we drill the tibial and femoral tunnel independently, and we drill this femoral tunnel with this accessory anteromedial portal. While creating this anteromedial portal, we should keep in mind that this portal should be as low as possible and also as medial as possible, but we should not hurt the medial femoral condyle, and it should the projection should be towards the femoral footprint. Then the preparation of the femoral footprint, we should prepare the femoral footprint properly. Of course, the remnant preservation technique is ideal, but we should not do this remnant preservation technique at the cost of improper tunnel placement of the femoral tunnel. Then we create the femoral tunnel. So there are two techniques of creating femoral tunnel. One is freehand technique. In this technique, we put our 4 mm drill bit at the center of femoral footprint. Then we drill with this 4 mm, pass this bead pin and 4 mm drill bit, followed by the 8 or 9 mm drill bit, whatever is chosen by the graft. And we use this shiver blade. This shiver blade basically serves two purposes. One, it drains this bony debris, and it also protects the PCL. And another technique of this femoral tunnel creation is with the help of offset guide. Those surgeons who are doing their ACL reconstruction in the initial phase, I would suggest to use this offset guide. The offset size is decided by the graft thickness by 2 + 2 by this formula. Suppose I have 8 mm graft, then I will use 6 mm offset. And how to calculate this femoral loop endobutton? The loop size is calculated by subtracting this tunnel size minus graft in the tunnel. Suppose the tunnel length is 40 mm and the graft in the tunnel would be 20 mm. Preferably, we want to keep 20 mm graft in the tunnel, though 15 mm is also sufficient. So our loop size will be 20 mm, and we do 10 mm over drilling for flipping of the endobutton. The creation of the tibial tunnel is followed by the femoral tunnel creation, and we use constant bony landmark of medial tibial spine and its drop point. After creating tibial tunnel, we pass the graft. Here, one important thing is we mark the graft at 20 mm, and then we tension the graft. So here is a good technique of tensioning the graft. We basically call it Rajiv Raman sir's technique, because Rajiv Raman sir has popularized this technique in eastern part of this country. So those surgeons who have back issues can adopt this technique for tensioning the graft. And for, after that, we fix the graft in the tibia with interference screw. So my take-home message will be proper patient selection is key of successful ACL reconstruction. Graft thickness should be 8 to 10 mm. It should not be less than 8 or should not be more than 10. Diagnostic round should be a routine, and remnant preservation is the ideal technique, but it should not be at the cost of improper tunnel placement. Thank you.
Thank you. We are running short of time, so I would like to ask only one question. Anyone? Dr. Nandu, you have anything to ask? Rajiv?
Nice presentation, Abhijit.
Thank you.
So, how do you plan your tibia? What are your landmark for your tibial tunnel?
So tibial tunnel, we have 3 landmarks. One is medial tibial spine drop point. We come along the medial tibial spine and go just lateral to that. Another is we come 6 mm anterior to the PCL, and another is just posterior to the anterior horn of the lateral meniscus. These 3 landmarks are followed, but we usually follow this medial tibial spine drop point as it's a constant landmark. Thank you.
Then Dr. Lebu Sarkar, he is there, yeah. MPFL reconstruction, how to do it.
Good evening, everyone. So my topic of presentation is MPFL reconstruction, how to do it. There are several methods of MPFL reconstruction, but this is one of the method. Before coming to the surgical procedure, here is some clinical features and some overview. First, anatomy of MPFL. This originates from triangular space between adductor tubercle, medial femoral condyle, and gastrocnemius tubercle. Insertion, a broad insertion, 20 to 30 millimeters, and onto the supromedial aspect of the patella. Function, it provides resistance to the patella during early knee flexion, like 0 to 30 degrees. It acts as maintaining proper, appropriate patellar tracking within trochlear group, providing 50 to 60% of restraining force against lateral patellar displacement. Clinical relevance. During lateral patellar dislocation, MPFL ruptures in more than 90% in the first time, and almost 100% rupture occur in repeated dislocation. Dislocation in mainly occur in flexed knees with valgus and torsional force. And here, 27 years old male, and this is the MRI showing the MPFL, torn MPFL. And this is the surgical video. First, draw a landmark and examination under anesthesia before taking in any incision. There is excessive lateral movement, and this indicates the MPFL tone, and we marking the medial and lateral side and upper and lower pole of the patella, and marked in the upper 1/3 of the patella. Semitendinosus graft harvested in standard fashion, and 1 centimeter incision make in medial upper 1/3 of the patella. Then patella was exposed and diagnostic arthroscopic round was performed to note any concomitant lesion and the patellar tracking. Mark the gap in 1 centimeter distance and semitendinosus graft prepared. And then with fluoroscopic guidance, 2 suture anchor 2.7 suture anchor was placed in medial portion of the patella in 1 centimeter apart in 1 centimeter, and the stability checked. Then semitendinosus gap is fixed and augmented, and there make a sharp passage between the retinaculum and an adductor tubercle. There is 1 centimeter long incision make, and there is another suture anchor fixed in adductor tubercle under CM guidance. And this is the Bloomstead nail and the posterior cortex of the femur, and the shuttle point is 2 centimeter above posterior cortical line and the Bloomstead line. This is the shuttle point. The direction of the drill is upwards, right, upwards or anterior. And the graft is then passed between layer 2 and 3. Before fixation and before tightening, there is isometric tensioning was done. And lastly, fixed a graft in 30-degree angle of knee flexion. And the wound closed. And mobility of the patellar change. This is mobile patella, but non-over-tensed patella. And this is normal. Then another diagnostic arthroscopic round found. The normal tracking of the patella. So take home message, proper case selection is important for outcome, and always perform diagnostic arthroscopy for concomitant pathology. Adequate knowledge and proper techniques is also important. And there is no violation of articular surface, and isometric tension is also important for adequate outcome. Thank you.
Thank you, Dr. Sarkar, for your excellent demonstration. Any question, any clarification from the floor? Rajiv, কিছু বলবি? ভালো হয়েছে, খুব ভালো, থ্যাংক ইউ। So I think next presentation is Dr. Bari is presenting. Yes, Wasim.
Good afternoon, everybody. Now I'm presenting the posterior cruciate ligament reconstruction. My technique is single band reconstruction with tense-tibial and endobottom technique. General consideration. PCL is the largest and strongest ligament of the knee joint, and it also important play role in the posterior stabilizer. It is 1.2 to 2 times stronger than ACL. Isolated injury is rarely occurred, and it isolated combined grade 3 injury required surgery. It clinically assessed by posterior sex sign, Latchman grade 3, and posterior Dwyer test. Radiological stress view and confirmed by MRI. This is the MRI view showing the normal and PCL injury. Anesthesia and patient positioning. We normally do under anesthesia, spinal anesthesia and supine position, and leg is hanging over the end of the table, and another leg is placed in the abduction position with stirrup. And with PCL injury examined under anesthesia, a tourniquet applied around the high of the thigh. This is the patient positioning in our setup. Now diagnostic arthroscopy. A quick diagnostic arthroscopy is done on the operating knee, and PCL injury lesion is high anterolateral portal is a viewing portal. There is floppy ACL sign in PCL injury. Other port used in PCL reconstruction, high anteromedial and a high posteromedial. These are port used for PCL reconstruction: anterolateral, anteromedial, and posteromedial portal. We normally use in 30-degree scope, but now people are coming with 70-degree scope for better visualization of PCL reconstruction. Graft harvestment for PCL reconstruction. We normally use the peroneus longus, a 2 cm incision given from posterior part of the lateral malleus. Peroneus tendon is undefined. Peroneus longus tendon is tendinous and situated in the posterior superior part than the peroneus longus. This is the incision for peroneus longus harvestment. This is short video for peroneus longus. One to 2 centimeter posterior to the lateral malleus incision is made. Now I'm go to next slide. Then tibial tunnel preparation. The scope is placed in anterolateral portal, and by anteromedial portal, working portal. We done the working portal, and guide is placed 10 to 15 millimeter below the joint line of the posterior PCL facet. Deal is oriented at 60 degree to avoid killer turn. More perpendicular it killer turn. So we drill is set at 60 degree. Simultaneous use of arthroscope and CM is helpful at this stage. And last stage, desired imaging is done. Adjust drill guide first is 1 centimeter less and tap 1 centimeter, prevent last by 1 centimeter tapping. Exact exit point physical is posteriorly, while tapping is placed curate through posteromedial portal to prevent the vital structure. Guide drill pin exit observed arthroscopically and we confirm by image intensifier. These are the picture of killer turn. Then femoral socket preparation. During femoral turn, scope is anteroportal and femoral guide jig through the anteromedial portal. Outside the femoral condyle, exit point in between the articular cartilage and femoral epicondyle. The femoral psychometric point 8 millimeter proximal to the femoral articular college. For the right knee, it is 1 AM o'clock and left knee 11 o'clock. Femoral foot is prepared by severs or curate or sometimes use the RF radio frequency ablation. Microfracture is sometimes made with owl and drill guide pin is inserted through starting point and drilling done inside out. The drill pass throughout, then 4 mm carotid drill done through the another drill. Then drill socket is made desired level for endomatum. When used in fixed loop 20, then we drill 30 to 35 mm up to the lateral cortex. Then fiber wire pass through the drill pin and on in and out front, then femoral condyle, another end prior to the knee through the anteromedial portal. Then graft is passed through the guide fiber wire. After graft is passed and flipped, maintain the graft by tensioning 10 cycling. Secure the graft with interference screws and tibial outside. If fixation is not secure, then post fixation, backup post fixation is indicated. Finally, check by scope placement of graft, tension graft, and floppy SL sign is gone. Then by image is where we confirm our screw position.
Your time is over, Dr. Bari.
Yes, sir. This is a short video.
So I think we can start the discussion.
Yes, sir.
We can have a couple of questions, that's all.
Yes, sir.
I think you have nicely elaborated during your presentation what are the landmarks and all these issues. So I think when doing the PCL, you have to take care two issues. One is that you are really at least minimum 15 millimeter down from the tibial margin.
Yes, sir.
And you take care of the posterior vessels. I think that was the take home. Anything to add on? Abhijit, Rajiv, or those who are doing the arthroscopy?
Rajiv, any comments?
Got the killer tunnel. Now what we do, once we pass the graft to the femoral tunnel and then take it reverse to the tibial tunnel. By that way, you are avoiding the killer tunnel. So
Yes.
pass the graft to the femur and then take it reversely back from the tibial tunnel. So by that way, you don't need to apply so much of force, because what happens even after putting your switching rod, sometimes it's very difficult to pull the graft if it's very tight.
Okay.
Thank you, Dr. Bari. Thank you.
Thank
so
you.
much.
Thank you.
So I now request Dr. Saurabh Das for his talk on the functional outcome of ACL reconstruction by remnant preservation. Dr. Saurabh is there, no? Yes. ওইদিকে।
Very good afternoon to my respected teachers and esteemed colleagues. My topic of presentation today would be functional outcome of ACL reconstruction by the remnant preservation techniques. I am Dr. Shurab Das, second year PGT from KFC Medical College and Hospital. So as the scope of sport medicine has grown tremendously in recent years, so has awareness regarding the ACL tear and has increased, and the ACL reconstruction has become one of the most frequently performed orthopedic surgeries. So what things we have to keep in mind are the structural integrity, proprioception, healing issues, and the rupture of reconstructed ACL for a successful ACL reconstruction. Then the sports person can be back to their daily sports activities earlier. So the study was conducted from April 2014 to March 2020. We had 160 patients, and of them 80 patients underwent remnant preservation technique, and the rest had concomitant meniscus and other ligamental injury and or did not have any ACL remnant. Or in all of the patients, the contralateral knee was unaffected. So we started with the standard arthroscopy portals of the knee. Diagnostic arthroscopy was done mainly to detect the presence of the ACL remnant. The semitendinosus and semigracilis graft was harvested and prepared conventionally. The tibial and femoral tunnels made, and the graft passed in very close proximity of the ACL remnant, so that the final position of the graft lies in contact with the ACL remnant. So this is how we did. We first marked the surface, marked the patella, the insertion of the quadriceps tendon, and the tibial tuberosity, and the medial and lateral joint lines, and made the anterolateral portals. And this is the ACL remnant. This is an example of the ACL remnant classified as per Crane et al. So this is the ACL remnant. Then this is how we harvested the graft. Then the graft was prepared, and finally the tibial tunnel was done. This is an example of a reconstructed graft. So the red arrow indicates the ACL remnant, and the yellow arrow indicates the graft that is placed, and as it is seen, it is clearly remaining in close contact with the remnant. So the femoral side graft was fixed with a fixed endobottom loop, and the tibial side graft was fixed with bioabsorbable interference screw. So the cases were followed up to the period of 2 years, and we evaluated the clinical outcome by Lachman test, anterior Doyer test, pivot shift test, and the range of movements of the knee. We use the International Knee Documentation Committee score, modified Cincinnati knee rating system, Tegnell-Lisholm scoring system, heel to shin, test for proprioceptive outcome. We found out the result was, out of 80, 74 patients had near total range of movement postoperatively. 5 patients had less than or equals to 15-degree lag in flexion and less than or equals to 5-degree lag in extension. One patient had 10-degree restriction in extension. Average flexion was 0 degree to 120 degree. There were no instability after primary surgery, and there were no traumatic or non-traumatic re-tear after 2 years of time. The International Knee Documentation Committee score was more than 90 in 88% of the cases, denoting minimal to no limitation in movement of the knee. And the mean AMCK-RS was 93, and Tegnell-Lisholm scoring system was 92, denoting excellent mobility of the knee. So as we can see, as it is very evident, so after 4 months, there is near total flexion of the knee, and there is no lag in extension, as it is also evident in this picture. So with proper rehabilitation, athletes return to the sports activity within a mean period of 4 to 6 months. And there were also marked increase in proprioception of the knee, inferred from the symmetry and the ability to perform the heel to shin test in relatively rapid cadence compared to the unaffected limb. So to conclude, there is a superior outcome in superior functional outcome in remnant preservation technique of the ACL reconstruction. The mobility and stability is excellent. There is faster graft healing, minimal chance of re-rupture, quick comeback to sports activity, marked increase in the proprioceptive function, and biomechanically superior outcome of the knee. To conclude, this is a video of a sports person, a gymnast to be precise, returning to sports after 6 months after the ACL reconstruction surgery. Thank you so much.
Thank you. I think this is the new concept people are coming with, the remnant preservation. Excellent presentation. Thank you very much.
Thank you, sir.
It's open for
Question,
discussion.
cut
Any
question and
questions?
check.
Question.
Proprioceptive function, have you read?
So the proprioceptive function is assessed by the heel to shin test, sir. Heel to shin test.
ठीक है, sir.
Thank you, sir.
Thank you. So now I will request Dr. Devayan Singh for his talk on the LET.
Good afternoon, everyone. So my talk is on lateral extraarticular tenodesis as an adjunct to ACL reconstruction in the pediatric, especially the adolescent population. So as we all know that LET is gaining in popularity in the adult population, but we are yet to have a very standardized and well-known technique for doing lateral extraarticular tenodesis in the pediatric population. So the rationale for this study was that age and activity at level are key risk factors for re-injury following ACL reconstruction. And ipsilateral re-injury rate in young athletic patients range from about 9 to 15%. And there's now ample evidence to back the addition of LET to ACLR in high-risk groups. We know of all the trials by the stability trial and also the review by the Santi group and all. So most studies performed in adults. So we are looking at Tanner 3 to 5, Tanner stage 3 to 5 adolescents with radiologically open physis and how to add LET in that group. So the study population that we did was 8 patients aged 14 to 17 years, 5 were males and 3 were females. And they were all involved in contact sports or pivoting activities. And they were stratified as high risk based on the presence of one or more of the following factors. There was either a presence of a grade 2+ or in some cases an explosive pivot shift on examination under anesthesia. There was a recurvatum of more than 10 degrees in some patients. A Beaton score of more than 6 was also taken as a risk factor. And a posterior tibial slope of more than 7 degrees was also considered to be a risk factor. And all patients were operated within 3 months of injury. So we did the ACL in the standard, ACL reconstruction in the standard manner. We did an examination under anesthesia and a diagnostic round. All patients demonstrated a pivot shift with significant subluxation and occasional locking when we did the EUA. The ACL was found to be nearly completely ruptured in all the patients, and 4 patients had a concomitant tear of the lateral meniscus, which were not addressed in our cases. So for the surgical steps, the ACL reconstruction was done in a normal way through the physis transfacial technique like we do in adults. In all the cases, we used ipsilateral semi-T graft, and gracilis was needed in 3 cases. And the mean graft diameter was 7.6 millimeter. In average graft diameter was 7.6 millimeter. Now transfacial tunnels were created with the tibial tunnel made at a little steeper angle so as to damage the physis a little less. And suspensory fixation with a fixed loop device was done on the femoral side. And then we started the LET procedure. So how we did the modified Lemire technique, and we modified it a bit for the open physis. So about 8 to 10 centimeter of the central band of the ITB was harvested, leaving the distal attachment at the Gardis tubercle intact. And so in pediatric population, the thickness of the ITB is a little difficult to measure. So what we did is we took the central third of the ITB, and then we passed the ITB. So there's a typing error here. We passed it deep to the LCL, and then we fixed it just proximal and posterior to the femoral attachment site of the LCL with a suture anchor. But we did a fluoroscopic evaluation to see whether we are going just above and lateral to the open physis so that we don't damage the physis. And also there's another thing that we can do is that before putting in the anchor, we can, if we haven't done the femoral fixation yet, then we can take our scope and put it in the anteromedial portal and look at the tunnel and see that we are not violating the tunnel, or we are not penetrating the tunnel while putting in the anchor. And so the early results that we have got is that in our short follow-up, this is a bit longer than this paper was written. This PPT was made like 4 months ago. So this is now about 10 months follow-up. Average follow-up of 6.2 months. We found that no patient had any significant loss of ROM, which rules out the constraint. So we are concerned about over-constraining the knee joint in these patients if we add LET to ACL reconstruction. But that was not found in any of the patients. There was no significant limb length discrepancy. and 3 patients have achieved full return to sports. Actually, this is now about 6 patients have returned to almost full normal activities and sports, and all patients have shown an improvement in the significant improvement in the IKDC score. So limitations would be, this is a very small sample size, very short study. We need a longer follow-up. And we use the transphysial technique. We need to adapt our technique to physial sparing techniques for even younger patients. And because we did this study in a government hospital, so their follow-up was not up to the mark and rehab monitoring was not also very good. So that would be all. Thank you.
Thank you for your excellent presentation, because most of the time we are doing for the adult patient, also we are doing for the pediatric. It's a nice job done.
Yes.
Any question from the floor? অঞ্জন কিছু জিজ্ঞেস করবি? রাজীব কিছু বলবি?
What about lateral knee pain in modified lamina? So how do you what is lamina and what is modified lamina? And what about the incidence of the lateral knee pain?
Sir, I'm not sure about the actual original technique by Lamar. I think he passed it above the LCL and now we are doing it under the LCL. But we didn't find any over constraining, so the range of motion was fine, and there was no lateral joint line tenderness in the follow-up period that we had. And also radiographically, we didn't see any, the diminishing of the lateral space or any clinically evidence of any lateral pain in these cases.
I think the follow-up period that you have bedside is very difficult to find whether we are going to have something with the original lamar or the modified lamar. Original lamar and the modified lamar is only because thing is that whether you are going deep to the FCL or superficial to the FCL. Now even people, those who are doing lot of lamar, they are now telling that you can go even above the FCL. So it is just the retightening. If it is grade 3 pivot, then only you do this explosive pivot. Then only you do the associate with this. I think this is now been all taken that if the guy is doing some pivoting sports less than 25, even in the pediatric group, explosive pivot you do with the either the modified lamar or the lamar. So that is the take home. Okay. Thank you.
Thank you, sir.
So I will now request Dr. Urup Burman for his talk on the quadriceps harvest.
Good afternoon, respected chairperson, my teachers, and all faculties and delegates. It's only a video demonstration in a minimally invasive and simple technique of superficial quadriceps tendon graft harvestation. This is only a video demonstration I'll show. So the knee is in a 90-degree flexion position, and here you can see there is a lateral. L is marked as lateral and M is medial. There is a 2.5 centimeter vertical incision is given at the upper pole of patella at the junction of the medial and the lateral third, middle and the lateral third, and 2 centimeter vertical incision. And as you can see, it's marked with a ruler marker, only 2 to 2.5. So after incising the skin, we are in and separating the subcutaneous tissue and the fossa. We are in the paratendon with the 11 number surgical blade. We are incising the paratendon carefully and separated it. And after the paratendon is dissected and sorry. Video is running. So after dissection of the paratendon with the 11 number surgical bed, we measure the width of the graft with the 8-inch right angle artery forceps, which is shown here. The tip of the angle where it is exactly 8-inch roughly. So we can take the graft width of the graft. As you can see, first we incise on the medial aspect, and from that, then again another incision to take the exact 8 millimeter of the graft width. And second incision in the 8 millimeter lateral to it. And after that, we will measure the depth, which is again taken with a 6 inches right angle artery forceps for just taking the superficial part of the tendon. And after looping it, here you can see the 8-inch width of the graft. And the distal end of the graft is detached from the proximal pole of the patella sharply and carefully. The only risk here is just we don't go beyond the 6 inch so that we do not injure the deep part of the quadriceps tendon. And the pre-distal end of the graft is secured with non-adjustable suture, which stitch. And after that, we will proceed 2 to 3 centimeters of the superficial tendon proximally with a scissor, so that we can free it from from the paratendon. And here you can see that the intactness of the deep layer is ensured. And with a closed tendon stripper, we introduced through the tunnel, and as far as we can go, we can harvest as much as tendon we can. And during the harvesting the tendon, we will make the knee extended. That means 30 degrees of flexion. So it is the most relaxed position of the quadriceps. And you can see how nicely we can harvest a long, thick graft for where we can use it for both ACL, PCL, multiple ligamentous injury conditions. So this is the around 90 centimeter of 9 centimeter of graft. This is the harvested superficial graft. And this is the after harvesting. So we will wash it and then suture the subcutaneous tissue fat, and then after with the absorbable suture, and then not with the skin with the non-absorbable suture. And this is only 2.5 centimeter incision. And here you can see 9 millimeter thick graft is prepared. I think it's enough. Thank you so much.
Thank you. Thank you for your excellent presentation. Yes. Any comment from the floor? Anjan, could you bolbi?
And this quadriceps graft, as far as strength is concerned.
Sir, the quadriceps actually it has superior quality graft, and there's a lot of advantages of the quadriceps regarding the in comparison to the hamstrings.
Other qualities, that is what I'm asking.
Yeah, so advantage is that easy to harvest firstly, and then the mechanical pain, and in comparison to hamstring, where the agonists of the ACL, where it acts the hamstring, the knee pain is less, the chances of neurovascular injury is less, and mostly the technique is very simple to harvest.
And if a patient comes to you with ACL tear, would you primarily use this graft
No,
instead of semi-T?
No, sir, I will prefer semi-T. If it is a
failed case, that is what my question. Only in a failed case, you will try to find other options.
Yes, sir. In case
these other options, which you think is better, quadriceps, peroneus, or bone pattern? Has there been any study in revision ACL?
No, sir. In case of multiligamentous, we have to take these quadriceps because of we want more graft. Yes, sir. We want more.
No, I think classically what Arjun is asking for, whether in the primary ACL, what is the best choice of graft? There is a debate between the bone tendon and the hamstring. Hamstring has now gone over. It is like 60 to 70% people all around the world, they are, even for the high-end athlete, they are doing the hamstrings. If it is more than 8, there is no need of bone patellar bone. It is no way superior to it, because Newton-wise, it is 2 times superior than the bone tendon bone. Then for the revision scenario, you can take this quadriceps. This is never for the primary ACLs. Okay. then the main problem with this harvesting the quadriceps is you don't know where is the central tendon. That is the problem. Where is the central tendinous part?
The lateral part is more
I will
tendinous.
tell you, I know this technique. What Sir is asking, the problem is that all the three muscles, they are converging at the tendinous part. You never know which is the base part of the tendon because your tendon stipple is going blindly superior. So you never know how much is the muscle, how much is the tendon. And the theoretical aspect, those who are harvesting the quadriceps tendon, they have the commonest problem is the hematoma and the injury to the rectus. Because you are going blindly to the rectus. So that is the problem.
I'm asking, in a revision scenario, forget about primary. In a revision scenario, what is the best graft to use as of now?
For the revision scenario, you go to either the peroneus or the bone tendon bone.
That is what I'm asking.
Yes, it is for the multiligamentous injury. When the people are not consenting for the other side knee harvesting, then you go. This is never for the primary ACL. This is only for the revision, and mostly the first indication is the multiligamentous injury.
That is the.
And I think this technique is only popular to I think the juniors must learn this, because when they find that they have amputated the semitendinous tendon, then you are nowhere because you don't know how to take the bone tendon bone. This is a very difficult procedure. So you must know how to harvest the quadriceps tendon. Then this is the bailout for your primary ACL. Yes, Rakesh.
Yeah, so Rajiv, it's for you also from an operation. We have Goto now which goes around harvesting all different aspects. Have we not do this extra bit and harvest grafts also? From the organ transplant units. If we can get enrolled, we can start harvesting Achilles tendon graft, beta tendon graft. Yeah.
I think what Rakesh is going, I think what Anjan was asking, how to harvest the best way of quadriceps tendon. There are typical 2-3 techniques of harvesting the quadriceps tendon where you can take exactly 70 to 80 millimeter of exact tendon only, not violating the rectus. Because if you put the whole tendon stripper to its whole length, you must injure the rectus. That is the problem. You will take off the muscle fiber. So you injure the rectus, then there is a hematoma because you don't know where your tendon stripper is hitting. So that is why this is you cannot suture because it is a blind procedure. No? So that is the problem with the primary harvest. Only in the hand of master like Rajiv Raman, they can do this because it is a problem for me. Okay. So I think this is a new technique only. And also I learned a new technique that if you have got a back problem, then how to cycle the knee. So I pray God that I don't have a back problem. I can do the ACLs. Thank you.
Thank you.
Thank you. Thank you, Devapida. Devapida, to final point.
It was a very good session, and thank you, Anup, for a very interesting video.
No, tendo-Achilles graft is never primarily taken from the graft. This is only for the allograft. This is never for the primary auto. It is not for the auto harvest. The revision cases even you don't take the auto harvest for the central tendon. No, it is a huge tendon. It is a huge tendon, but it's not recommended for the primary ACL for a autograft.
Thank you, respected chairpersons.
Thank you so much. And I think the arthroscopy session is over. So
okay, with the conclusion of the arthroscopy session, we shall now move on to the East Zone session. For this, I would like to, if you want, we can have a photograph of all the arthroscopy speakers. Please, Dr. Anup Burman, everyone, please come up on stage. Ready? Online, ready? Online present আছে অনলাইন লগইন করে রেডি আছে আমারটা এরপরই করে দিন আচ্ছা হ্যাঁ ঠিক আছে তারপরে করে দিন চাপ নেই So thank you, respected chairpersons. Now we shall move on to the East Zone session. It's going to be a very fun-filled session. We are going to cover a lot of topics, including trauma, arthroplasty, as well as spine. So I would like to request the chairpersons to please join me on stage. Dr. Rakesh Rajput, can we please have you on stage? And Dr. Kiran Mukhopadhyay, sir, please join us on stage. And Dr. Sanjay Kumar. So can we have Dr. Dinesh Jaiswal, sir, please, on stage? So without further ado, let me just call upon the president of the East Zone of Indian Orthopedic Association, Dr. Tanmo Mohanty, for his address.
I'm not taking much time. Just I want to tell you that the East Zone, it is just more than 1 year that we have started. And the headquarters is at Calcutta. And we are West Bengal, Orissa, and 8 Northeast states. So it is quite a 10 number of cases, 10 number of states we have come together. Our main aim is to see our presence felt in the central highway, nothing else. So maybe every 5 years, the chance of IOCON will come to us and possibly we'll decide where the IOCON will be and how best it can be. Then comes our organization, how you do it. Already a lot of members who are Indian Orthopedic Association members amongst the state members, they have become the members of East Zone Orthopedic Association. And the last conference, it was done in Ravindra Tirtha in Calcutta. That was the first East Zone conference. It was very well attended. And I must congratulate the people who really did it there with help of the organizers there. And Dr. Dinesh Jaiswal has taken pain in maintaining the papers and the office in Calcutta to the extent that because it is a budding institution, a lot of things have to be done. And Dr. Rakesh Rajput has taken a lot of interest in the academic side. He handled everything. And a lot of people helped them there. And finally, the East Zone is coming up. So without wasting more time, we'll start the scientific session here. As a president, just I wanted to tell you and just welcome you to this meeting. Thank you.
So our first talk for the evening will be the functional outcome of AO 31A 2.2 and 2.3 fractures, functional outcome PFN versus DHS. For this, we have an online lecture by Dr. Chinmoy Das. So can we have the online feed over here?
Dr. Das from Guwahati, he is our secretary of East Zone Orthopedic Association. He could not attend this conference. From there, as you know, in every state conferences, a part is given to the East Zone now. In Calcutta, WBOA, there was a part, a session was kept for East Zone. In Orissa at Bhubaneswar, when we at Puri, we had the conference, same thing. So this is going on so that at least the presence of East Zone will be felt there. And Dr. Chinmoy Das could not come. He was waiting all set to present his paper, I think. Is he ready?
Yes, yes,
Thank you.
I am ready. I'm audible, sir, and visible, I think. Good afternoon, everyone. Hello, am I audible?
Yes, sir, you are audible.
Yeah, good afternoon, everyone. Welcome to the East Zone session. This is the fourth scientific session we are having. We had East Zone session in West Bengal Orthopedic Association last year, then with Odisha Orthopedic Association and Nerosa also. So this is the fourth session of East Zone Orthopedic Association. So I'm just presenting a small paper. So regarding these AO 31A2.2 and 0.3, these are quite difficult fractures, and there is a dilemma, and debate is always going on that whether you go for a DHS or whether you go for an intramedullary device like a PFN. So which implant to choose? These are some of our cases where in A2.2 and 2.3, we have used the DHS as well as the PFN. Of course, the indications are for a long butterfly fragment or a long fractures extending way down below to the shaft of the femur. You always prefer an intramedullary device, longer PFN, and we also went for encerclage wirings in these cases. And sometimes there are many debates about whether to stabilize the trochanter with a tension band wiring or a TSP. So just introduction, brief introduction. So hip fractures, there is a projection that by 25, it will be around 2.6 million cases per year. So we are having a lot of cases, I think, from 2 years down the line. And because of the increased age, increased incidence is there, increased incidence of fall due to weak reflexes in the elderly people, usually results from simple fractures, but in youngsters, young patients, it's because of high energy trauma. Treatment is generally based on patient's medical conditions, bone quality, and the fracture configuration. Fracture stability, it depends on the posterior middle bony contact, which acts as a buttress. So in this study, our aim was to compare the functional outcome using the Harris-Hip score in cases of 0.2 and 0.3, 31.2 and 31.3, and to analyze and assess the radiological union of the fractures at different time intervals. We did this study in Tezpur Medical College and hospital. It's a government hospital in Tezpur, and it's a prospective hospital-based comparative study. 60 patients, 60 subjects were considered for this study randomly, and they were equally divided, 30 each in both the groups. We formulated some inclusion and exclusion criteria. We excluded compound fractures, pathological fractures, polytrauma patients, patients non-ambulant with previous history of surgery and with cognitive disorders or steroids or immunosuppressant. So these are few of our cases where all 31, 2.2 and 2.3, where we can see that we got good functional results with DHS and with the proximal femoral nail, PFN. So what we got the results is we had more elderly females. Population is more than males, and the mean age for DHS we had around 57 plus minus 11 years, and for PFN it was 62 plus minus 10 years. And operative variables, of course, PFN has got little bit benefit over DHS, and where the mean blood loss was less in PFN, operation duration was less, but PFN gave your more to your radiation exposure using the CM. Harris-Hip score also, we got good results in 15 cases in DHS and 4 excellent results. In PFN, we got 18 good results and 10 excellent results. So around 28 and 19 here. So in this, while we use the Harris-Hip score system, So we got that PFN gives a better outcome than in case of DHS. And using the Singh's index also, we came to know that type 3 and type 4 osteoporosis are, type 2 and type 3 are quite common osteoporosis in these patients, above 60 years patients. Complications, we had a good amount of complications with the wound infection, varus collapse, persistent thigh pain, persistent hip pain, non-union, as well as peri-implant fractures and shortening. But more of these complications are with the DHS group than with the PFN group. So intertrochanteric fractures of femur, these are challenging not only for obtaining fracture union, but also for achieving optimal functional recovery. Statistically significant differences were noted between the two groups in terms of duration of surgery, blood loss, and time taken to full weight bearing, as well as functional outcome. We also got similar results in different studies published with our Pulin Bihari Das sir et al. As well as Dubey et al. These are Indian studies only. So concluding, I must say that IT fractures occurs in elderly population around 6th decade of maximum patients are in the 6th decade of life. Apart from routine AP and lateral traction views and internal rotation views are important to see the posterior-medial buttressing. No statistically significant difference in terms of radiological union and complications. Radiation exposure is, of course, as I said, it's more in PFN than DHS. It's to the surgeon as well as the patient. And then lag screw and anterior rotation screw has to be in central in the lateral view, and it should be near the calcar in AP view, and post-operative function was measured by Harris-Zip score for both the groups, and PFN group showed significantly better functional outcome than your DHS group. So we would like to recommend that unstable intertrochanteric fractures can be managed by both the techniques, DHS and PFN. And in the morning session, I heard one medical legal paper in today's WBA. And then he said that the court, the law cannot sue a doctor if suppose he is having he has done a DHS, but it has failed, and someone recommends that PFN should have been done. So the law also cannot sue us for this, because these are recommended operations, DHS and PFN, for your intertrochanteric fractures. And early post-operative mobilization and physiotherapy is the key for good functional outcome in the patients. So in summary, we should recognize the fracture pattern, choose the appropriate fixation, performing accurate reduction, ideal implant placement, and being conscious of the implant costs also. So with this, I thank you all for your patient hearing. I thank the chairman, co-chairman, our president of East Zone Orthopedic Association and the West Bengal Orthopedic Association for giving me this chance. And here I would like to just announce that this time the second East Zone Orthopedic Association conference is going to be held in Guwahati, Assam. So we got this chance to serve you. So please come. We are planning this conference in the month of June and July because the timings are not yet fixed for East Zone conference. So last time we had just pre-puja we had in West Bengal. So after puja, the WBOACON starts, and we are having a this thing spine IORA in West Bengal also. Then the IORA conference in September in Vanaras. So that's why we have tentatively fixed it in June and July. All are welcome. I welcome you all to that East Zone conference. We will be posting the updates. Thank you.
Thank you, Mr. Das.
Yeah.
If there is any question from the floor.
I think there is no question. So
Okay, I will stop sharing.
Professor Das, can I ask you a question?
Yeah, Rakesh, sir.
Yeah, it's here.
No, we have fixed that if you ask questions, you will get one peg less in each zone conference. So it's up to you whether you want to ask or not.
I think it'll still go ahead because there are some come with these papers.
Okay, thank you. Please, please.
Yeah. So did you do all long nails or did you short nails? And in which
No.
cases you use short if you did?
We just if the fracture is means way down to the shaft of the femur, we use longer nails. But shorter nails, it's easier to introduce, easier to do, faster to do. So it has got benefits. If you have got just in the comminution in the proximal part and the fracture is not extending down below, so you have got the advantage of shorter nails. But longer nails, they have got their advantages. In some cases, we use longer nails. Some cases have shown that some cases we use shorter nails also. Am I audible?
Yes, you're audible. Yeah.
Okay.
Okay. Thank you very much.
Thank you, and welcome to East Zone, Guwahati. Huh?
Please stay on for the session.
Yeah, sure.
Thank you, Chinmoy sir, for that excellent presentation on such a relevant topic. Next, I would like to call upon stage Dr. Shonendu sir for some important tips and tricks of reverse shoulder arthroplasty.
I think because of the thank you, my teacher, Tanmay sir, my senior Rakesh, my dear friends Kiran and Dinesh. And this is because of the conspiracy of Rajiv and Somodi, most of the time I spent on the dais. Okay. ওখান থেকে চালাবে, তোমরা চালাচ্ছ? কে চালাবে? করেছো, করো। এসছে? ওইদিকে যাবো, আচ্ছা ঠিক আছে। I'll be very fast on talking about the tips and tricks of how to do the reverse shoulder arthroplasty, because this is an area of interest in the shoulder we don't do very regularly. So we have to understand basically what are the basic tricks of doing the reverse shoulder. We have to whenever we do the reverse shoulder arthroplasty, we must understand what is the basic biomechanics of doing it. Basically, if you see the left picture where my mouse is moving, when we do the normal shoulder movement, this is a center of rotation at the humeral head. In the reverse shoulder, you see now the ball is on the glenoid side. So your center of rotation is at your base plate. So your center of rotation changes from lateral to medial. What is the advantage of doing this? It is because your lever arm, if you see the L1 here on the left picture, and if you compare this lever arm on the right picture, you see L1 is much smaller than L2. And also the F1 is the deltoid force, and this is now been the F2 is the longer one. So now your deltoid is moving your abduction. So basically, whenever your rotator cuff is not functional, there is rotator cuff deficiency, then only you do the reverse. Probably these are the all common indications of doing the reverse, your rotator cuff, then the osteoarthritis, rheumatoids, acute fracture, where you cannot reconstruct. Sequel after fracture is the revision arthroplasty. So you all know that this is the classic picture of the anterior superior escape. Anterior superior escape means when the humeral head escapes in the anteriorly and superiorly. So this is the classic picture of your anterior-superior escape. So this is a really horrifying X-ray, and if you see this picture, probably this I did in 5th of January this year only, few days back. This was a very is a very high-grade professional. He had a 4-part fracture of the proximal humerus. He was fixed with some nail sort of thing, which is, I don't know, this ras nail or whatever. And you see the ras nail is quite medial. This is the glenoid. Here is it. Some part of the humeral head is there. This is the horrifying looking the CT scans. It is more or less unreconstructable because I cannot reconstruct the tuberosity. The only option left, even if you see the some fragments of the humeral has been migrated on the lower down segment here. So I do all my shoulders in the beach chair position. So I told in some discussion during the reverse shoulder that whenever you do the reverse total shoulder or your hemis during the Amitabh's the workshop, that you must have the X-ray of 100%, how we do in the proximal when you do the hips, that you have to have the other side 100% X-ray so that you know where should be your humeral head height. So here you see when we measured, there is more or less 3 centimeter bone loss on the humeral side. So whenever you do, like, it is like templating for your hips. And if you see this, the gentleman, and he is now moving his shoulder. এটা চলবে কি? চলছে তো গো। So he was having very, very difficult. You can see this is more or less like a pseudo paralytic scenario. He is hardly abducting 20 degree. Hardly his forward flexor is around 20 degree. And this is the right hand. He was really incapacitated with all this problem. So I did the class in the beach chair, the classic deltopectoral approach. And it is a very hard job to take out all the small bony pieces from there, because it was here where some part of it is also be migrated very, very medially. এটা কিন্তু চলছে না, তোমাদের ওখানে চলছিল, যাই হোক। ওটা কি তোমরা ওখান থেকে কন্ট্রোল করছো? ঠিক আছে, আমি এখান থেকে দেখিয়ে দিচ্ছি, ছেড়ে দাও, তোমাকে দেখিয়ে দিচ্ছি, দাঁড়াও। So now you see this is the way how I took out all the humeral head fragment. The main problem when you do the reverse is the glenoid exposure, because you have to have the 360-degree vision of the glenoid. It is just like doing your the total hip, because unless you do have the 360-degree exposure of your acetabulum, you cannot do this thing. So this is a very tough scenario, because this is all been fibrotic. The whole anatomy has been disturbed. So now you see I have put the levers on the back side, one Homan on the top side at the 6 o'clock, and one Homan has to be on the 6 o'clock just at the triceps, so that you know this is the now you see the whole glenoid is now visible. You see how beautifully now the glenoid is visible. Now I am marking with the cautery where should be the center of the glenoid. So this is the way how you decide where should be the center of the glenoid. So this is a very, very tricky scenario. So you have to mark the center, then your guide wire, this has to be 10-degree inclined. This is a classic technique of doing it, so that the glenoid breastplate comes inferiorly, so that it is the 10-degree inclination of your guide wire, so that your baseplate is correct. So once your baseplate is correct, now this is the sequential reamer. You go, these are 2-3 sizes are there. You do the crown reaming, and then you do your baseplate. And now you see, once I am fixing the base plate, then you have to fix the 4 screws, because those who have attended the hemi workshop, then you understand that on the glenoid side, your bone stock is very, very poor. So you have to be very 100% accurate how you put your screws, because the base screw is towards the coracoid. So you have to put your all screws very, very meticulously, so that the glenoid breastplate is very, very correct. These are the locking screws, so that it has got 25-degree divergence angle. So you can diverge and converge according to your base plate. Now with your probe, you can feel it is like like your pedicle probe, how you do your pedicular screws. So this is the way how you put your glenoid on that side. So if you are very, very meticulous, then only you can do this. So if you are very, very correctly doing this, then only you get this picture, that so that your base plate is correct, your version on the retro version on the humeral side is correct. And you have to be very cautious how you target your screws. As I told you, you have to be targeting your screws at the base bone. Then only this is the way how you put your base plates. And the goal is this, so that the best bone is towards the coracoid and your scapular, so that you don't go for the scapular notching, because the scapular notching is a big problem for your this. If the fracture, then it is a different ball game, because in the fracture scenario, all the tuberosities are flying. So you have to resuture that. It is a special trick of resuturing all your lesser tuberosity and the greater tuberosity, because if you don't do resuture, then this is going to dislocate. And if the reverse dislocates, it is a nightmare. If your reverse dislocates, it is a nightmare. So I request, if you learn how to resuture your greater tuberosity. So this is I think there are many techniques of resuturing the tuberosities. I think if you please read the Pascal Ballou's technique of resuturing the tuberosities, because this helps in your reverse, your hemis and totals. So read the manual, play with the instruments, and be meticulous. Thank you. Rakesh, any question or anything to add on?
No, I think it was wonderful. Any questions? I think not many do these operations, so not many will have questions. But I think that is the whole crux, doing the glenoid. I see Anando doing these things. I've seen you doing it. And I've always found that is a jittery place. And I've seen live surgery where I think I remember in even the foreigner managed to destroy our glenoid. And I remember the live surgery being done in Murshidabad. Avik was doing it. And even there, the glenoid had trouble. So it's a troublesome area, I think. And whoever gets away with it, fine. So I think, but that is where I think I was liking the hologram effect of technology of Amitabh. That may come into picture, that you can actually target and actually even make your own glenoid for the native glenoid. That may be the way to go.
And I am very lucky that sometimes Rakesh, being a good friend of mine, me and Rakesh, we commonly jointly do some shoulder replacements. Even for one very close friend, I have done a total shoulder. He is now playing golf, that we have presented last year. So I think doing the glenoid is the basic trick of how you do your total shoulder, the reverse. Thank you, Chandan. Kichu bolbi? So I think the whole trick lies in the total shoulder or the reverse is how you expose your glenoid. So always remember that you have to put a Homan on the back side, one Homan at a 12 o'clock, one Homan at the 6 o'clock, one lever on the front, so that it is like your acetabulum exposure, and always release whatever soft tissue like your labrum from the glenoid, and try to release the long head of the triceps from the 6 o'clock. So if you release all this soft tissue, then only you can feel the bone around, because always the glenoid will be the deformed glenoid. That is the problem. So try to feel your index finger, where is the base bone, because wherever you are firing your screws, that towards the coracoid or the scapula, is all blind thing, because the bone is very, very thin. It has to be a long screws, because the front screw and the back screw is hardly 25 millimeter. The upper screw and the lower screw is like 35 millimeter. So your coracoid screw and the scapular screw has to be 35, and it should be absolutely dead in the bone. So try to do this like your pedicular screw, so that you try to fill this with your depth gauge, so that you are absolutely in the bone, you are not misfiring.
So I think the mistakes, Chandan, you and me will make. One is that we will oversize the glenoid. That's a common mistake we'll make. Second is that we'll prepare in such a way that we'll only manage 2 screws, and the third, there won't be a place for the third screw. And that's the mistake which the beginners make.
Always give 4 screws. The glenoid base plate loosening is a very, very common thing. That's why the follow-up of the reverse is very, very poor. People who are struggling to have the best follow-up for 5 years, now people are giving the follow-up for the 10 years. Even people are not happy to do under 70. We are debating for the hemis and total hips for 70 years for the hips. But people are very apprehensive when they are doing reverse less than 70 because the follow-up is very poor because of the glenoid loosening. It is always to be inferiorly placed. Always. It is you never. That's why there is a special curate which is known as the crown rimmer, so that you ream on the 6 o'clock so that it fits. It has to be. That's why I shown that because of the time constraint, you have to mark with the diathermy cord where your center is. So at the center, come to that below the center, and your angle of that primary wear is very important. It has to be inferior to superior 10-degree inclined. So your base plate is 10-degree inferiorly inclined because your hemi, the ball is absolutely a ball. It doesn't make sense whether you can retrovert or antivert. You can retrovert only on the humeral side because glenoid is a ball. It is no meaning you can superiorly vert, inferiorly vert. Only thing you can play with the glenoid base plate. So I think it is a very difficult surgery. I think probably with Rajiv and you and Devapida, we are planning to do one cadaveric workshop with the reverse shoulder very near future. Also the live workshop so that we can plan accordingly.
Tension is not refer for this.
Thank you.
Thank you, Sanandu sir, for that excellent presentation. Now I'd like to call upon stage Dr. Partha Shoite Sarkar for his talk on lateral mass screw fixation the right way.
Okay. Respected President sir, Tanmay Mohanty sir, and our dignitaries in the dais and of the dais. Today I am going to present this lateral mass screw fixation the right way. It was in the long 1980, Roy Camilli introduced this lateral mass fixation technique, and the indications are mainly trauma, the unstable fracture, unilateral or bilateral facet dislocation without posterior disc bulge, or bus fracture without retropulse fragments. Other indications are reconstruction, degenerative condition, and pediatric spine. It is occasionally used. But when there is a more than 2-level disc bulge, the anterior interbody start gaping beyond this 2-level will increase the failure rate. So this anterior fixation will be supplemented with the posterior stabilization, or a single stage posterior approach is more appropriate, which is usually done for this lateral mass technique. So whether there is a static or dynamic subluxation, if there is any severe subluxation on dynamic imaging, the laminectomy, stabilization, and the fusion is the treatment from the posterior approach by this lateral mass fixation. So what is the patient baseline medical status? When the patient is aged, in case of anterior approach, there may be swallowing dysfunction, or in case of severe osteoporosis, there may be chance of calf subsidence. So in older patient, this posterior approach is more appropriate. So now a little bit of anatomy. So this is the part, this part is the lateral mass, and this range is from 18 to 16 millimeter. Mean white gaiter in males, all levels, and greatest at C6, and males are having this 12.8 millimeter and females having 11.1 millimeter. And so the lateral mass, this is the bony structure. This part is the lateral mass. This is the superior
joint and this is the inferior joint and this is the lamina. So this lateral part of the lamina, this quadrangular part is the lateral mass. And it is a part lateral to the lamina between this inferior and the superior articular surface. And this is the anatomy. And the most interesting part is that this 12 to 13 millimeter from C3 to C7 and the height is 11 millimeter at C3 and 15 millimeter in C7. But the thing is that the smaller at C6 and C7 level. So below C6, we usually never apply this lateral mass. So this is the bony anatomy. This is the two-dimensional part of this. This part is the lateral mass. Here lies the spinal cord. This is the vertebral artery foramen. So this part is the lateral mass. And so if we see the entry point, this is the direction of this lateral mass. While putting this pedicle screw, the direction is towards the vertebral artery or towards the spinal cord. In case of lateral mass, it is away from these two vital structures. It is laterally directed. So it is very safe and it is very easy to identify the part of this lateral mass. So it is always away from nerve root, spinal cord, and the vertebral artery. These three are the main part of this anatomy. So there are two techniques. One is the McGrail and there is the Roy-Camilli. There is a basic difference. It is the original McGrail technique. Rather, later on it was modified as a modified McGrail. The entry point is different. It is in the center. It is in the upper quadrangular part of this lateral mass. And the direction, that lateral inclination 25 degree in case of McGrail, and this lateral inclination is less, that is 10 degree in case of Roy-Camilli, and also the direction of the screw. It is parallel to the facet joint. This screw is parallel with this facet joint, but in case of Roy-Camilli, it is perpendicular with the surface, spinous surface. It is perpendicular with the surface line of the, along with the spinous surface. So the screw trajectory, the main difference is the inclination. This is the lateral inclination. This is the lateral inclination. It is 25 degree in case of McGrail or Roy-Camilli. It is 10 degree. And another big difference is that the direction of the screw, it is parallel with this facet joint, but it is perpendicular with the spinal plane. So there is because of this difference, the Roy-Camilli and the McGrail, the screw length, the McGrail trajectory is significantly lower than the Roy-Camilli trajectory. So the average screw length is 2.6 millimeter longer at C3, C6 level and 1.3 centimeter longer. So the longer screws are required in case of McGrail technique. So this is the modified McGrail. The thing is that if we divide this quadrangular lateral part into 4 parts, this is the lower quadrangle, medial quadrangle, and it is 1 centimeter below and 1 centimeter medial to this lower part of the quadrangle, and this is the direction. This direction will be perpendicular, parallel with the facet joint. So this direction will be the parallel with the facet joint, and this is the lateral inclination. The lateral inclination is so that the all from this entry point, if we direct the all and it touches the spinous process, it is the 20 to 25 degrees. So it is very easy to put the screw in freehand technique also. Just this is the prone position, and the head is fed with the head holder to give the traction in case of cervical spine intra-operatively. And it is very easy that we have a nuchal line, which is a avascular margin, and just we give the incision, and along the plane of this nuchal line, there is a avascular zone. So after this spinous process, there will be no bleeding if we follow this nuchal line. But in case of, and very easy to identify this lateral mass, also lateral mass, that is the superior articular, inferior articular, and which is the between the part. So after putting this screw, this is like this. And the screw is as usual contoured rod and the facet joint, and we usually give bone graft to achieve the fusion. And this is the post-operative Siam conformation. So post-operative protocol is the stitch removal 14 day, follow at 6 weekly interval for the 6 months, 3 monthly for 1 year, and 6 monthly for 2 years. Neuro grading by SCR score. And so there is a various complication there is a literature evidence, that is the vertebral artery injury, post-operative radiculopathy, iatrogenic nerve root damage, screw pull out, and the screw loosening. But the literature support is that lateral mass technique is the safest and the most effective available technique, and the rate of complication is nearly zero. And there are several literature that support that it is a very stabilization with a polyaxial screw and rod system. And this is a very large study with the 6 and 7 screws. And it is also said that it is a very safe. So freehand technique we usually use. This is the literature evidence, and this efficacy, there is a fusion of 97%, good maintenance of stability. It is more than 95%, low complication rate, injury, nerve root injury is 1.2, vertebral injury, very small risk. This is the case 1, traumatic cervical spine injury. This is the alignment is maintained. This is another case. There is a subluxation of this 3 and 4 and 5 vertebra, and this was also the alignment is well maintained by this putting this lateral mass screws. This is another case. There is a C7. There is the pedicle screw was applied, and this is the case 4. So it is a very effective and very good, easy technique, so that we can have this apply this technique for this older patient and if each and every patient where the posterior stabilization is required. Thank you. Thank you for your presence here.
Thank you, Partho sir.
This is open for question. Any question from the hall? So no, okay. If there's no question from the hall, I'd like to ask Vijay. Your topic was lateral mass screw fixation the right way. So you have shown the 3 methods. Which one is the right way?
Modified Magral.
Modified Magral.
technique.
What difficulty do you face in modified Magral is while you're putting the screw from medial to lateral, what comes in your way is the spinous process which is long. How will you address that?
No, just it is the angulation. If you enter through this lower part of this quadrangle, if we angulate it, the 25-degree makes when this all touches this spinous process. This is the so this spinous process usually do not interfere with the while putting the screw, because it is the we have applied this technique that it is the point that where we can calculate easily that it is a 25 to 25-degree inclination lateral.
Many of the times it interferes. The spinous tip of the spinous cord interferes with your direction of putting the drill. So in that case, you'll have to trim the tips of the spinous process so that you can make way and put the screws medially. That is the point I want to make.
Okay.
Just one question from the layman. What I found, all surgeons now spines are moving away from pedicle is lateral mass is a much bigger area. So are you able to put bigger size screws to actually get a bigger hold, or screw size is still the same?
No, the lateral mass is it is the separate part, and the screw length, as I have already discussed, the screw length is different. Size is same as
same
that
size.
same size nearly.
Size is same or small, but what is the advantage? The safer area. Pedicle screw is technically very high, and it is very unsafe area to pass through the screw. But this is the safer area. Rather, even the screw length is small, but the thickness we can purchase more bone so that the fixation is quite tough. Yeah. Thank you, Partho.
Thank you, Partho sir, for that excellent demonstration. Now we are going to go to our next topic. TKR in valgus knees, is it still a challenge in 2023? By Dr. Sanjeev Patnaik, who will be joining us via online lecture.
Yes, sir.
Can you please have the online feed?
Is it all right? Am I audible?
Yes, Sanjeev, you're audible. You can
Yeah,
go ahead
hello.
with your talk.
Respected chairpersons, Rakesh sir, Dr. Mukhopadhyay, Dr. Sanjay Kumar, dear friends, the president of the East Zone Orthopedic Association, Mahanti, a very good afternoon to all of you. At the outset, I would like to thank the entire West Bengal Orthopedic Association for giving me the opportunity to speak in this prestigious conference. The topic of my presentation is total knee replacement in valgus knee. Is it still a challenge in 2023? Share. Just a minute. Well, valgus knees constitute almost 10 to 15% of our clinical practice. And the total knee in valgus knees, they continue to be a challenge. Because there is altered pathoanatomy in the valgus knee, it needs to be addressed intraoperatively. And these deformities are very uncommon, and hence we have less familiarity with these deformities. And valgus is not the opposite of varus. And there is no fixed consensus regarding the surgical approach, the type and sequence of releases, and the type of implant which is used. Now, coming to the etiology of the valgus knees, the most common is osteoarthritis.
Sanjeev, I mean, I'll have to interrupt you. Your slides are not moving. You're still on your first slide, introduction slide.
Sorry.
So maybe it's stuck up.
Is it okay?
You're still on your first slide. I don't know if you try and move. Yeah, now it's moving. Yeah.
Moving? Yeah. Thank you. Thank you. So coming to the etiology, the most common is osteoarthritis.
You need to go on the slideshow.
Followed by
Sanjeev, I'll have to interrupt you. You're still, you need to go on the slideshow.
Right. Is it okay? Is it moving now?
Yeah, moving now. Yeah.
Yeah. So the other causes may be post-traumatic, renal osteodystrophy, rickets, poliomyelitis, and females are more commonly involved in valgus knees. Now, coming to the surgical goal, it remains the same as with any varus knee also. And the goals are restoration of the joint line, soft tissue balancing, equalization of the flexion and extension gap, correct positioning of a well-fixed component, and restoration of the patellofemoral alignment. Now, these are the various challenges we face in valgus knee. There is a complex pathoanatomy, technical aspects of the surgical approach, the bony cuts of the distal femur and the proximal tibia, rotation of the components. It's often very difficult to discern. Then medial and lateral ligament balancing, flexion, extension, mismatch, and unstable joint. There are more chances of patellofemoral maltracking. Preserving the peroneal nerve function during an extensive lateral release, especially during pie crusting, is also very important, and selecting the appropriate implant with the appropriate constraint. Now, the bony deformity, there is a posterolateral femoral condyle hypoplasia, and there is erosion of the lateral cartilage, and there is tibial central bone resorption with marginal osteophytes. And in severe cases, there may be external tibial torsion, tibial tubercle is positioned laterally, and the metaphyseal changes are seen, and remodeling changes are seen in the valgus knee. Now, coming to the patella, it's often subluxated laterally. The lateral facet is deformed, flattened or concave with large traction osteophytes. Now, all these lead to contractures and tightening of the lateral structures. That the posterolateral capsule, the LCL, the arcuate ligament, the popliteus tendon, IT band, lateral intramuscular septum, and sometimes the MCL is usually attenuated or deficient. All these lead to the problems in valgus knee. Now, various classification systems, the Ranawat and the Krakow classification, they divide into three types. The type 1 are the less than 10 degrees valgus with a stretched MCL. These constitute almost 80% of the cases. The type 2 are the partially correctable valgus knees, 10 to 20 functional, and these are 15% of the. Our pre-operative evaluation is very important. We have to examine the ipsilateral hip, ankle, foot as a contributing factor to the knee pathology. The alignment of both the extremity is important. We have to look for any extra-articular deformity. The stability of the joint in the coronal and the sagittal plane has to be ascertained, and the posterior structures need to be examined for any popliteal cyst. And radiologically, we have to have full-length scanograms and lateral view as well as skyline view. Now, basically, what is important in valgus, we have to know whether it's a fixed valgus or a passively correctable valgus. Now, the surgical techniques are very important. We have to know the approach, the bony preparation, the soft tissue balancing, and the patellofemoral tracking. Now, medial parapatellar arthrotomy still remains the most important approach. Now, the disadvantages here is that the patella maltracking is more common, increased potential for inaccurate flexion extension, gap balancing, increases the external rotation of the tibia, the access to the tight posterolateral corner is sometimes difficult, and the vascularity to the quad patellar tendon mechanism and the lateral skin is always at risk. Now, the lateral parapatellar approach, which has been advocated by it preserves the vascularity because medial side remains untouched. It centralizes the quadratus mechanism, which optimizes the patellar tracking, but it is not routinely used. There is chances of damage to the genicular artery, not familiar with the exposure technique, so there may be also a possibility for tibial tubercle osteotomy. And there is also concern regarding the soft tissue coverage after alignment correction. Now, bony preparation, you have to go for a 3-degree valgus cut instead of a 5 to 7 degree valgus cut in varus. Now, AP femur cut is very difficult to ascertain due to the hypoplastic lateral femoral condyle. So we have to base it on the transepicondylar axis, the white side line, and also make the cut parallel to the tibial cut, that is perpendicular to the tibial axis. Now, using the posterior condylar in the posterior referencing, it can lead to malrotation of the femoral component. Now, the femoral filtration, as you can see in some cases, the section from the medial side results in minimal or no imbalance with rectangular flexion extension gap.
Sanjeev, can I stop you for a moment? Hello.
Maintaining the lateral
Sanjeev, can I stop you for a minute?
of the knee infection. And the releases can be either full release, yes. Hello?
Your voice has completely broken. Do one favor.
Hello?
Just,
Am I audible?
Yeah, you're audible, but your voice
Is it okay?
breaking. So just take away your video. Just go on your presentation. Just take away your own video.
Okay. Just take the video. Okay. All right. So there are, this is a sequence of lateral release. Can you, am I audible?
Yeah, you're audible now. Yeah.
Yeah. Okay. So the various surgeons, all the stalwarts, Insal, Whiteside, Clark, and Ranawat, all they have advocated the sequence of lateral release, but there is no consensus. Now, this is one sequence. The first, we have to remove the osteophytes and then go on to the iliotibial band of the tibial joint line, then the posterior capsule of the femur. Sometimes we have to excise the PCL, and in very rare cases, we have to take off the popliteal tendon or the posterolateral capsule and the LCL. And this is basically advocated by Misayaka and Miyasaka and Kenji. Now, as you see the sequence of release in the valgus knee, as you release, these are the structures. If you release the PCL, the posterolateral capsule, IT band, this is the amount of release that you can have on the lateral side. Now, soft tissue balancing, as you know, that LCL and popliteus tendon, they provide lateral stability in both flexion extension. The IT band and the posterolateral capsule, they provide lateral stability only in extension. So we have to release the IT band at the Gerdy's tubercle and lengthen by pie crusting. And if more correction is required, the posterolateral capsule to be, the peroneal nerve is very close by. Now, this is the sequence tight in both flexion extension. The LCL and popliteal release is done, followed by the IT band, and the posterior capsule is released, and then the lateral gastrocnemius release may be required as the last resort. If it is tight only in extension, IT band release and the posterior capsule release can be done. And if a lot of releases are done, we sometimes have to go to a constrained condylar knee. Now, to deal with the patella maltracking, we have to have correct femoral rotation, and the posterior condylar axis is erroneous. So we rely on the trans-epicondylar axis and the white side line. We try to lateralize the femoral component, externally rotate the tibial tray, and the tibial tuberosity transfer may be required in extreme cases. Now, there is a technique by Krakow. When the MCL is too lax, we can go for a MCL advancement. It should be done when the medial ligaments are too lax after complete release of the lateral ligament. And either you can go for a proximal advancement on the femur or a distal advancement on the tibia. And it is performed only after final implantation of TKA component just before the closure. Pie crusting technique has been described by Clark et al. And Ranawat. The inside out technique, it has to be performed with a lamina spreader distracting the femorotibial junction, and multiple stab incisions are made through the lateral structures, especially the IT band and the posterolateral capsule. Now, this is very important that we have to be aware that the peroneal nerve has to be protected. And there is a lateral epicondylar osteotomy described by Arun Mulaji using computer navigation, especially for the rigid valgus deformities. Now, the choice of implant depends on the collateral ligament stability and extensor mechanism integrity, the degree of bone loss, the residual bone. And the choice of implant, again, there is no consensus. We can go for a CR or a PS knee, unlinked LCCK knee, rotating hinge, or a modular prosthesis. Now, young active patients with mild to moderate valgus, we can go for a CR knee or a PS. Now, PS designs, they avoid concerns with PS balancing, PCL balancing with a potentially abnormal native PCL. And the CR knee potentially preserves the condylar bone for possible revisions in the younger patients. Now, if there is a valgus with bone deficiency, we can straight away go to modular implants with augment and offset stem. An elderly low demand patient, we can go for a CCK knee. And the elderly patient with fixed valgus, we might consider a rotating hinge knee. So some cases, this is a windswept deformity. As you can see, the distal femur cut in the valgus, very minimal cut on the lateral side of the femur condyle. And this is the post-operative X-rays and the clinical picture of the patient. This is a very grotesque deformity, rheumatoid patient, bilateral, valgus knees, fixed deformity, as you can see, fixed flexion deformity. And this is the intraoperative pictures, and where stems have been used, but this is the PS knee. This is a post-operative X-ray. The left side has been operated. And this is again a rheumatoid patient, severe bone loss, as you can see. A patella is deformed, concave, and where a patella button has been used, and a PS knee. This is another case. As you can see, very difficult valgus knees. This is the windswept. And this was the intraoperative exam. As you can see, opening up on the medial side, MCL is lax, but MCL is intact. So that was the advantage. So where we went for basically a PS implant with stemmed tibia. This is the post-operative video of the same patient. Another case, this is the same patient, post-operative video 15 days after the operation. This is again 67-year-old female rheumatoid patient, bilateral valgus. This is intraoperative video. This is a correctable valgus again. So that is the very important thing. And these are the intraoperative pictures, as you can see, managed with the PS knee, and good stability as well as alignment has been achieved. Now, this is the immediate post-operative picture of the patient. Now, complications, soft tissue instability, there is a risk of dislocation, patella maltracking, peroneal nerve palsy, wound complications, as well as the chance of recurrent valgus deformity. Now, TKR in valgus knee still remains a challenge in 2023. Multiple surgical techniques have been described with satisfactory result. Adherence to a stepwise approach to deformity correction and implant selection with appropriate constraint, preferably the least constraint, is recommended for a satisfactory long-term functional outcome. Thank you very much.
Thank you, Sanjeev. The presentation is open for question. Chandan, you want to ask him anything about valgus, because you present a lot on valgus knee in different forums. Anything different to what he has said? Can you give a mic out there?
And hello, my take on valgus is at what point you decide that you need a TC3 or a semi-constant. At what point on the table you feel that it is enough, you cannot manage with PSC.
the most important, my first go-to is to, because I normally do most of my cases PS knee, it's posterior stabilized. So I sacrifice the PCL. So if I cannot balance the knee in flexion and extension, and there is an opening up, both medially as well as laterally, in the coronal plane also, if there is an opening, and I'm not happy with the stability after a trial with the PS knee, and then there I decide to go for increased constraint. So preferably a LCCK. So all these armamentarium has to be ready in the OT, especially you are dealing with a fixed valgus deformity, because preoperative evaluation is very important. If we feel that the MCL is attenuated, but it is still intact, then only we can think we can bail out with a PS knee. But if the MCL is dicey and we are not sure about the MCL laxity, and there is also bone loss, then only we go for increased constraint, and especially in the elderly individual, where we hope that we can get away with the increasing constraint.
So Sanjeev, the question was, would you go for increased constraint or then would you do the MCL tightening like Krakow?
I do not have much experience with the MCL tightening, because ultimately there is chances of giving way. There may be laxity in the immediate post-operative period or in the late post-operative period. So I have no experience regarding that tightening of the MCL.
The second question is, you said you straight away go for PS implants. Now all your tightness is on the lateral side. Whereas the moment you cut PCL, you've actually made the posteromedial side even more lax. So that actually contracts each other. So how do you
I would say the most important, we do not touch the medial side. There is absolutely no release on the medial side. It's only the meniscus which comes out. Without touching the medial side, the amount of, first of all, we try to remove the osteophytes which are there on the lateral margin of the tibia and on the femur also. That contributes to some amount of tightness. What I'm telling you is most of the 85% of cases, which are almost like grade 1, grade 2 valgus, in most of the situations, we just remove the osteophytes and do some amount of release on the lateral side. Some amount, I mean to say, the posterolateral corner. That amount of release will probably balance out the knee joint. And having very minimal cut on the tibia as well as on the femur is very important, because these patients are lax medially. So we need to remove as minimal bone cut in the femur as well as the tibia. So that is our basic goal. In spite of doing all these, if there is opening up on the lateral side as well, medial side is already attenuated, and we have opened up the lateral side, then probably we have to go for more constraint.
I think we can close it. Thank you so much, Sanjeev.
Thank you very much, sir.
Yeah, the E-Zone really thanks you along with WBA.
Thank you.
Thank you, Dr. Sanjeev. Now we go on to our next presentation, which is Approach to Low Back Pain by Dr. Utpal Bandyopadhyay. So please join us on stage.
Good afternoon, respected chairperson, Honorable Professor Tanmoy Mohanty, my seniors, my dear junior colleagues. My today's talk is basically it is meant for the PGTs and the youngsters who are basically the first liners in any OPD or clinic. How they can see a patient with coming to them with complaining of low back pain, and how they can screen which one is serious and which one is not that much serious. So if we, before entering in the topic, whenever Professor A.K. Pal was delivering his talk on a novel approach of low back pain, he has commented that probably it is the bread and butter of all the orthopedic surgeons. Yes, I agree with him. At least before advancement of the operative technique, its accessibility and availability of the trauma surgery, definitely it was bread and butter for all of us. But the sad part of that it is the most common medical cause of workday loss worldwide. If we think about the developed countries, American Journal of Public Health, in 99, there was a paper and they mentioned that there are work related case lost was more than 100 million work days lost. And in 2000 also in the same journal, they are repeating the same thing, that it is the most common cause. And now the health cost related to low back pain, it is more than $300 million, and wage loss is more than $13 billion. And back to our country, if we think about a report of the global expert group who worked on the Gachiroli, which is probably famous for the political issues which revolves around their poor and marginal socio-political situation, where average they earn average daily, they are per capita daily they earn 100 rupees, and average they lost 11 days per year for low back pain related issues, and they spend more than 1,300 rupees per year for these issues, and total economic loss is more than 3,000 per year. So if it is mostly mechanical back pain and it is acute, if it is less than 6 weeks, which frequently resolves and recurs, but only we need to aware of the red flags. We all know age is below 20, above 50, recent history of trauma, if there is malignant tumor, use of corticosteroid, if there is associated deformity, thoracic pain, drug abuse and immunosuppression, unexplained weight loss, Koda-Equina syndrome, fever, and constantly progressive non-mechanical pain. And most importantly, the patient will repeatedly say that I am unwell. That is very much important. And if it is chronic, if it persists for more than 3 months, here evaluation is complex. And here malingering, this is the issue. If you go through any textbook of the book on the clinical examination of spine, 3 or 4 tests of malingering is mentioned there. It is not mentioned for the clinical examination of any other joint or organ system. So here also there are some yellow flags. These patients with the chronic low back pain, usually they live in very low mood, and usually they come with a, they always say that they think that they are suffering for a very harmful diseases, and they always say that Dr. Babu pongu hoye jabo na to, sarche na কিছুতেই কমছে না, এবং হচ্ছে তারা, and they avoid the activities, and most importantly they rely only on passive treatment, and they tend to believe in all sorts of cure all available in markets. So the most common cause is mechanical. It may be neurological, non-mechanical, or referred pain. And to evaluate it, we should not miss every teeth and bits of the clinical examination, the history taking and investigation. All the 6 to 7 points of pain that we should inquire about it. If there is injury, mechanism of injury, functional limitation, if there is associated limb deformity and claudication, radiation, inquire about the systemic diseases, the medication and the treatment. And regarding clinical examination, apart from the inspection from the head to toe, we must not miss any the patches in the trunk, and if they are in tufts of hair over the spine. And during the clinical examination, we must feel the tenderness over the spine, over the SI joint, using all 3 techniques of elicitation of tenderness. We must measure the chest. We must feel if there is any step. If patient is not in very much pain, we should ask them to move, to bend forward. If it is very much painful, it is probably due to disc disease. If the pain is more in extension, it is probably due to facet joint disease or spinal canal disease. Now some special tests, a Scobart test and passive SLR test. We all know these are for ankylosing spondylitis, and passive SLR test to see the neurological involvement. And the detailed neurological examination, we should never avoid the gait, motor examination, sensory assessment, reflexes, pronus, bowel and bladder examination, and vascular examination. And we must not forget, before concluding our examination, to examine hip joint, knee joint, ankle joint, SI joint, everything. And after finishing the examination, if required, we should think about the investigation, which may be hematological, biochemical, or radiological. The most common, one of the more common cause of the back pain, that is the vertebral compression fracture. In elderly, maybe there is no definite history of trauma, or maybe associated with history of trauma with neurological symptoms. The typical osteoporotic spine, ballooning of the disc. Here it is also osteoporotic spine, codfish vertebra. And probably you all agree with me, in recent years, the cancer is on the rise. Many patients who are having pain in the back and it is progressively worsening, not relieved by common medication, we should always screen about multiple myeloma and secondaries. And of course, osteoporosis screening, that is also important part for women over 65 years, men over 75 years, recent history of bone break after 50, women of menopausal age with risk factor, post-menopausal women more than 65 with risk factor, or men of between 50 to 69 with risk factor. We should think about osteoporosis screening. And we can think about screening by quantitative CT scan, by SPECT, by DEXA scan. So this is a common condition. Lumbar spondylosis usually more than 40 years. Pain on extension and rotation. Neurological examination usually normal. Commonly occurs via stress, by minor trauma, like things like this. Spondylolisthesis usually more than 40 in women. The patient with back pain maybe back pain. Sometimes back pain is more than leg pain. Sometimes leg pain is more than back pain. And neurological examination, disc herniation, typical pain on bending forward. And the Kodai-Kuna syndrome, we must not forget this is an urgent condition. Lumbar canal stenosis, pain on extension and while coming down. Some non-mechanical back pain, infection, tumor, and referred pain from other systems, GI system, renal and aortic aneurysm, fibromyalgia. Patient is typically in low mood with sleep disturbance, psychological issues, female preponderance. And last but not the least, I'll take 1 minute, is malingering. Malingering issue is what we are talking about. We should all aware about these, at least these 3 to 4 tests, Hobart test. This relies on the cross extensor response. The Magnuson test, the patient will show the painful area in different locations if we distract them, and the simple slump and film test. From this, we can get the idea. We should examine where the symptom is disproportionate to the physical examination. We should at least do 1 or 2 tests for malingering. Thank you.
Thank you, sir.
The floor, this session is open for questioning. Any question from the floor? Oh.
So, any PGT here? Any training in the back? Is there anybody training in the back? All are training. No, I just wanted, because he's given some very good messages. I just wanted to, if it has actually gone into their heads or not. But so can you stand up and say, okay, just name the red flags which he mentioned?
Come forward.
Just mention the red
Come
flags.
forward. Come forward. Come to the mic. Come to the mic.
Sir. Yes, sir. More than 45 years old and fracture, acute pain. Around more factors are forget, sir. Then around 12 points was there, sir.
Mention lots of points.
Yes, sir.
The red flags. I think one should know that.
Sure, sir.
So your job is to go back and read those.
Of all the causes of back pain, the disc is the major component, degenerative disc, that is cause of the chunk of the back pain, main chunk of the back pain. And it is a most prevalent cause of disability worldwide. So what I want to emphasize is sometimes we miss the relation of pain with time, age, and sex. That is very important. His presentation was very good, but one thing I like to add in this presentation, that in female patients, we also consider the gynecological problems, that a fibroid in the uterus or some menorrhagic problems, some Trojan pelvis and all inflammatory diseases. All these things are very important to rule out the things. And we'll have to, most important part of our examination is to find out the pain generators. That is the thing. Thank you. Comment? Yeah. So thank you very much.
Thank you.
Thank you, sir, for covering this very important topic of the universal issue of low back pain. So next, I would like to call upon stage Dr. Sabyasachi Shatra for his talk on uncemented THR in ankylosing spondylitis, his experience.
Good afternoon, everybody. My topic is on uncemented THR in ankylosing spondylitis. What is my experience? So, ankylosing spondylitis is a perennial inflammatory condition with a momentous involvement of the hip joints, also affecting the spine and the sacroiliac joints. It's affecting mainly males are more commonly affected between 15 to 25 years of age. The DMRDs are usually used to decelerate, but not to treat the patient. THR is advised to alleviate the pain and to improve function in case of ankylosis of the hip joint. Uncertainty prevails between the perfect implant and the approach for the procedure in cases of THR. The methodology, it's a study which was done at the College of Medicine and Sagar Datta Hospital. It's a prospective study between June 2007 to November 2021. The study population is usually clinically and radiologically proven ankylosing spondylitis patients, and the scaling systems are used, usually Harris hip score, VAS score, and the range of motion of the hip joint. The inclusion criteria is negligible where there is negligible range of motion of the hip joint, and in cases of intolerable pain. The exclusion criteria: non-functioning abductors, prior surgeries to hips, compressive myelopathy or radiculopathy, bedridden for prolonged duration, and in cases of infections. The management protocols: preoperative management is to done X-ray of the pelvis with both hips and the spine, the whole spine, AP and lateral view. Blood evaluation should be done, routine examination, and ESR and the CRP. The range of motion, VAS, and the Harris hip score charting is done after the operation. Deformity calculation is done, commonly flexion, adduction, and rotational deformities. Usually external rotation is more. Assessing pelvic obliquity or malrotation, hypertrophic spine conditions. Before doing the THR, the thorough templating should be done. In intraoperative procedure, we usually do the surgeries through posterior approach. There should be, in cases of femoral neck resection, the line should be identified, the inferior neck. The femoral neck cut was done, usually a wedge shape bone is resected out. Articular capsule and osteophyte excision should be done. Femoral head is taken out with piecemeal with the reamers. Usually small to large reamers gradually increase in size. Intra-op X-ray may be required in some cases to identify the acetabulum. Incomplete gray ossifying cartilage and foveal soft tissue as a landmark in advanced cases to detect the depth of the acetabulum, the medial wall. Tag capsule closure to restrict extension and external rotation. Due to the obliquity of the hip joint, in cases of contralateral hip, if it is in abducted position, the pelvis is in cephalad position, the usual inclination of 40-degree reference to the ground level creates less inclination. If the contralateral limb is fixed in the adducted position, the opposite can happen. For lordotic spine, more anteversion with normal inclination, and for kyphotic spine, less anteversion and horizontal cup is needed. To identify the acetabular version. The transverse acetabular ligament may be used as a guide, and lesser trochanter a guide to for the appropriate appropriate anteversion of the femoral prosthesis or femoral stem. In postoperatively, indomethacin may be given to prevent the heterotopic ossification. Drain removal done, and post-op X-ray is usually done. Weight bearing is usually allowed after 1 week. Post-operative complications may occur like dislocation, periprosthetic fracture, aseptic loosening, wound complications, prosthetic joint infections, venous thromboembolism, sciatic nerve palsy, heterotopic ossifications, vascular injuries. But in our cases, heterotopic ossification is never seen, and one case of dislocation is seen. Outcome is assessed by Harris Hip score, VAS score, and the range of motion. The overall outcome is excellent. Mean follow-up is about 24 months, mobilized independently unaided. The mean age is usually 33.7 years. So this is a case showing the total ankylosis of the hip joint, uncemented. This is a 42 years old male patient. See the total ankylosis of both hip joints. So these are the post-operative X-rays at 6 months, 18 months, and at about 5 years. And this is the functional outcome. Here the Harris Hip score is more than 90. There is no pain, no limb. Walk without support, sit comfortably for more than 1 hour, walk unlimited, stairs without railing, with railing, no deformity. This is the post-operative video. See, the walking is totally painless. This is a second case. This is a type is chondrolytic type in this case. Both hip joints are involved, and on left side there was a fracture of the neck femur. See the spine, squaring of the vertebra seen, and in MRI the Anderson lesions are seen, like the infections of the disc space. This is the post-operative X-ray at 6 months and at 4 years. And this is the post-operative video. Walking effortlessly without any pain. And this is another case showing both hip joints involved. This is the post-operative X-ray at 6 months and at 5 years. Harris Hip score is more than 90. See patient sitting comfortably. And this is the post-operative video. See patient walked without pain and very much easily. So take home message, posterior uncemented is the key. Cemented option to be kept always. Thorough physical examination should be done before surgery. Pre-operative templating should be done. Thorough lavage and post-op indomethacin should be advised in all cases to prevent the heterotopic ossification. Early mobilization should be done and long follow-up needed. Thank you.
Thank you, Sabyasachi. It was wonderful.
Thank you, sir.
So, Dr. Chandan to ask one question, and I think that should be it. No question?
Thank you, sir.
What is your post-operative protocol of giving indomethacin? What is the dose?
It's given 25 milligram twice daily for about 3 weeks.
Okay.
Thank you, sir.
Thank you so much, Sabyasachi.
Thank you, sir, for that excellent case series demonstration. Before moving on to the next session, we have one last presentation left. This has been a recent addition. So the topic for the discussion is surgical management and outcome of quad equina syndrome with delayed presentation. And Dr. Guru Amrit from Orissa will be making the presentation. He is an assistant professor at SCB College, Medical College in Cuttack. So can we please have him have the online feed? Yeah.
He's on. So Dr. Guru, you can start.
Sir, your mic is muted. Please unmute yourself.
Yeah, am I audible now? Hello.
Yes, sir, you are audible. Please continue.
Okay. So today, first I would like to thank the West Bengal Orthopedic Association for giving me this opportunity to present my paper. So basically, my paper is about the surgical management outcome of quad equina syndrome with delayed presentation. So we are going to touch a few topics like introduction, the definition, clinical presentation, what is the traditional management plan, and what not exactly in our cases. So this is not a new thing. Everyone knows that the spinal cord ends near the lower border of the first lumbar vertebra, and so the length of the successor roots rapidly increases. So when the rest of these nerve roots of the lumbar sacral coxal nerves from the caudal part of the cord takes more or less a vertical course and bunch of nerve fibers are formed. That is called as the quad equina. So what is a quad equina? It's a complex of symptoms and signs consisting of low back pain, unilateral bilateral sciatica, like pain, motor weakness of the lower extremity, sensory disturbance of the saddle area, and loss of visceral function, that is bowel bladder function and sexual dysfunction. The quad equina syndrome can occur secondary to any condition, which results in the narrowing of the spinal canal and leads to compression of the quad equina nerve fibers, like in case of lumbar disc herniation, lumbar canal stenosis, lumbar spine fracture, tumors, infection, spondylolisthesis. Out of all those, the lumbar disc herniation is the most common cause of quad equina syndrome, and it accounts for 43% of all cases of the quad equina syndrome. So basically, the quad equina syndrome is divided into two parts, whether it's an incomplete type of quad equina syndrome or a quad equina syndrome with retention, or a complete type of quad equina syndrome. A patient who has a urinary difficulties of neurogenic origin, including altered urinary sensation, loss of desire to void, poor urinary stream, and the need to strain in order to micturate, falls in the category of incomplete quad equina syndrome. While a patient who is having a painless retention and overflow incontinence, where the bladder is no longer under executive control, falls under the category of quad equina syndrome with retention. So both of these conditions actually have a prognostic significance. We'll come to that later. So whenever a patient presents with the quad equina syndrome, the traditional definition that says that conjunctive management out of question, already the patient bladder ball is involved and sexual function is involved. So we have the left with the option of operative fixation, whether it may be laminectomy, decompression, either without fixation, depending upon what is the cause behind the condition. So when I went to the literature, I found many of the there are many topics, many surgeons with different opinions. Few of them are the opinion that we have the early decompression. Few papers that support there is no definite result between the early decompression and late decompression. The controversy arises from something called the decisionary time of the nerve loop that was initially defined as 12 hours, but later on therefore it is 6 hours also in some cases. But all of the papers, they have one thing in common, that early decompression in case of a quad equina syndrome, there is an incomplete quad equina syndrome, is a better result if as compared to one that has a quad equina syndrome with retention. So this is a paper that I write. This is a meta-analysis of surgical outcomes. A paper by UD Michael Hahn. So they basically quad equina syndrome secondary to lumbar disc herniation. They have analyzed the 322 patients. They found out the preoperative chronic back pain, which was associated with the poor outcomes in the dental function. Increasing age was also associated with the poorer post-operative sexual function. No significant improvement in surgical outcome was identified with interventions less than 24 hours from the onset of quad equina syndrome compared with patients treated within 24 to 48 hours. Similarly, no difference in outcome occurred in patients treated more than 48 hours after the onset of symptom. So the significant differences, however, were found in resolution of sensory motor deficits as well as urinary and rectal function patient treated within 48 hours compared with those treated more than 48 hours after onset of symptoms. So they came to a conclusion after all the meta-analysis that if you treat the patient within 48 hours of onset, they have a better result. So basically, I'm going to present 4 cases that we found. Normally, co-diagnosis is emergency. Most of the centers they manage it in the emergency basis, but because of the in our setup, because of the delay when the patient comes from the gets referred from periphery center, comes to the central issue where that he will be treated. So the delay happens in that region. So first case was 36-year-old male patient. He had the interval between surgery was around 3 weeks. At the time of admission, he has a power of loss of G1, L4-5-S4 dermatome, loss of sensation as well. We operate the patient with decompression. At the time of discharge, patient had regained his motor power as well as sensation become normal. The bowel movements were voluntary, but the patient was catheterized on discharge. After 6 months of follow-up, we found out that the patient has complete recovery and the patient bladder bowel function has become normalized. The second case was a 50-year-old male patient present with a post-traumatic spondylolisthesis, and we operated the patient of the 6 weeks duration. The patient initially at that time of admission has a 0 power at the time of admission. That got improved partially of 3 power in L2-3-4 dermatome and 4-5-S1 dermatome. And at the end of 6 months of follow-up, patient has completely recovered except for there is some 1 grade of weakness in the L5-S1 dermatome, bowel bladder function normalized. The third patient was operated after 4 weeks of duration. At the time of admission, there is a 0 power motor power, sensation was intact, bladder was catheterized due to tension, and bowel function the patient was having involuntary bowel movements. Similarly, he got improvement at the time of patient has complete recovery of the condition. The fourth patient that we operated, he was almost present for the 2 months of onset. At the time of admission, patient has a partial loss of motor power and sensation was normal, but bladder was complete. At the end of follow-up, also patient has not recovered his bladder and bowel function, and his motor power is recovered partially. So this is case 1. So basically, you can see there is a L4-5 PIVD was there, and this patient was operated 3 weeks of duration. We went for a decompression. So in case of quadriplegia, they say we have to decompress, we have to remove the lamina completely because further compression while doing a laminotomy movement may cause further worsening of the condition. So treated by laminectomy. This was the second case where the patient have a L3-4 traumatic spondylolisthesis. So the patient was managed with fixation and fusion was done at the site of fixation. The third case is a history of fall while working, and patient was having a L3 compression fracture with cord compression. The operator stabilized, and decompression was done. This was the last case. This presented very late, about 2 months after the onset of the symptoms, and patient was underwent surgery with appropriate decompression and fixation. There was no instability, but because the age of the patient was 59 years, that's why we planned for a fixation along with the decompression of the cases. So from all of these cases, so what we learned from this is the timing for surgery for quadriplegia is a controversial thing. And we have to differentiate between a complete and incomplete type of quadriplegia syndrome. And incomplete quadriplegia is a better result if treated earlier. And complete quadriplegia syndrome has a poorer prognosis. Thank you.
Thank you, Dr. Amit, for your presentation. Any questions? Any questions from the floor? Okay, thank you for your nice presentation. So thank you for your presentation, Dr. Guru Amrit. With this, I would like to conclude this session on East Zone of Indian Orthopedic Association. I would like to thank the chairpersons. So you can please take your seat in the audience. Dr. Rakesh, Dr. Dinesh, and Dr. Presenters, please come over the dais for a photograph. We can have a group photograph. Dr. Shatra.
Rakesh da, you can hear me? If you ask the IT people to
Now we shall move on to the next session, which is the basic science session. To chair this session, I would like to call upon stage Dr. Dilip Mujumdar. Sir, can you please have you on stage as our one-man chairperson army? Please join us on stage. Without wasting any time, let me just call upon the first presenter, Dr. Haripada Giri. He'll be speaking on in designing a load bypasser knee orthosis. Sir, please join us on stage.
So we invite Dr. H.P. Giri for his designing a load bearing orthosis.
First slide.
Dr. Giri.
Yes.
Because we are going short on time, so please 8 plus 2.
8 plus 2.
Okay.
Okay.
Thank you.
First slide. First slide.
So, apna dikhe jaise. आपने बोला था
Okay. This is my paper in designing a load bypasser knee orthosis. Me, Dr. H.P. Giri, and my professor was S.K. Rai Chaudhary, PhD, Department of Mechanical Engineering, IIT. Okay, next. 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 This is the problem of osteoarthritis knee, varus knee, and deformed joint, knee joint. Next. These problems of the disease, that is chronicity. So YLD, year of living with disability, is about 20 to 30 years. Prevalence 10% of global population, 60 years of age. Additive fracture every year, 20 lakhs, and people are yearly added at 20 millions. State burden 0.5 GDP, in USA 1% GDP. Next, this is the cumulative expenditure, huge recurring expenditure. For conservative, estimated about 20,000 per year over 30 years. Semi-conservative, conservative surgery about 1 lakh, TK 3 to 6 lakh, revision TKI, and then again conservative. Next. And out of many factors, body weight is the key factor here. We advise reduce weight. It is easy to say about for us, but for the patient, it hurts us to comply. Now, if we can find out some way to relieve weight, at least partially. Next.
This is the weight bearing from quadrupeds to bipeds. Next. These are the braces about knee, which are soft, unicondylar. Next. This is our design. This is probably for coupling thigh and leg socket. Aluminum sidebar. Okay. Each. Sorry. That's it. And this is the hinge part of the knee. Strain gauge in the thigh socket, strain gauge in the leg sidebar, in between potentiometer. In between potentiometer. This is simplest way of it. Okay. This has already described molded thigh socket and molded leg socket attached by side aluminum bar and connected by gauge, data analysis and data collected in real time. Next. Yes. Strength analysis of the model by 3D modeling and SIS. Next. This is the stress collection in this X, Y, Z. This red part suggests that there is obviously there is stress and it's transmitted to the breast. Next. This is the fitted thigh socket, leg socket, and connected with a electronic device with resistance. It is in turn connected with laptop. Next. During different stage of walking, the data are collected. This is heel strike. Next. This is mid stance, toe off, electric circuit, and this is the computer for analysis. Next. Experiment with breast fitted. Tests were conducted on 3 normal volunteers of age 25 to 30 years and average weight 60 kg. The base was fitted snugly around the knee. Initial data of load sharing was noted from stance position. Then dynamic data in different reflection angles was recorded. Next. Yes, this is the force analysis about every knee joint, even in the osteoarthritic knee joint. FQ, that is force of quadrature is equal to, this is the formula we derive from, and F beer we derive from this formula. Next. And this is the obvious sign. This black part is the total force passing to the end. This is the pink one, breast force. Next. This is the data analysis. This is heel strike, and this is mid stance and toe off. At almost 1 degree flexion, it is started, and 12 degree flexion, the toe off started. Next. It is obvious. Next. Yes. From this plot, it is
obvious that in every stage of walking, there is some amount of weight bearing. Maximum weight bearing was 25 kg, that is 42% of the body weight shared during hill style. Load is shared at a constant level of 11 kg, that is 18% during flexion of 3 to 9 degree. 3 to 9 degree. Yes. Next. Yes. With toe up, that is 10 to 12 degree load sharing is 0. Oh, sorry. Next. Conclusion. One orthosis is designed to share load from 18 to 42%. It is a custom-made partial load sharer and stabilizer also. It can safely be used for painful knee requiring load bypass or stability like OA, IDK, postoperatively for AC or PCL repair, TK, etc. The cheap clinical trials still in progress. Thank you.
Thank you, Dr. Giri. It is a marvelous thing that you are working on in Kharagpur, IIT Kharagpur. So in future, we'll see that there will be new horizon in conservative treatment of the osteoarthritis, type 1, type 2.
Yes.
Okay. So 2 questions, because you are going short of time. Any 2 questions from the floor, please. Any question, Jaswal? Osteoarthritis of the knee. Tanmay?
Just compare it with the unloader which is available in the market. I'll suggest you, unloaders are available in the market. Now they claim that it is giving good result. I think this is a test which has not been shown by them. So you can take one from the market and compare.
Yes.
Maybe if you prove that this is better, obviously things will be better.
That is, I am doing as custom made in my clinic just now. In course of time, if I find one manufacturer, then it will be.
No, from the market you can take this unloader. Right now also in the exhibition they were showing one company was showing unloaders.
Unloaders, one thing, those unloaders are soft bucket, but this is firm bucket. Weightlifting is more better here.
Another thing, recently we have got a TBI in KIMS, Technology Business Incubation. And one doctor, they have one engineer and one physiotherapist, they have come out with a press like this, where they are giving short wave along with that. And they have already used it on more than 3,000 patients and now trying to go into the market. So this is a thing.
Okay, thank you. Thank you, Dr. Manti. It is taken up. So, Dr. Giri, please accept this token of appreciation in a form of a paper, certificate. Please come.
Thank you, Dr. Giri. Now let me call upon our respected Dr. Debajyoti Bose.
So thank you, Dr. Giri. Nice presentation. We'll see it come out very soon. We'll give this. Yeah. So next is our Debajyoti Bose. 8+2.
Respected Chairperson, it is a proud privilege for me to address this August gathering. Now I am going to for an overview of recent osteoarthritis guideline. Need for a new intra-articular glucosteroids. You all know that we are doing lots of research on osteoarthritis by avoiding surgery. So the need for a new intra-articular glucosteroid. Need for intra-glucosteroid is rapid pain relief, IA steroid with increased mean resistance time and long-term 24-week sustained response. Previously, we also used to give this intra-articular steroid, but that was not lasting. But this intra-articular steroid, it lasts about for 24 to 26 weeks. So you can buy some time for replacement. triamcinolone hexacetonide pharmacology. This is the newer drug. This is pharmacodynamics, triamcinolone hexacetonide, synthetic glucose corticoid with pronounced anti-inflammatory activity, almost insoluble in water, and therefore dissolution, dispersion in the tissues at the injection site is generally slow, taking a few weeks to several months. Anti-inflammatory potency approximately 5 times that of hydrocortisone. Triamcinolone has practically no mineralocorticoid effect, therefore no sodium retention occurs, relatively safe in cardiovascular and renal patients. And most of the patients of osteoarthritis either suffer from cardiovascular or renal patients. So we used to avoid intra-articular steroids in this group of patients. The clinical evidence with triamcinolone, intra-articular triamcinolone hexacetonide versus placebo in osteoarthritis, the lying data proves that intra-articular triamcinolone helps a lot than placebo. Clinical evidence supporting rapid pain reduction with triamcinolone hexacetonide. This outcome, triamcinolone, because many people use methylprednisolone. So outcome from triamcinolone hexacetonide versus prednisolone versus methylprednisolone, and this it shows that this newer drug triamcinolone hexacetonide is much superior than prednisolone and methylprednisolone. So now this is a newer drug. If you give it intra-articular steroid, you can buy some time for doing some surgery. This is the comparison with the triamcinolone hexacetonide versus prednisolone versus methylprednisolone, and duration action is intermediate methylprednisolone. Triamcinolone acetonide is long and triamcinolone hexacetonide more long. That is more than, if you do only triamcinolone, it will be 1 month, and this is about 4 months. You can, so less dose of injection is necessary, and that will prevent the sepsis also in the artery. And so THA has a better intra-articular duration of action as compared to methylprednisolone and triamcinolone. Clinical evidence supporting long-term and sustainable response with triamcinolone over 24 weeks. Dosing of intra-articular triamcinolone acid for knee synovitis in chronic polyarthritis, a randomized control study. The aim of this study was to compare the outcome between 2 common doses of intra-articular THA for rheumatoid arthritis or psoriatic arthritis with active knee synovitis using the relapse rate for 6 months. So one group we have given THA 20 milligram intra-articular 40 and THA 20 milligram IA. So endpoint, time to relapse of the arthritis affected. Adult patients with rheumatoid arthritis, that was the number, and this single injection, and above more injections are required. Dosing of intra-articular triamcinolone for knee synovitis chronic polyarthritis, a randomized controlled study. The proportion of relapse after 6 months was equal in the 20 milligram and 40 milligram of triamcinolone treatment. Aims 30% versus 32%, and no significant differences were found in the subgroups of rheumatoid arthritis and psoriatic arthritis patients. So in summary, triamcinolone hexacetonide, the essentiality and the desirability, THA is comparable in efficacy to currently available intra-articular corticosteroids. It scores over others in the following parameters. THA absorbs slower than the currently available other intra-articular steroids, thus creating lower systemic corticoid levels. THA least suppresses HPA axis as compared to MP and prednisolone, therefore offering more safety. THA has better intra-articular duration of action as compared to methylprednisolone and triamcinolone acetonide. THA is less soluble than MP, methylprednisolone and triamcinolone with within the synovial joint, thus increasing the mean duration of time within the synovial joint. Thank you very much for your patience here.
Thank you, Dr. Information that you are giving. So, two things that come to the mind. One is what do you do in the diabetic mellitus cases when there is type 2 osteoarthritis?
Yes, you can give because single dose, it will not increase much of the diabetes. But if it's say, if you have a 300 milligram PP, so you control diabetes and give it.
Any one adjuvant therapy that you do in arthroscopic lavage in type 2 osteoarthritis?
That's a different scenario. If you want to do it, you can do it always along with this.
Thank you. Any
Yes.
question from the floor?
Without this newer molecule has got better inflammatory and controlling the duration of the pain. But they have never mentioned anywhere in their literature about the subchondral bone loss. Is there any comparative study with the prior molecules of the drug that has been intraarticular with this molecule?
Yes. The subchondral bone loss in steroid was a big problem. But in this study, because it's a slow acting, so as per my knowledge goes, it is just buying the time. We don't recommend normally, but you can do it, but very less subchondral bone loss occurs due to this steroid. Yes, no doubt. It was not very much studied. In selected patients, you can go where grade 1, grade 2, even grade 3 you can give who doesn't want to do surgery, and along with that load sharing brace. So that is simple. In synovitis, pain is not relieving. In that case, you can go for this.
So thank you, Dr. Bose.
Thank you
If there
very
is no question, then we will pass on to this third speaker.
Debojyoti Bose, sir. Now I would like to call upon stage Dr. Arindam Basu. He'll be delivering the last presentation for today, comprehensive management of painful knee osteoarthritis. No.
Is it the similar online?
My topic is the last topic, that is comprehensive management of painful osteoarthritis. Mostly I will tell about the newer medical agents. Now, clinical presentation of osteoarthritis, it is mostly dominated by pain during joint use, and also there is rest pain. So causes of osteoarthritis pain, there is aberrant functioning of pathologically altered nervous system, and altered nervous system is the key mechanistic driver from peripheral nerves and central pain pathways. Now, osteoarthritis is a disease of whole joint, and it not only involves the articular cartilage, but also involves the subchondral bone, ligament, capsule, synovial membrane, and also the periarticular muscles. And additionally, there is active dynamic alteration. There is imbalance between the repair and destruction of the joint tissues. Now, the major elements of painful osteoarthritis are mostly three. There is degeneration of the joint, there is inflammation, and there is neuropathy. And it is seen in osteoarthritis, there is angiogenesis, and angiogenesis and inflammation are closely associated in osteoarthritis. Angiogenesis modulates the function of chondrocyte, also causes abnormal tissue growth. There is perfusion, extra ossification, endochondral bone development, and there is also a radiological changes in the joint. And it happens across all the component of the joint. Mostly there is trauma, injury, mechanical stress, and aging. It leads to uneven pressure and compression. It ultimately leads to local hypoxia. Local hypoxia promotes release of vascular endothelial growth factor and nerve growth factor. And there is neovascularization and also neoinnervation. And ultimately there is neurosensitization. The pain in osteoarthritis is absolutely multifactorial. There is, as I earlier also told, there is inflammatory pain. Also there is neuropathic pain and degenerative pain.
Now, inflammation occurring across all the joint structures. Neuropathic pain, there is neurosensitization and new nerve formation. And in degenerative pain, there is damage and occurring across the different joint compartments. Now, the comprehensive management of painful osteoarthritis, mostly I will tell the newer medical drugs which are coming in the market, though it is completely hypothetical and cannot act on grade 4 or late grade 3 osteoarthritis. The components which are there in undenatured collagen type 2, there is andrographis paniculata, there is sodium hyaluronate, vitamin K2 to K27 and vitamin C. And each have different role. Undenatured collagen type 2 regenerates subchondral bone. Andrographis paniculata promote chondrocyte growth. Sodium hyaluronate delays disease progression. Vitamin K2 increases bone formation, also transfer calcium from blood to bone. And vitamin C supports collagen formation. It also acts against inflammatory pain, mostly by reducing COX-2, interleukin 6, TNF alpha. These are mainly pro-inflammatory markers. And it is seen that theoretically, andrographis paniculata, also sodium hyaluronate, undenatured collagen type 2, vitamin D3, these reduces the inflammatory cytokines. So it reduces inflammatory pain. And also neuropathic pain by the same, almost same mechanism, by inhibit interleukin 1, also NFKB, substance P, decreases the substance P, and improves the nerve growth also by vitamin D3. Now, it is recommended in, these drugs are recommended in painful osteoarthritis, also neuropathic arthropathy, synovial arthritis, rheumatoid arthritis, and trauma and joint injury we can give, and pre-total joint arthroplasty preparation and post-total joint arthroplasty rehabilitation. Now, undenatured collagen type 2, this is a recent advance and numerous drugs are there. It also helps maintenance of bone collagen matrix, stimulate type 2 collagen production, and improves the subchondral bone collagen. And also in neuropathic pain, it is seen vitamin K27. This acts by reducing the recurrence of neuropathic symptom. And also vitamin D3 acts by almost the same mechanism by reducing the inflammatory cytokine and also inhibit the nitric oxide and reduces development of central sensitization. Thank you.
So thank you, Devajyoti, for your nice information. And with Devajyoti, actually, I thank all the golden speakers for this session. And as we are running behind 1.5 hours, we will close it and go for the other functions. Thank you. Thank you, the organization.
Thank you so much. Thank you so much. So with that, we conclude the scientific session. Now I would like to call upon stage Dr. Gigi Kaur, organizing chairman, organizing secretary of WBOACON, Dr. Devajyoti Bose, organizing chairman for WBOACON. I would also like to call upon Dr. Rajiv Raman and Dr. Chandan Pathak for the valedictory session.
So thank you everyone and Malda Orthopedic Club for excellent WBOACON 2023. So we'll make it very short, and in valedictory session normally we announce the result of the competitive paper session. For Siliguri Best Paper Award, the first Dr. Parvez Samin has stood first, Dr. Swastik Bhattacharya second, Dr. Parkavian R third, and Dr. Aniruddha Bhattacharya fourth. So the Dr. Parvez Samin will receive the Siliguri Gold Medal in 2024 WBOACON inaugural ceremony, and the rest three with Dr. Parvez Samin will go for the traveling fellowship to Odisha and UP respectively. The Biswajit Sen Best Paper Award, Professor A.K. Pal sir has won the Best Paper Award for Biswajit Sen. The first runner-up is Dr. Subhadeep Mandal and second runner-up is Dr. Arnav Karmakar. Best Poster Award, and thanks to Dilip Majumdar sir for conducting that session. Dr. Anubhav Goswami has won. Or any one of you is there? Anubhav? So first runner-up is Dr. Kuntal Mukherjee and second runner-up Dr. Saikat Sarkar. Yes. So now I would like to invite our president, sir, to say a few words, followed by organizing secretary.
So, a fantastic WBOACON 2023 has come to an end, and there's nothing to enumerate any further. It has been a very well organized WBOACON, and I hardly find any fault, and there's hardly to complain anything, and maybe some points which are human, and that will happen to even to possibly a computer organized program also. So big thanks to the organizing team, Malda Orthopedic Club, especially Dr. Debojyoti Bose and Dr. Gigi Kaur and whole Malda Orthopedic Club. And special thanks to the scientific committee of West Bengal Orthopedic Association, and to put up fantastic academic events. And I think we'll continue with that. Thank you.
Thank you, Chandan, for your encouraging words. It's the pleasure after 3 days of academic extravaganza and the fun, it's time to bid adieu with heavy hearts. But the light at the end of the tunnel is that we will have other WBOACONs, and shortly we'll have ICL also. So it's my pleasure to thank everybody, but I cannot name everybody, obviously, because of the shortness of time and my throat is almost choked. So let me start with thanking WBOA for entrusting us to hold this conference. In spite of Corona, after 2 years, we were again interested to hold this conference. So my heartfelt thanks to WBOA and obviously WBOA Executive Committee who came over here as AOTS program to reconnaissance this venue, and they suffered air conditioning failure. In the room, it was very difficult to stay, but they entrusted us on the promise from the BM grant that by the time this conference will happen, ACs will be repaired. And in any case, February is not a very hot area in this part of the country. And then my thanks goes to the professional conference organizer, Rueda, and especially their graphics team. Graphics team works behind the scenes. We see people of Rueda like Devnath, Tania, Anamul, Deepak, but the graphics team who has come up with this grand ambience. And I was mesmerized to see nobody told them to do that. Post big flex about Sibram Chakraborty, who was the son of the soil. That was extremely innovative from their part. WBOA office bearers, Kakoli is here, Moramadi is there. Everybody took their part, and Prasanjit and Gaurendu and Krishnendu were running around, and they were tolerating our whims. Sometimes we changed things in a moment of notice and they complied. I would like to thank, already Chandan has told that the scientific committee has come up with in very short time, such a program that people will not go outside of the halls. Halls were packed. And then I would like to thank faculty from the other states and even other countries. Tanmoyda is here. Professor Dilip Sinha could not stay because of a family problem. Apart from that, Arun and Professor Pachore. Then our academic partners, if we see the name list of the academic partners, it starts with A and finishes with Z. Sorry. Okay, so just a small thing. audiovisual, and Bapi the photographer. Where is the Bapi? Bapi the photographer, who was running around with his DSLR and taking nice pictures of us. And we'll be having those pictures in our website shortly, I think. The internet provider, Norway Hospital. I must say that Norway Hospital did a great job of the live surgery, and they waived all the charges, all the hospital charges for these patients. So basically, apart from the implant, all the surgeries were free. So that is an excellent gesture from their part. BM Grant staff and kitchen, they, I think, improved a lot comparing from this AOTS conference, and overall people's satisfaction were good. So with these few words, I take, sorry. Bola. A to Z. It starts with A and finishes with Z. If you see the list, they are the academic partners of us. With these few words, I take adieu from here. I think over to Darjeeling. Next is Darjeeling, no? Bardhaman Orthopedic Club will conduct, and they are preparing for Darjeeling. So it will be the first time in the history of WBOA that a hill station will have WBOACON, if everything goes well. Thank you. Thank you so much.
First of all, I want to ask all my friends from Malda Orthopedic Club to come to the dais. This is my junior teams who helped me a lot to organize this conference. Along with that, I want to call upon two-person more, Devnath and Kakoli. From there, come here. From there, from morning to night, they helped us. Whenever I called them in odd hours. And last of all, I must call upon Shomodip here. Without him, this conference could not be successful. Without them, I could not hold this conference. Thank you all. My pleasure of showing these people to help me and Dr. Kaur to organize this huge event, along with the WA President and Secretary. I bow my head and appreciate the help Chandan, Rajiv, Shabbir Shachi, and office staffs, along with and the organizing team to help me. Thank you very much for your patience here.
Audio video special thanks to Rajkumar.
Rajkumar. ठीक है जी Hotel, please don't leave your room before 8:30. Please don't leave. At 8:30 to 8:45, you all get down at the reception. The cars are ready for departure. There will be a minibus to Innova, right? We'll depart with that. And all. ওয়ান একটা জিনিস ভুলে গেছি, এই আমাদের রেলের যা হেল্প করেছে চন্দন, বাপ রে বাপ, এটা ভুলে গেছি, ভেরি গুড হেল্প। আমাকে ওইখানটায় পার্কিং ইজ নট অ্যালাউড, পার্কিং অ্যালাউ করিয়েছে, ওইখানে ভিআইপি রুম খুলিয়ে দিয়েছে হিপে ফুররে, and all dinner packets are ready for them who are from the place as well as who are going in coach, right?
Three cheers for WBOA and Malda Orthopedic Club. Hip hip, hip hip, hip hip.